help promote health and even prevent. And of course, too, a lot of things are happening in the country, particularly to ensure that those who have long-term care are not just kept at the specialist centers, but after they've received the proper care, the investigation, diagnosis, and the management and the regimen, they are allowed to go home, and then there is a follow-up at home so that to ensure that they are keeping to their management, and then they come back for checkup as required. So a lot is happening in that direction. Maybe with time we'll also share with you what we're doing, what we're encouraging. But I want to thank you very much for this very nice program, and the quality is top-notch. Thank you very much.
All right, can we give another round of applause, please? Okay, so really quickly before we go to the next session, if you notice there are some QR codes on your table, please feel free to scan and join the WhatsApp group. You will get some of the slides, some information about even some subsequent events and seminars that we host. So please, I can understand that there's been admin issue there. Just request, we'll add you shortly. All right, so we're about to go into our next session for our ALS, but a little icebreaker. Who's ready? Oh yeah, can we be on our feet? Please, let's be on our feet. Come on, come on, come on. This is very brief. As you all know, as well as maybe you, maybe me, but I'm very excited to be here. And this event is more than just all the ones that have come thus far. As you know, we are going to be the inaugural class of the Primary Cardiovascular Society that we're trying to establish. But if you're glad to be here, can I hear a yeah? Okay, so this is what we'll do. I will call and we'll respond. It is important that we are all etched into memory. Some of us that came earlier on saw our faces on the screen. So apply yourself. This is what I'll say. I'll say we are the 9th annual, you reply, Abuja Cardiovascular Symposium. Are we ready? With applause. Okay, so testing round. We are the 9th annual. That's only 13 people. Let's see if we can get everyone here. Are we ready? One more time. Let's do it for real. We're at the 9th annual. All right. Let's be on our seat, please. Now for the next session on stroke, we call on Dr. Osamoyi for the presentation, please.
All right, thank you very much. All right. Good morning, everyone. Please permit me to stand on existing protocol and especially thank the cardio care team for having me on the second time in a row. The GMD says my glasses are on fire. All right, so let's go. Stroke. Okay, no, I can see the screen, but I'm talking about, okay, I should point to the screen. Okay, good, I got it. So, everyone does not need to go abroad for advanced cardiovascular healthcare, that's true. So many more people need to know this. Now, this is the outline I'll be following. It's very easy. What is stroke, why, how to see stroke, and then how we can recognize and evaluate a patient who we think has a stroke, when and how to treat and be fair, and then appropriate care. So what is stroke? It is a clinical syndrome. Now we know what a syndrome is. A syndrome is a constellation of signs and symptoms, 1, 2, 3, and 7 equals XYZ, something like that. So these are the things to note. Number 1, it is sudden, of rapidly developing clinical signs. Very important point of history, because when you look at the differentials of stroke for someone that has an intracerebral space occupying lesion, for example, it usually progressive slowly, as opposed to stroke is sudden. And then even if the patient has a symptom or a sign and it's going to progress, it rapidly progresses. Okay, so that's a fact to always remember. It can be focal or global in the case of coma or disturbance of a cerebral function. All right, and then it lasts for more than 24 hours or leading to death, with no apparent cause other than a vascular origin. Very important. So we have other differentials that present like this but differ a little bit, but for stroke it is vascular in origin. It is typically supported by neuropathological, neuroimaging, and clinical evidence for permanent injury. So this is a hybrid of the old and the new definition of stroke. Now, very important that you recognize that it's not just the signs and symptoms. We need neuroimaging to say that actually, yes, there is a stroke. Fine, there's a clinical stroke is a clinical diagnosis. All right, let's not get that wrong. But when we want to differentiate between ischemic and hemorrhagic, for example, we definitely will be needing neuro imaging for that, and then evidence of permanent injury. Now, let's talk about TIA, transient ischemic stroke. All right. So it's a brief episode of neurological dysfunction or deficit due to focal cerebral or retinal ischemia. This is another concept of stroke and TIA that you must bear in mind, because sometimes the symptom is that the patient may present with is just a transient blood vision that I can't see for a minute or two. All right, but again, when you look at do a neuroimaging, you find that there's an infarct, and that is a stroke. Okay, so sometimes it is just the retina that is involved. It can also be just the spinal cord, and then of course the cerebrum. All right, without any objective evidence of infarction, usually lasting seconds, minutes, with complete recovery. So for TIA, typically that focal neurological deficits last for less than 24 hours. Typically, if it's a true TIA, 30 minutes is gone. All right, but please remember, you have to have focal, there should be no, by the time you do a neuroimaging, particularly an MRI, it will be normal. All right, there are some people that have focal neurological deficit, it disappears, and then you do a CT scan, it is normal, or there's no abnormality. It still cannot tell, we will still not say that patient did not have a TIA up until the person does what? A brain MRI. And if it is clear, then we say yes, this for a fact is a TIA. What are classification of stroke? All right, so there are 3 basic classification of stroke. I know some people used to say know it as either an infarct or a bleed. Now, it is better said as an ischemic stroke, intracerebral hemorrhage, or a subarachnoid hemorrhage, simply because these are distinct entities. Do you understand? And they are managed differently. So you don't want to clump up intracerebral hemorrhage and subarachnoid hemorrhage. They are both bleeds into one, because they present differently, and the way line of management is also different. So it's better to just differentiate them right from the beginning. Of course, you wouldn't fail if you write hemorrhagic and ischemic, but it will be more advanced and better if you say ischemic stroke, hemorrhagic stroke, and then subarachnoid hemorrhage. So this is a broader classification of stroke. What I just want you to pick from this slide is the fact that there are different ways to classify stroke, and one of which is, I think it's better shown here. Okay, let me just go back one bit. is to know that it's a vascular issue, all right? And from the vascular issue, it can either be venous or arterial. We rarely see venous strokes, but for that 1% that may just show up, you need to know that it is possible. And then the most of what we talk about are the arterial stroke, which can be infarct or hemorrhage, which I already spoke about. And this hemorrhage can either be intraparenchymal or subarachnoid hemorrhage. And then we have the ischemic stroke. Now, for the ischemic stroke, there's a sub-classification of ischemic stroke. Why are we doing all this sub-classification? You know, it's very important to profile patients. When you know and understand where the infarct has occurred or the injury has occurred, and then the severity, you know, the location and all of that. In fact, part of the issue is that sometimes due to the location, if someone, for example, has an infarct, a posterior circulatory stroke, and the person does not have apparently no focal neurological deficit, but of course, if you begin to assess the patient's vision, for example, then you now begin to see, oh, actually there's actually a focal neurological deficit. And then when you're now talking to the patient, you know, you have had a stroke, and the person gets angry, I've never had a stroke before, and sorry, the MRI or the brain actually shows that you have had one before. So that's the essence of all of this profiling. So it helps you, you know, profile your patients appropriately and communicate properly, and then remove those terms that where patients say things like partial stroke or a minor stroke. There's no such thing. A stroke is a stroke. Then there's the anterior circulation, which can be sub-classified as total anterior or partial anterior, and then the lacunar stroke, that's where the volume or the part of the brain that is being affected are really tiny bits, all right, and then the posterior circulatory stroke. All right, this was what I was looking for, but let's go. Then epidemiology. Now, epidemiology speaks to the burden of stroke. All right, and the burden of stroke is real. First of all, the cardiovascular diseases are the second most common cause of death, with a vast majority of such deaths occurring in low-income countries. All right, and they are projected to be the second leading cause of death by 2030. You know, before now, 2030 feels like, or looks like it's far away, but we have it right in front of us. It's 5 years. In 2016, the global burden of disease reported that the worldwide prevalence of cardiovascular disease was 79.6 million. WHO places the global incidence of stroke at 200 cases per 100,000. Just think about that. All right, and then up to 80% of these strokes are actually ischemic. All right, and let me add to that, okay, when I get to risk factors. So what are risk factors? Now, there are two major, you know, groups of risk factors. The non-modifiable group, these are the groups that the group of risk factors that you can't really do much about, okay? And they include increasing age, gender, male gender more predisposed to the female gender up until 55 years of age, where the protective influence of estrogen is off, and then race, that's black African descent, for example, more prevalent in that group, and then family history of a stroke and a previous vascular event. So when you're taking a history from a patient who you think has a stroke, it's very important to ask them if they have had a stroke before. They say minor stroke or partial stroke, whatever. You need to get that history. A previous history of myocardial infarction, they may not know that they had myocardial infarction, but they may be able to insinuate, you may be able to insinuate they may have had it if you ask them if they have angina-like chest pain. That's the kind of chest pain, a chest pain that they have with activity. We know that when it progresses, even at rest, they can have chest pain, but just for the generality, you can just ask, do you have a history of chest pain with activity? And then peripheral arterial disease, we saw that in the previous presentation where the person complains of pain in the calf while walking, for example. Then hereditary diseases, sickle cell, hypercoagulable states, and autoimmune diseases. Then to the modifiable risk factors, things that we can do about it, and gladly 80% of the strokes are actually tied to these modifiable risk factors. So that means, that speaks to the fact that strokes can actually be prevented. So we look at the three trial that we described already: hypertension, diabetes, hyperlipidemia, cigarette smoking, added to the fact that cigarette smoking predisposes the individual to hypertension. It causes chronic inflammation, in fact, is linked to stroke. All right, and it causes a lot of endothelial injury as well. Then excessive alcohol intake. We know now that there's no safe limit for alcohol, so just even forget that little amount that we used to know before. There's no safe limit actually. Then next, physical inactivity is a risk factor. Heart diseases like atrial fibrillation and the rest. So I'm going to stop here for want of time, but I've mentioned the major ones. Now, how do patients with stroke prevent? Now, this is the big one. It is either sudden in onset or stepwise progression of symptoms and signs over a few minutes and sometimes even days, because you find that someone just couldn't walk or just had slight one-sided weakness of facial, or only facial weakness on the first day, and they were managing at home. But by the next day, the person now couldn't move. That's when they now show up in the hospital. So sometimes it can be stepwise over days. Then there are focal signs. The focal signs relate to the distribution of the affected area, but collateral supplies may cause variation in presentation. All right, I'm going to skip this for want of time, but this just speaks to the subclassification of stroke depending on the areas of circulation. That's the anterior circulation, posterior circulation, and all of that. Now, when the anterior cerebral artery is affected, these are some of the symptoms that the patient may present with. So, disinhibition and speech preservation, all right? Speech impairments, sorry, that should have been. Then the patient may have primitive reflexes. Now, primitive reflexes, if you have ever carried it, most of us must have carried a baby before. If you put your hand in a patient's, in the baby's hand, and then the baby just grasps it, and then you carry a baby, and the baby just tends to suckle at the mother's breast. Those are just natural reflexes. Now, you now find out that in patients who have had a stroke, anterior circulatory, these primitive reflexes now begin to play out. All right, then they can have impaired judgment, collateral weakness, that's one-sided body weakness of the hands or the legs or the face. Then contralateral cortical sensory deficits. This is very important. So sometimes it's not just weakness or speech. Sometimes it is just abnormal sensation on one side. So it's not always a peripheral neuropathy or cervical degenerative diseases of the spine. That could be the case, but sometimes it's actually a stroke. All right, very important. That is, let me say it clearly, or let me repeat it. That means one-sided abnormal sensation on one side of the body. That's the hand and the leg, for example. All they are feeling is hotness or pins and needles on one side, and it could be a stroke. Gait apraxia, inability to walk, and urinary incontinence. Then middle cerebral artery, all right. In this area of supply, they can also have contralateral hemiparesis, that's one-sided weakness, contralateral hyperthesia, that's abnormal sensation, and ipsilateral hemianopsia. That means that when you are assessing, when you're asking the patient, to move, one side of the body, and the person does not is not able to move that, does not know that he or she should move that side of the body, okay? Then gaze preference towards the side of the lesion, agnosia, repetitive. Okay, so the patient may also have language deficits. Let me try and make it simple. All right, so we have generally, there are different types of aphasia. So there's the receptive aphasia, and then there's that receptive aphasia where the patient is unable to understand what it is that you're saying. So if you say, how are you today? And the person saying, just begins to say jargons, that's because the person doesn't quite understand what it is that you're saying. So reception is a problem. Then expressive aphasia, where the patient he or she cannot express himself. So you find out that the person, and that's the one that can be very troubling and is associated with depression, because the person understands you perfectly, understands what's going on, but cannot really say what it is he or she wants to say. Then there's neglect, inattention, and extinction of double simultaneous stimulation, and some non-dominant hemisphere lesions. I feel I'm going too far, but when questions arise, I'll take it. Then posterior circulatory cerebral artery stroke. Now, this is also a very important one. Now, the patient, I'll just emphasize on the 4 Ds. The patient may be dizzy, have double vision, that sees to double vision either side by side or one on top of the other, then dysphasia, and then dysarthria. All right, so these are the 4 Ds that the patient can't present with. Then still on the posterior cerebral artery stroke, the 4 Ds are the common ones, but again, vertigo, nystagmus, diplopia, and this phagia, and this arthria, and facial hypothesia, syncopal attack, and ataxia. All right, the features. Now we move on to how hemorrhagic stroke presents. Now, typically, they present with headaches, vomiting, neck stiffness, and then they can have focal weakness or anything that looks like all the other things I've spoken about concerning ischemic stroke. And then, of course, altered sensorium. Now, that does not mean that when it is ischemic stroke, they do not have headaches or they do not have a focal weakness. I mentioned that already. They can also have altered sensorium. Then, for subarachnoid hemorrhage, is similar to intracerebral bleed, but the headache is thunderclap. The headache is usually, even if the patient had headaches before, like the patient is a known migraine headache patient, for example, the patient will tell you that this is the worst headache he or she has had in his life or her life, and it is very troubling. The headache most often the times is the most predominant symptom. Then the patient may have vomiting, neck stiffness, photophobia, focal weakness, and altered sensorium, and anything similar to the previous presentations that I mentioned for either ischemic or hemorrhagic stroke. Now, how do we manage stroke? So we first have 5 more. Okay. All right. So we will just follow this algorithm, this ABCD. The first thing is to resuscitate the patient, assess for airway. And I do not like to take this airway for granted, because some people just like to just rattle out ABC. And then when it comes to practicality, what exactly are you doing? So A is making sure that the airway is patent. All right, there's nothing obstructing the airway. And if you have issues with that, you can tilt, jaw tilt, okay, and then you can use a suction machine to make sure that the airway is clear. Very important. Ensure that the patient is breathing. How do you know the patient is breathing? You see the chest movement, you feel the air moving, and then you can check the pulse, or use the pulse oximeter to assess that the patient is actually saturating well. And if it's less than 95, you give supplementary oxygen. Next, you check circulation. You ensure that the patient's blood pressure, that's the pulses and blood pressure, are optimal. And then you secure IV access as well. Then D, you check for any disabilities, and this is where you look for, you seek for your focal neurological deficits. So you quickly do a neurological exam and see if there's a facial deviation, there's weakness on one side, or there's a limb weakness on one side. Those are the major things that you can pick quickly, all right? And then if it's very important to pick fever, if there's fever, and because we need to give antipyretics at that point to take care of the fever, because if there's an infarct or a bleed, it can increase, it can cause an increase in the progression of the infarct or the bleed. Then optimal glucose control is very important. So at that time, when you're checking the pulse and all that and securing the line, you draw blood for random blood sugar and take for other samples as well, other investigations as well. Then this assessment is important, but because of time, I'm going to skip this, but it's very important that you rank the patient, you score the patient, the NIHSS score, to identify which, if it's a mild, moderate, or severe stroke, and then modified ranking score. This measures the level of disability of the patient, and this will help you mark progress as your patient moves. For example, you initially see the patient, the modified ranking score is 5, that means the patient is bedridden. Then after maybe like 3 months, the patient is able to walk with support. That's a score of 4. Now, let's move. Blood pressure management. Now, please remember this. There is permissive hypertension. And the essence of the permissive hypertension is to allow for blood circulation to the penumbra. Now, you have the area of infarct in the center, which is already infected, is gone. But the area around it is salvageable. And for it to be salvageable, it has to continue to receive consistent blood supply. Now, if you crash the blood pressure, it's going to worsen that penumbra. Do you understand? So that is why we allow for permissive hypertension. Okay? So what we do in essence is that, just to make it clear, if it is an ischemic stroke, once the blood pressure is over, yes, you can calculate the map and all of that, but just to make it easier and very straightforward, if the blood pressure is greater or equal to 220, 120, then you give antihypertensives immediately, parenteral. And the whole idea is even not to crash it, but to reduce it by 15% over 24 hours. What is 15% of 220? So that means what we're trying to do is to take it from 220, for example, to maybe like 200. Our goal is not to crash it, all right? Because we want that area that is salvageable to continue to receive perfusion. Then for hemorrhagic, 180, 120. Then someone may ask a brilliant question. The blood pressure is 220, 120. We're not sure if it's infarct or hemorrhagic. Whichever one it is, once it's 220 and is 120, you can begin to give parenteral antihypertensive already. Do you understand? It's except if it's less than, then we're waiting to do a CT scan to be sure. Then the next point is, okay, so when you have done that, you've done your ABCD, you've picked out the focal neurological deficit, the patient is, quote unquote stable. You now send the patient for a brain CT scan. Now, the imaging of choice is a brain CT scan with contrast. But with plain CT scan without contrast. But of course, if you have the luxury of, the EUCR and all of that, and it's normal, and of course you can do with contrast. But the idea is for time and to be able to do thrombolysis for this patient, you can do brain CT without contrast. So this picture just shows you the first one. To your left shows an infarct. You can see an infarct on the left hemisphere. It is hypodense. Then the one in the middle is hyperdense. Somewhere in the basal ganglia, you can see that spot that is whitish. All right. Then the last one, you can see lines. So that is subarachnoid hemorrhage. So the CT scan, this is the ideal, in an ideal setting, when the patient comes within 4 to 5 hours, window, and at that point, you can thrombolize the patient. But from from arrival, that's the door to see the doctor, it should be as short as 10 minutes, as much as possible. Then access to neurological expertise. This does not necessarily have to be a neurologist, but someone who is already trained in the stroke team, for example. This person can see and assess quickly that, yes, this is most likely a stroke. We can see the focal neurological deficit. Let's go for a CT scan. And at that time, you've already drawn blood for all the other things that you'll be needing for, like clotting profile and platelet count and all whatnot. And then within 25 minutes of completing the CT scan, you can get an interpretation by 45 minutes. That's cumulative time now, 45 minutes, by the radiologist, who tells you that, yes, this is an infarct, there is no bleed. And then from at that time when you have confirmed that, yes, this is an infarct, and then you've gone through the criteria for and against thrombolysis, if the patient qualifies, then you can quickly give the thrombolysis and thrombolize and send the patient to ICU. All right, so I'm going to skip that. So if you're not doing that, you've already taken blood. You also take blood for EUCR. Very important that you want to know if there are any, because if the patient is hypertensive or diabetic, the patient may also have some form of nephropathy. You want to have that in view when you're managing this patient. Liver function test. You're going to be giving the patient statins if the patient has had an ischemic stroke or has dyslipidemia. So it's important that you check the liver function, because of course we know statins are notorious for affecting the liver at some point. Then fasting blood sugar, we heard that already. You do the trial, not just random blood sugar. Fasting blood sugar 2 hours postprandial HbA1c is not enough for the patient to tell you that, no, the patient is not a known hypertensive or diabetic. You need to screen the patient properly. Then the lipid profile, prothrombin time, INR, HIV screening, toxicology screen, and the rest of them. Of course, you don't do all of that, but the first 5, yes. Then we do other things like echo, ECG, and chest radiography. I'm going to skip that. We don't, because the other ones like the lumbar puncture, we don't typically do that. It's only if we think it's a subarachnoid hemorrhage, there may be an indication where we would have to do that. So yes. So with this, I can actually summarize. So look at the top part. I wish I had that pointer that Dr. Iseko was using. Where is it? Okay, please show me how to use it. I should hold it down. Is it my red glasses? Yes, please. Okay, great. All right. So the patient comes, whether unconscious, whatever it is, and then the first thing you notice is that you do your ABC. That's you assess the patient, airway is clear, patient is breathing, circulation, you've taken samples and all of that. And then you've done your primary survey and you can find a focal neurological deficit. You now send the patient for an urgent non-contrast CT scan. When this patient comes back and then it's an ischemic stroke, what do? I wish I had an insert of those 3 pictures that I had shown you before, and it's an ischemic stroke. What do you do? Now, if the patient qualifies for thrombolysis, in that the patient comes within 4.5 hours, then and then the blood pressure is less than. If the blood pressure is over 185, 110, you control giving IV labetalol, for example, all right, to get it within normal. That's at least 160, 90, for example, to get it down. And then you can thrombolize the patient. Remember that there's a list of indications and contraindications. So I'm assuming that the patient passes that list. Then we can thrombolize, and then we keep before we come here, okay? And just maintaining the blood pressure below 180, 110. Now, if the patient is not a candidate for thrombolysis, which is in most cases we meet such patients, first of all, they've passed the timeline. Once they've passed the timeline, there's no point, going through all the other lists. The major thing to look out is to make sure that the blood pressure management is very important, because we allow for permissive hypertension. We do not want to worsen that area that can be salvaged. You only give antihypertensives if the blood pressure is greater than 220, 110, okay, 120, sorry, and you can give IV labetalol 10 to 20 milligrams over 1 to 2 minutes and repeat every 15 minutes, a maximum of 300 milligrams. Remember that we only want to reduce it by 15% in the first 24 hours. Okay, then after that we move to the next step, which is we give antiplatelets. We can give 300 milligrams starts if the patient comes in the first 48 hours, all right, and then 150 milligrams daily. Otherwise, you only give 75 milligrams daily, all right. If the patient has had thrombolysis, you have to wait for 48 hours before you start antiplatelets. Then hemorrhagic, whether intraventricular extension. Did I do something? Okay. So one of the things we need to do is, once you see signs of raised intracranial pressure, we co-manage with the neurosurgeons, which will come in, all right, to sort that out. Otherwise, we just focus on controlling the blood pressure, and our target is 140/90. And then, whether it is ischemic stroke or hemorrhagic stroke, early neurorehabilitation as quickly as possible. And remember, they know how to start slow, and go slowly, all right? Start low and go slowly so that they're not so radical in the neurorehabilitation, which also has speech therapy as well in the neurorehabilitation. Then we go on to secondary prevention and then prevent complications. All right, so I've already said this, okay? Early rehabilitation, it should be multidisciplinary. It's not just the physical therapy. There's speech therapy, there's occupational therapy. There are few, but they are present in Abuja and in Nigeria generally. Then remember fluids. I didn't mention fluids earlier, but please, is also part of the concept of permissive hypertension, or ensuring that the penumbra is well perfused. So we give fluids, IV normal saline, like 1 liter, 8 hourly. However, if the patient has some cardiac compromise, we want to step down on the volume of fluids that we give. Then supportive care, I've spoken about febrile, how we have to give, how we have to control temperature. We have to give antipyretics. Head up, that's the nurse, the head, the position of the head, that it has to be 30 degrees head up to, to help in case there's raised intracranial pressure. It'll help for venous drainage. All right. Nail powers, we also have to assess that there is for gag reflex. If it is absent, we have to pass an NG tube and make sure there is nail powers. Okay. And then prophylaxis for DVT has to be kept in view. I've spoken about glucose control. I'm going to skip this. I'm going to skip this. I'm going to skip this. So in summary, stroke is a leading cause of disability. The burden of this disability is real. It's not just real to the individual, it's real to the family, especially if the father or the mother, someone who brings in great income to the family has had this stroke. So you can imagine what that whole family will be going through. Then rapid diagnosis and timely intervention is key in the stroke management. Brain is time. So in summary, this is how I like to summarize management of stroke. Resuscitation, that's the ABC that I spoke about, and then you send the patient for a CT scan or a brain imaging, and then recanalization if the patient qualifies for thrombolysis, then you recanalize. Reperfusion is what I spoke about, where you give IV fluids and manage blood pressure to ensure that it's optimal, so that that area of the penumbra can be salvaged. Then we go to neurorehabilitation. You find that sometimes what happens in a lot of our hospitals is that because they're of the poor, a lot of the physiotherapy department, they can be overworked. So sometimes when you ask for a patient who has just had a stroke to get physiotherapy, they don't even get it until 1, 3 days or 5 days after, and that's sad, so that is something that needs to be looked at, because neurorehabilitation is very important. And of course there's a place for speech therapy and occupational therapy. Then for secondary prevention, that I did not spend time to look at, but this is very important. So this is where you look at all the risk factors for stroke. Number 1, hypertension. If the person is hypertensive, make sure that the person gets good control. Diabetes, if the patient is diabetic, and you have to be sure that the person is not diabetic. Even if the person gives a negative history, screen for diabetes and make sure, all right, because on that presentation may be when that diagnosis will be made. And then we look at lifestyle, issues, alcohol, cigarette smoking, and then exercise, diet and nutrition, and please permit me to mention sleep. Because sometimes people exercise and then they don't know how to manage stress properly, and then they are not sleeping effectively, because I found come down with a stroke. When I mean healthy people who exercise, and who look fit, and they're not hypertensive and diabetic. So you need to look at all these other risk factors of stroke, because once a patient has had a stroke, there's a high tendency that they're going to have another one. So just to make sure that they do not have another one, you must and should address these secondary or these risk factors for stroke. I think at that point, you've taken off my slides already, so thank you very much.
Thank you so much, ma'am. Do we have any questions? Quick questions.
Please, I want to ask the place of use of IV monitor and furosemide in stroke management. Also, the furosemide also in the management of the BP aspect. Can we also use furosemide to at least to reduce the BP?
All right, thank you very much. So very quickly, so the place of mannitol is for the management of raised intracranial pressure. All right, so how do you know that this patient has raised intracranial pressure? For example, first of all, symptomatically, if the level of consciousness is dropping, all right, then there's evidence of if the patient is vomiting and then blood pressure goes up and the pulse is reduced, that can be a sign that there is raised intracranial pressure. And then if you have the opportunity of doing a fundoscopy and you find papilledema, fine. So those are evidences of raised intracranial pressure. And yes, that's when we use mannitol. And we don't just use mannitol like that. So the way to use the mannitol is you use, for example, 20% mannitol. You give it over IV 20% mannitol over 15 minutes. If you give it longer, it's actually counterproductive. So like 15 minutes, and you give it with IV normal saline because it has a great diuretic effect, and you don't want your patient to come down with AKI. So that's the reason why you give it, and it's also for that reason that you also give furosemide. So we don't give furosemide because of the blood pressure. We give furosemide because we are administering. Some people in some centers, they don't even bother giving furosemide while they're giving mannitol, but in some centers, yes, while you're giving the mannitol and IV fluid, you give furosemide, and you give it 8 hourly over like 24 hours. So it depends on how the patient is responding. You reassess. If the patient is stable and getting better, fine. Otherwise, you may want to increase it for another 24 hours.
Again, just to re-emphasize, we don't rush down the blood pressure. We have criteria for touching the blood pressure by the height of the blood pressure And then when we are giving the blood pressure, when we are going to take care of the blood pressure, there are drugs we use. We typically prefer parenteral short-acting drugs that we can control. We talked about that earlier. And furosemide and mannitol is not really for blood pressure, it's for cerebral edema. And by the time we are giving that, we're not using the furosemide to control the blood pressure, we're using it with that one. Just to re-emphasize, the nursing care is perhaps one of the most critical things for the patient that has had a stroke. And whether they will die or not, I don't know whether the study was ever published. There was something done in UCH at the time where they checked the cause of death of most people from stroke, and most of them was aspiration related, aspiration and pneumonia related. So just to emphasize that what happens in the nursing care afterwards is very, very critical. Okay, but very, very good question. Thank you so much.
Thank you very much. This question is on lifestyle, and you know lifestyle is the cornerstone, whether it's hypertension, whether it's diabetes, and the stroke, as you mentioned. The question of alcohol is not clearly defined. The previous speaker on hypertension said reduce alcohol. The previous speaker on diabetes said reduce alcohol. In your own case, you say don't take alcohol. And the standard recommendation for alcohol is 21 units per week for a man and 14 units per week for a woman. When you say reduce, can you quantify it? And now you said stop. Which one do we take?
Follow me. Follow me.
Follow what she has said. Stop. Stop.
So let me even tell you, I'm also a board certified lifestyle medicine physician. What we say is no alcohol. No alcohol, okay? No. Studies have shown, we are not just saying it, studies have shown there's no safe limits.
So no alcohol. Don't start. Don't say that they say red wine. Somebody's here. Don't say that they say red wine. Don't start. And if you must drink no more than 2 glasses a week, 3 glasses a week, it's fine. But by the time you sit down and say let's cancel bottles, you know that you are canceling life. So 1 glass, 2 glasses, 3 glasses a week, but do not start, do not encourage to stop alcohol, especially once they are having or they are at risk for this. Please stop. Thank you.
Thank you for the presentation. From the medication point of view, talk about aspirin, starting aspirin 300 milligram to continue with 150 milligram daily with clopidogrel 75 milligram. So, not clopidogrel 75 milligram. So my question is, many a times you see patients on secondary prophylaxis with aspirin. Some you see them on 75 milligram, some on 150. So please, I need explanation for that. Then for how long will you keep place a patient on clopidogrel 75 milligram for how long? Then for aspirin as well. Then in patients with hemorrhagic stroke, when do you place them on nimodipine? Thank you.
Thank you. Nice question. So let me take the first. So basically,
please, can we? I'm hearing somebody in the house. Please, let's listen and take notes. We'll be done today. After today, you can gist again. But now let's collect as much stuff.
Okay. So when the patient comes in and you know that the patient has had an ischemic stroke, you should give antiplatelets. Studies have shown that it helps with reperfusion, clearing of the thrombi and all of that. If the patient comes within 48 hours of onset, that's when, up to 48 hours, you can give that 300 milligram start of aspirin, then subsequently 150 daily. If the person has gone past that timeline, just give 75 milligrams of aspirin. Or if they can't tolerate aspirin, give clopidogrel, 75 milligrams daily. Now, it is that's clopidogrel or aspirin will be part of their secondary prevention or tertiary prevention of stroke, so it will be continuous. All right? You got that. Then the second one is nimodipine. Now, nimodipine is given in the management of subarachnoid hemorrhage. Now, when a patient has had subarachnoid hemorrhage, you remember that picture that has star-like, and remember that their major complaint will be headaches, all right? And you've done a CT scan. Yes, it's a subarachnoid hemorrhage. So apart from controlling the blood pressure, we specifically give nimodipine to prevent rebleeding, because once they have had that bleed, remember that subarachnoid hemorrhage is a bleed, and we want to prevent a rebleeding. So studies have shown that we need to give that nimodipine, and we give it for like 21 days. Okay, that has nothing to do with the blood pressure. It is specifically for that. Sometimes we, even in controlling the blood pressure, while we're giving the nimodipine, we're even giving amlodipine as well, you know. But the nimodipine is for that purpose. Thank you.
So remember that the man has had a stroke. So what kind of risk would he be on? High risk, extreme high risk, very high risk. Who remembers? Very high risk. So the LDL target will be what? 55. And then now the ASCVD score is automatically over 30%, Abby. So he will definitely be on that antiplatelet for life. When we're talking about hypertension, we talked about people that you put on aspirin. And we say it's not everybody that you put on aspirin. Only those that their ASCVD scores above 10% or above 20%. And these people can now qualify for that.
Okay, so I have two nice questions here. Yes, I need to highlight this very clearly. How long is permissive hypertension allowed? So typically for like 48 hours. So when the patient comes in and has just had a stroke, so within that first 48 hours, you're not touching the blood pressure. You are leaving it as it is. Only if it is an ischemic stroke and it is 220, above 220, 120, then you want to attempt to reduce it strategically over 24 hours by 15% using parenteral antihypertensives. Okay, so 48 hours. So after that 48 hours, you typically commence with what the patient was on before the patient came. And even that, you're not just trying to crash it. You just give it, okay, 10 milligrams of amlodipine, okay, and lisinopril. You just recommend and just watch the patient go on. And remember that the patient is also on IV fluids as well up until that time. So that will also, so typically 48 hours before you recommend the antihypertensives the patient was before he or she came to the hospital. Then please, at what instance do you request for a brain MRI and versus CT scan? Yes, nice question as well. So I think you should basically, what you should go with is when a patient comes in, especially if it's an acute stroke, the patient comes in less than 24 hours, as in 4 hours or, you know, within that window, just ask for a brain CT scan. Just avoid any complications. Leave the decision to ask for an MRI to the neurologist or to, you know, to the stroke team. Do you understand? Just stick to that. Yes, there are times when we would actually prefer to do a brain MRI, especially when there's some confusion. Is this a stroke or not? So leave that to us. But for clarity and rapid response, which is what we're dealing with here, please just go for a CT scan. In fact, a plain one at that. Okay? Thank you.
All right, let me answer the final questions. Who's the next speaker? Get ready. So question one, I see some institutions give both aspirin and clopidogrel. Is that okay? So the setting in which we give dual antiplatelet therapy is typically A, in a patient that is having a STEMI, a heart attack. B, patients that have had a stent in situ. So they typically will take those dual antiplatelet for 6 months to 9 months, sometimes up to a year, especially if they've had many stents. So aspirin and clopidogrel can be given together, especially if the person has had a stent or is having an ongoing heart attack. Coronary, we'll talk about that today. So that is when we use that. In stroke, we typically don't give that because it increases, if you give that together, it increases the chance of conversion. Now, if you've not done a CT scan, do not give aspirin. CT scan and MRI, CT scan neuroimaging is mandatory in the management of stroke. Know that, okay, it's poverty that caused the problem. Don't go and complicate the problem. If they cannot afford a CT scan, please be very careful about just starting it. You might think an ischemic stroke and you give that aspirin and the patient will just worsen, because if it's a bleed, the person will just bleed more and get worse. Okay? Very important. Why is aspirin or clopidogrel given to patients that have not had cardiovascular events? Is it right? Remember that we talked about our ASCVD score. Right? Who remembers that? And we said calculate it. calculate, go to this thing, and if it's more than 20%, you can consider it, especially if there's diabetes. What is the role of alteplase in stroke management here in Nigeria? How readily available are surgical interventions? Okay, so she talked about it briefly. I'll just say something and then she can add that as well. Alteplase is a thrombolytic agent. It helps to burst up clots. You will only use it in a stroke that A, the person got to your hospital, you have had your CT scan done, you have been sure that it is not, that it is ischemic. And all of that was done in less than 4.5 hours after the first symptom. That the person started feeling like this, cannot move the hand and leg. Then he got to the hospital. Then he had a CT scan. Then the CT scan was interpreted. And we are sure it's not hemorrhagic. And all of that in 4 hours. Hello? It's possible, Abby?
Yes.
It's possible. It's possible. Ambulances, 911, color code. Okay? Is it very possible? Sir, what do you think? Is it very possible? They have to go open card, Abby. Then go to pay for the CT scan. Then we have done a number of cases for thrombolysis in cardio care. Quite a number, actually. Okay? Now, is alteplase readily available? It's very expensive. It's about, the branded is almost 2 million or 3 million naira for the vial. Tenecteplase is a little bit cheaper, but it's available. So all of that must happen and the money also must be available. So this is where insurance typically will come in. But we have it available in cardio care, so you can actually send somebody. I think we are more or less the only institution that has it in Abuja. So we keep it. If anybody needs it, you can come to cardio care and pick, so that it does not expire on your hand, since we are a reference center. Okay, then surgical management, how readily available? Surgical intervention is readily available, at least available in cardio care, and available in a lot of tertiary institutions, government owned and some private institutions. But it's available in cardio care. We've done quite a number of surgical intervention for stroke from EVD. What's EVD again? Extraventricular drain, including drain from the cerebral ventricles, including all those things. So we do that quite a number of times. So it's very available. So healthcare in Nigeria is not that bad. It's just scattered and it's costly and it's difficult for people to pay for it. And the healthcare workers need to come together, learn the education and apply it in an organized manner. I think that's just the main thing. It's not that it's available. Okay? I think I want to identify.
Yes, no, I think you've said it well.
Great, thank you so much. We have to end here. We can do stroke for 2 days. I can assure you.
Please, can we give Dr. Samuyi a wonderful round of applause? Thank you so much, ma'am. Thank you for that very beautiful presentation. So before I invite the next speaker to educate us, I'd like to give us to give a warm round of applause to our sponsors. Please, one round of applause. Let's appreciate our sponsors for ACS 2025. They have their booths at the back: Metronics, Edge Plus, Gales, Novartis, Airtel Nigeria. Who are ambassadors here? Nobody. Airtel, sorry. Okay. So we have Airtel Nigeria and then Basic Pharma as well. So please, you can visit their booths at the back. All right. So moving on, let's please give a warm round of applause to Dr. Adedeji as he comes up to give us a wonderful presentation on acute pulmonary embolism. Please, you can clap louder. It's not easy.
All right, just to add, so these presentations today are mainly part of ACLS, Advanced Cardiac Life Support. So stroke, PE, acute coronary syndrome are all part of Advanced Cardiac Life Support. So this is a build-up. We're going to use it later. That is why you must take notes. So by the time you started that CPR that we did yesterday, you will now start finding out which are the things that caused it. And we have 5 H's and 5 T's. One of those T's is called thrombus. Okay, we'll talk about that later. One of these is called thrombus, and that will be thrombus in the pulmonary, thrombus in the coronary, thrombus in the brain. So, and you may need to address that while you are doing CPR and all of those things. So that is the essence of this lecture. So they are part of this acute cardiac, it's acute. The coffee is wearing off. I need more coffee, please. Okay, so advanced cardiac life support. All right, so we'll go to PE, clot in the pulmonary, then we'll go to acute coronary syndrome. Before acute coronary syndrome, we'll take a short case presentation of an atypical presentation, 5 minutes, and then acute coronary syndrome will come, so you can see one of the cases.
Hello. I guess you were having a nice time. I will be standing on the existing protocol to present the practical approach to management of acute pulmonary edema. My name is Dr. Adedeji Adibayo. I work with Cardiovascular Specialist Hospital, a center you can always rely on in your cardiovascular care. Okay, why are we looking at acute pulmonary edema? Pulmonary embolism, rather. Embolism, rather, sorry. Okay, why are we looking at pulmonary embolism? It remains the third leading cause of cardiovascular deaths, as Dr. Miller has said, after stroke and myocardial infarctions. And it remains a silent killers of human race just because of the way it presents. It makes so many diseases. What it means is it's mostly made in the clinical practice. And you should bear in mind that it has a very strong correlations with deep vein thrombosis. In those people that have PE, usually when you check and do their Doppler ultrasounds, they will always have a coexisting deep venous thrombosis. Usually the incidences are higher in people that are holders and people that are medically ill, people who are admitted in the ward. You only needed the high instead of suspicion to know that, okay, this particular patient actually has a coexisting pulmonary embolism. Now, it usually results from a triad of endothelial damage, the hypercoagulable states, and sepsis. And usually we call this the Vicos triad. Now, when this happens, it usually forms a venous thrombosis. It forms usually in the deep veins of the legs. Now, when this embolizes, it finds their ways to the inferior vena cava, from there it goes to the right atrium. From there it escapes to the right ventricles, from where it goes into the pulmonary arteries. Now, the size and the location where the emboli occluded will determine the clinical presentations of such a patient. Now, when it happens, it will have an effect both on the pulmonary system and the cardiovascular system. But usually on the pulmonary system, it results from the increase in the alveolar dead space. Because of this, there will be a mismatch between the ventilation perfusion, there will be a ventilation perfusion mismatch. And because of this, patient will develop hypoxia. And usually, how do you detect it at the bedside? It's through our common pulse oximeter. When you check, you see the oxygen level coming down. We won't just explain why the oxygen level is just going down. The only thing patient comes with is just probably difficulty in breathing. It's now having low level of oxygen. Now, you have to have an index of suspicion that this is probably a pulmonary embolism. Now, when it happens and it blocks the pulmonary arteries, now there's a build-up pressure there in the pulmonary circulations. That build-up pressure put a stretch on the right side of the heart. Because of that, it will be distended. Naturally, the left side of the heart is bigger. It pulls about 2/3 of the heart size, and the right side is usually 1/3. But when it has pulmonary embolism, the reverse is the case. Because of that build-up pressure on the pulmonary system, now the right side is dilated. Because of that, there will be a stretch. When that happens, the supply to the left side of the heart is impaired, cardiac output is reduced, and when you check your BP, the blood pressure will be low. That's the way the patient will present. Because of that, the supplies to the coronary circulation become reduced. Patient can have some microischemia on the right ventricle. And that's the reason why when you do your troponin, in some patient that has pulmonary embolism, they can have an elevated troponin. Now, usually if a patient is presenting and you are suspecting that this patient has a pulmonary embolism, usually these are the 6 steps that you can actually follow in evaluating such a patient. Usually the first thing is the clinical presentations. You come with difficulty in breathing, you examine the chest, you didn't find anything remarkable, but the only thing you realize is that this patient's oxygen level is just going down. These are the patients you want to suspect pulmonary embolism. Now, usually it's a 6-step thing. Now, when such a patient comes in and you check your BP, the BP is normal, 120/80, he has these symptoms you are suspecting. These are the patient, you follow this step ladder approach in the evaluation of such a patient. When you have that, the other step I will explain further. But one thing I want to mention is that if a patient is coming and he has these symptoms, you check your BP, BP is low. You will skip this 1, 2, 3, 4. You go to your 5. Because at that time you need the bedside echo to actually ascertain why is the BP low. Because once you pick that, the dynamics of management change immediately. Now for the step 1, usually as I said, is a masquerade of so many diseases. You needed a high index of suspicion to be sure that this patient has a pulmonary embolism. What this means is that it's not all patients that come with difficulty in breathing that is heart failure. It's not all difficulty in breathing that is asthma. It could be a pulmonary embolism. Especially when you examine, you look at the chest, it's nothing remarkable, but the saturation is going down. You have to think about it. You admitted a patient in the ward, initially okay, but now realize it's desaturating. Patient that has spent 48 hours in the ward, spent 2 hours in the ward, you need to start thinking about pulmonary embolism. Now, the classical presentation, as I said, is unexplained difficulty in breathing. About 50% of them can come with chest pain. Now, the locations of the embolus will determine the type of chest pain. If it's periphery, those are the ones you see a pruritic chest pain. In that instance, you have the task of differentiating from a pneumonia. If it's central, it could be angina-like, meaning that it's more of a exertional chest pain. Now, if it is massive, you can come with this syncope, pre-syncope, and all those ones. And some of them can come with hemoptysis, meaning that not all hemoptysis are TB. Now, when you now have a patient that you are suspecting a pulmonary embolism, BP is okay, more than 120/80, 110/70. Now, but you want to ascertain that is it really a pulmonary embolism? Now, you follow this particular score. Patient with clinical signs of DVT, usually they come with lateral leg swelling, there could be pain on the calf. If you have such a patient, it's going to have a score of 3. Now, if we are sure that the diagnosis cannot be explained by any other thing other than pulmonary embolism, the score will also be 3. Patient at the bedside, pulse rate is more than 100, the score is 1.5. You admitted a patient, now up to 3 days in the ward, is developing difficulty in breathing. That patient has a score of 1.5. Or somebody that had a surgery in the last 4 weeks, even discharged, now coming to see in the clinic with difficulty in breathing, he has a score of 1.5. Previous DVT, 1.5. Hemoptysis, 1. Malignancy, whether on treatment currently or it has previously been treated, it's also a score of 1. Now, when you do this summation of this, a score that is less than 4, P is unlikely in that instance. Is a low risk of pulmonary embolism. But if his score is up to 4, those are the ones that the likelihood is very high, and those are the ones you go ahead to do your CTPA. Hello? I said what? CTPA. If it's less than 4, it's low probability. Those are the ones that you want to go ahead and check their D-dimer. If you do your D-dimer, if it's low at that instance or normal, that means PE has been ruled out. Because D-dimer is a product of the breakdown of the clot that is formed, usually from fibrinogen. That's what the D-dimer is actually assessing. Now, meaning that if you do your D-dimer and it's normal, meaning that there's no clot anywhere. And that's why the D-dimer is not elevated. In that instance, pulmonary embolism excluded. But if you now do your West score is more than 4, you don't need to do that again because these are more of high risk. You just go ahead to do your CTPA. Now let's assess Let's see who is following me. Now, this is a patient, 41-year-old woman, that presented with sudden onset of difficulty in breathing and chest discomfort for about 12 hours. He has associated sweating and cough, no hemoptysis, no fever. The chest discomfort does not radiate to the left or the neck. He's not non-hypertensive or diabetic, and there was no previous history of pulmonary embolism. Neither smoke or take alcohol. He however had myomectomy about 4 days ago for symptomatic fibroids. She was not on oral contraceptive pills. Now, on examination, she was tachycardic, BP was still normal, GBP was not raised, heart time was 1 and 2, other than the loud P2. He has tachypneic and is desaturating. Now, if you look at this, what's the likely well score of this patient?
All right, what's the well score? Can we calculate?
What's the likely well score?
Please go back to the previous slide. Let them see the well score again. What's the well score? Somebody say 3. Everybody can calculate the well score. It's not for specialists. All right, what's the likely well score? Go back to the case. All right, so now let's calculate together now. What do we think? Somebody say 3. Somebody say more than 3. Yes. Yes, what do you think, ma? Yes, what's the well score? Those of you not paying attention, I'm coming there.
6.
6, how did you reach 6?
Respiratory rate was 102. It's more than 100.
That's how many scores?
1.5.
1.5.
She had a previous surgery less than 4 weeks.
Okay.
That's 1.
That's another 1.5.
5. Yes. She has symptoms that are consistent with PE. She had cough, she had chest pain, and she was breathless.
Okay, excellent. Sudden onset difficulty in breathing in a woman that had surgery in about 4 days ago.
Okay, do we understand that? So we can see how we can calculate. Anybody can calculate it. That's very important about it is that there is no other diagnosis that is more likely to explain it. So let's say she had fever, she had other things that can say, okay, maybe, but the fact that it is sudden is very important. The SpO2 is low, it's very important. She has myomectomy, risk factor, very important, so it's very likely. So based on this now, we now calculated the well score. Now the well score of 6, is that positive or negative? Positive. So what do you do for a positive well score? CTPA straight.
Yes, if you can look at this, the answer here is 6, and you go straight to your CTPA. You can see this is 6, as he said. You follow the last, you guys go straight to CTPA.
Now, if you don't have CTPA, you can still do D-dimer on your way so that you can extra increase your confidence. Okay.
Now, we are now going to step 3 and 4 of that, the step ladder assessment of patients with pulmonary embolism. As I said, the D-dimer is basically to assess the risk of a thrombus that is formed, especially in people that has a low to intermediate risk of pulmonary embolisms. Now, once your D-dimer is normal, you know that P is excluded. Now, but if it's positive, it increases your suspicions in those ones that has low intermediate risk. In that instance, that means you will go ahead to do your CTPA to confirm your diagnosis. Don't forget that D-dimer is not a diagnostic test. Now, the next one is the troponin and the brain nitrate peptide. Basically, it's not for diagnosis. It's just to further stratify your patient. Because if you have a patient that has a pulmonary embolism, don't forget I mentioned stretch on the right side. There's a stretch on the right side. Because of that stretch, there's production of brain nitrate peptide. Because of the micro-infarctions on the right ventricular wall, there's elevated troponin. Now, if you see those tools, it increases the risk of your patient in somebody that has pulmonary embolism. These are the patients you look at. Because if at all is coming in with the normal BP, those are the class of patients that, while they are in the ward, they can actually deteriorate. They can deteriorate, they become an high-risk patient, and you have to start considering thrombolysis in such a patient. Also, if at all you miss this patient, these are the patients that long time, they are at risk of complications. They have chronic pulmonary embolism, pulmonary hypertension. If you see the patient that have the chronic pulmonary hypertension in the past, you will know that detecting this and treats when you pick them is very important. It's only very burdensome. Come with this refractory bilateral leg swelling. Everywhere is swelling. Those are the complications. Now, for the ECG, when you do usually is the most commonest thing you see sinus tachycardia. Other thing may be normal. In fact, in some instances, it could be a normal ECG. But in some of them, the only thing you see is sinus tachycardia. Others, you could see features of right ventricular strains, T-wave inversions in V1 to fever, and they could have right axis deviations, either complete or incomplete right ventricular bundle branch block. That's our step 4. Now, as I talked earlier, there could be pulmonary embolism with hemodynamic instability. What defines an hemodynamically stable patient that is coming with pulmonary embolisms? Now, one, they can have a cardiac arrest, meaning that you needed, as Oga said yesterday, the pulse will be absent, cardiac activities will be absent, they can have an agonal breathing. Those are the class of patient. Patient that has obstructive shock, meaning that the systolic blood pressure is persistently less than 90, and they have features of end organs hyperperfusions. Third, they can have either a transient or a persistent hypertension. Those are what defines somebody that has hemodynamically unstable pulmonary embolisms. As I said earlier, once that step ladder approach to evaluation that I mentioned earlier, you skip from that step 1 to step 5, and this is it. You need a bedside echo to look at the right side. Usually what you see is a dilated right ventricle. The 60 sign is basically the pulmonary acceleration time is less than 60. The peak pressure for tracheostomy regurgitation is also less than 60. Now, when you do your CT pulmonary angio, what you see basically is a what? Is a central filling defect in the pulmonary artery. However, there are contraindications to it. Patients that have renal failure, but don't forget the contrast for CTPA is going to be excreted by the kidney. You don't want to worsen the baseline clinical characteristics, allergy, or somebody that is pregnant. Now, these are the findings that you can see on echo. This is a patient that I presented earlier. This is the CT of that woman. Now, this is just a summary. But while you are doing that, you always have to have at the back of your mind the likely differential diagnosis of a patient that is called pulmonary embolism. It could be MI, it could be pneumonia, it could be acute heart failure. Now, this is just an algorithm that summarizes what I've been saying since morning. Patient is coming with what looks like pulmonary embolism. The question you are going to ask next, is he hemodynamically stable or not, based on those earlier defined criteria. If it's unstable, I said, what you need next is your echo to confirm that the right side is okay. Because once the right side is dilated, in the settings of a suspicion of PE, the dynamic for treatment will change immediately. Now, once it's there, if we are applicable, you can actually go ahead to do your CTPA. Now, if it's not, that means the BP is okay, your suspicion is still this, you assess your West score, as I said earlier. If it's positive, or if it's negative, that rule out your pulmonary embolism. But if it's positive, you go ahead to do your CTPA. And if it is positive, those are the ones you anticoagulate in that order. But if it's hemodynamically unstable, as I said, the treatment is for you want to dissolve the clot that is formed there. And that means, in this instance, it's more of a thrombolysis that you're going to do. Okay, this is just a scheme explain what I've been saying since morning. Acute pulmonary embolism, low risk if the BP is okay. You did your echo, right side is fine. Your biomarkers are normal. These are just anticoagulate them for 3 to 6 months at least. Now, this one, suspected PE, BP is low. These are high risk. These are the ones who thrombolize. Now, there is this intermediate class. When they are coming, PE, you did your initial BP was normal. But when you did your echo was dilated. If it's dilated without elevated biomarkers, these are low intermediate risk. Those ones just continue anticoagulation. But RV is dilated, biomarkers are elevated. Those are the ones you have to be on the look. they can go down, and once they go down, you want to thrombolize. Systemic thrombolysis. Now, the goal of treatment, how do we treat? Goal 1, reperfusion therapy is high risk. In those ones that are low risk, you just treat and prevent recurrence, and you address the complication where it is present. Now, in those ones that are coming, as I said, hemodynamics, oxygen usually low, you want to give oxygen. Low BP, you want to give a cautious normal saline, nothing more than 500, because if it's more, you are going to worsen the right problem. Now, as per perfusion, and somebody can benefit from inotropes to support the BP. Now, the treatment, if the perfusion therapy could have a systemic or catheter directed. Systemic, we follow normal standard protocol through our normal IV line. Why catheter directed means you are introducing a catheter either through the femora or you are using radial and take it directly to the pulmonary artery and allow the drugs to be dissolving the clot that is forming already. Now, and surgery, depending where it's available, if you are contraindication to systemic thrombolysis. Anticoagulation that I said, first lines, there are these newer drugs, the NOACs. Exceptions are those ones that are pregnant and other contraindications to this. IVC filters in those ones that have contraindications to systemic thrombolysis, or somebody that have a recurrent thrombolysis. Now, for thrombophilias, treatment is usually lifelong. Thrombophilias are those ones that they have this genetic derangement in those natural anticoagulant, protein C, protein S deficiency, people with antiphospholipid syndrome. Those are the ones that are on lifelong treatment. Now, complications, chronic thrombopulmonary embolisms. These are one of the complications that patients that are missed, pulmonary pressure will be more than 20, and usually local to where the clot is and dissolve it continuously. And in this woman, it was more of a catheter directed that we did, not the systemic thrombolysis. Okay, this is a summary. Patient was discharged after 6 days. We discharge on rivaroxaban, usually 15 milligram BD. You start for the first 21 days. Later, it was 20 milligram daily for 3 to 6 months, and we have been seeing this woman in the clinic. Now, if you look at this is the repeats. 72 hours after thrombolysis. This is the initial one. If you compare it, though it's not less than this, but it's closer compared to what it was initially. Okay, this is the second one.
We need to end now.
Okay, something similar to what I discussed.
Any questions?
Something similar.
Any questions? So, PE, we have said, number 1, sudden dyspnea, sudden breathlessness, often, worsening. We'll now classify whether it is very high risk or not by what? Blood pressure, not so?
Yes, sir.
Low blood pressure, cardiac arrest, even if it is transient low blood pressure, that is a very high risk and you need to treat immediately. Typically, you would need specialist input at that point. Now, if it is blood pressure is fine, we will now look at other things. For those with abnormal echo or those with abnormal biomarkers, we can now put them towards intermediate risk and we watch them very closely, typically in ICU. At some point in time, we may have to progress to treat them like high risk because if they are getting worse. But in some other cases, people don't have many symptoms, they do well on oxygen, we just continue anticoagulation. Anticoagulation is typically for a minimum of 3 to 6 months afterwards. And most times, patients will do very well when they are treated on time. Okay? Now, very important, one of the presentations we talked about is that they can come with a cardiac arrest. They were on the ward, they were fine, they were about to be discharged tomorrow from stroke or from any other thing, from pneumonia. And suddenly, they said somebody came to see them. Everybody said that person brought jazz. They did not bring jazz. They developed P and got a cardiac arrest. In the process of doing our resuscitation, we made the diagnosis. And then we can thrombolize during that code. While you are doing your CPR, sometimes you can thrombolize. Okay? And then you continue up thereafter. So patients typically can do very well if you're able to get the clots out. All right. Can we give a round of applause for Dr.
Thank you, sir.
Dr. Fortune? Any burning question? Burning.
Okay. There's somebody at the back.
We have about, I don't know how we'll do this time. Let's do ECG before we do this one.
Thank you very much, sir.
Yes.
I'm Chijoke, a physiotherapist. Okay. And my question is, knowing everything in here, I think it's both a question and more like a suggestion, and that is about bringing us in as the physio team, because sometimes we can see patients and then we are seeing certain red flags, and then you're trying to communicate that to the appropriate professional who is meant to see, maybe refer to cardiology or refer back to the referring doctor and all of that. So I think it would be nice to look at both the tertiary prevention and then the primary care, how to integrate physiotherapists. I'll be very, very glad to know and also communicate with my team. And again, I would also like to, if there's any way that we can make this kind of training, I know this is not for you, the team generally, to make this kind of training compulsory for physiotherapists. Thank you very much.
Thank you, sir.
I didn't get the question very well.
The training of
more of a recommendation.
Integrate. That's why you're here. You're integrating.
Now, but you mentioned something about the primary, secondary, or something. Now, I didn't mention this, but if you are admitting a patient and you are anticipating that this patient is likely to be more than 48 hours on your bed, there is no harm. You need to start a prophylactic anticoagulation. Because don't forget, I said it is more in those that are medically ill. They have other comorbid things that they are managing. And cellular injuries are ongoing. Probably he has a sepsis. And you're anticipating that this particular patient it's going to be on my bed for 48 hours. You need to start anticoagulations prophylactically so that it won't be as if you are managing something, the patient is developing another thing.
All right, so very important. Prevention is better than treating PE. A lot of times, you see all these things we talked about, sometimes you never get an opportunity. The patient just dies suddenly. Now, very important about physiotherapy. So our standard, and for all of you that are in ACS 2025, our standard is generally any patient above 40, especially those that have an underlying illness, that you think will be on admission for more than 48 hours, please give prophylactic anticoagulation. Either clexane and enoxaparin or heparin. Almost all of them must be, except there's a contraindication, which you must document. And if there's a contraindication, make sure that you have them move around a little bit or wear some stockings that can prevent it. So if a patient is in the ICU and it's not that they are bleeding or had an issue, they almost always must be on anticoagulation to prevent PE. A lot of people that die in ICU die from PE, not from what brought them in. People that die from stroke, a lot of them die from PE. And that brings me to the physiotherapy guy. A lot of times people come and say they have leg pain, one leg pain or the other. I have seen it time without number, and the physiotherapist starts massaging the leg, and 30 minutes later the patient is dead. Okay, so in terms of physiotherapy, very, very important. And nursing, unilateral leg swelling, especially with pain, must be assessed before anything is done. So I saw one patient, I was so impressed with the physiotherapist that she went there, she was having leg pain and this, and the man said, what? One-sided, touch it pain, and he said he's not doing anything. Go to the doctor. I have never been so impressed with anybody like that. Okay, some other people will just collect and start doing, before you know it, boom. There are so many cases. So leg swelling, leg pain, no. There must be somebody that certifies. 2, if you are going to do physiotherapy for people that have been on admission or have been immobile for a long time, you should make sure they have been on some form of anticoagulation. And if they have not, you need to take special precautions from the managing physician. Why is the person not on anticoagulation? And are you sure you want to go ahead with physiotherapy? Because if not, you are the one that will do. Why? They could have small clots in their legs, and once you just massage the leg, you will help to push the clot straight in. Some people will get to the hospital, some will never get. Okay, so very, very important. Thank you for that question. We need to go into 14 around now. It's not around.
Hello, sir.
It's around. Okay, come now, quickly.
Okay,
you have
so
3 minutes.
My own question is as regarding most of my patients, I think I'm a dialysis nurse, so they're having dialysis and through their central line, and then air goes in through the central line. I think just a few days ago, I had a patient that was in the ICU, was on clexane, and then had a femoral artery repair, and we're battling it, and then blood went through, and we had a very similar case of PE. So through the weekend, before this symposium, I kept wondering, what did we...
Just say again, you were doing dialysis, and what happened?
No, this patient was a renal patient. Post-dialysis, I think in fact, he weren't able to complete the session 2 hours into the session. The patient was already becoming breathless.
Yeah.
But the patient had a background history of... there was an aneurysm, so they were correcting it. And this patient was on 15 liters of oxygen. In fact, the moment I stopped the session, we put the patient on high. And then this patient already was on clexane. And in fact, I think he was having, because before the clexane, he was on heparin, IV infusion, just so that because of the suspected clot. So I kept on trying to think, where did we get it wrong, or what did we miss? Because eventually we lost that patient. You will lose that patient, unfortunately.
No, I'm not saying you did anything wrong. I'm saying that unfortunately you will lose that patient. I'm not castigating you. Just so PE is deadly. It's deadly. Unfortunately, giving prophylactic anticoagulation does not 100% exclude deformation. So in those kind of very high-risk patients, you may have to add pneumatic compression stockings. So you have this big thing, we connect it to light, and it's giving air and pressing the leg, pressing. So as soon as they come in, especially when you cannot give good dose of prophylactic anticoagulation, you need to wear the big stocking. It has airbags like that. So it will be pressing the leg continuously while you are giving maybe a lower dose of your Clexane or whatsoever. Now, in some people, despite that, they may still have it. They are extremely high risk. If you notice that they are such high oxygen requiring and you've done all of this and it's very likely PE, you may have to treat the PE before the dialysis. And in this case, you might have to do the systemic thrombolysis or take a catheter straight in there and try and break it up. Or better still, take a catheter there and extract the clots. So we have a catheter called an inari thrombectomy catheter, which we take from the groin. It's a very big catheter, pass it through the right heart, go into the pulmonary artery and suck out the clot and bring it out all at once. So that will have been perhaps the role, especially when the patient started going down. Immediately you had to stop the dialysis, and thus was that your first thought should go towards PE. And immediately you should be thinking of thrombectomy or what they call it, thrombolysis, either catheter directed or systemic. In this kind of case, I will choose catheter directed because there's likely of bleeding everywhere. So you take the catheter to there, and you will give it a small dose, unlike the one you give systemic, because you are now over the clot. The person will now typically. So in those kind of patients, what we have seen, I presented a case series of about 17 cases in Senegal last week, and then in NCS during the year. They normally go off oxygen within 24 hours. It is that dramatic because you have taken out the clots, the thing will break it up. It's really dramatic. It's expensive, but it's dramatic. It really, really works. So in those cases, that's the way you could have handled that case. But I cannot tell you that you did anything wrong or right. It's a very difficult case. There's no easy way out. But like we have said, P is a masquerader. We should be extremely ready, extremely prepared. It could happen at any time and it could happen to anybody. Okay? But it should typically not happen for a patient on your ward. And one of the key things is to prevent and be on prophylactic anticoagulation, and also to recognize it quick. Immediately it's happening. Those well score, the nurse should calculate it and say, doctor, this is what the well score is. The nurse may even request the D-dimer if it's allowed in your facility. Request it so that you can have that evidence. Everybody's mind will go there. Then we can now start thinking of thrombolysis, either systemic or peripheral. Thrombolysis works. It's expensive, but it works. Sometimes it's more expensive to do burial. So don't forget about cost. Money is not as important as life. Think about what is best for your patients. Think about what is best for your patient and offer it to them. Don't think about, it's costly, let me not offer it. That is bad practice. Okay, we will get there. We will get there. Before ECHO was not everywhere, CT was not everywhere. Now we are doing CT every day. Okay, very importantly. Thank you very much. Thank you for that last question, dialysis nurse. That was a really fantastic question. All right, so over to you for a quick. Now, after this case, we are going to learn ECG. So you need to do some small press up, because you must read ECG now. So your pens, your papers, everything, get ready. You will take this case for 5 minutes, and then we'll go straight to ECG interpretation.
Thank you very much, Dr. Iseko. My name is Dr. Fortune Wachuku. I'm a medical officer in Cardiocare, our National Center of Excellence in Healthcare, Cardiovascular Healthcare. So I'm going to be doing a case presentation for a patient that will manage in our facility, Mr. SGVP, admitted on the 30th of June and discharged on the 11th of July 2025. So Mr. SGV was a 65-year-old Indian citizen, known hypertensive diabetic of 5 years, who presented to our facility with complaints of epigastric discomfort and bloating, abdominal distension, and difficulty in breathing, all happening 1 day prior to presentation. There was no history of chest pain, no history of palpitations, no history of diaphoresis, feeling of impending doom. There was a positive family history of hypercholesterolemia, does not smoke, does not take alcohol or use any recreational drugs. So this, just to talk about the history of presenting complaints, the epigastric pain, discomfort, said to be associated with nausea, but no vomiting or changes in bowel habits. Abdominal distension also occurred few hours after onset of epigastric discomfort. And this said difficulty in breathing. There was also a positive history of orthopnea, PND, however, no palpitations or leg swellings. So on examination, this is just a brief summary of the case. On examination, he was a middle-aged man in obvious respiratory distress. He was dyspneic, febrile, 37.8 degrees, not pale, anicteric, cyanosed, not dehydrated, with bilateral pitting edema up to the mid-shin. His RBS on presentation was 7.4, pulse rate 134 beats per minute, small volume regular, no arterial wall thickening or anything suggestive of long-standing hypertension. The BP 114/72, he had an elevated JVP, and his apex beat was displaced and diffuse. Heart sounds S1, S2, S3 with tachycardia. On the abdominal examination, full moves with respiration, vague right hypochondriac tenderness noted. The liver was 4 cm below the right costal margin, no other palpable organomegaly. CNS, there were no remarkable findings. And in the respiratory system examination, the respiratory rate was tachypneic, 34 cycles per minute, saturating at 71% in room air, and then 93% on non-rebreather face mask. No tracheal deviation. On auscultations, there were bronchial breath sounds with widespread crepitations bilaterally. So I know, looking at this, our history and presenting complaints, epigastric discomfort and bloating, most people will think, oh, this patient is probably having an ulcer or dyspepsia or something like that. So, and then on further examination, our working diagnosis for this patient, we're thinking, oh, because of the dyspnea on at rest with orthopnea and PND, this patient could be in acute decompensated heart failure, NYHA, class 4, secondary to a query-dilated cardiomyopathy precipitated by a chest infection. Our second working diagnosis, we're also thinking about to rule out an acute coronary syndrome complicated by acute pulmonary edema, that's acute left ventricular failure with the KILIP classification. So we did some investigations. We did the troponin I, NT-proBNP, full blood count, CRP. So as a rule of thumb in our facility, every patient who comes in with chest pain, epigastric discomfort, they need to get an ECG within 10 minutes of presentation. So coincidentally, this particular patient on presentation, doing the ECG, we could see that this patient had obvious ST segment elevations in the anterior septal leads with ST segment depressions in lead 1 and AVL, and then also sinus tachycardia. So this is a classic case of anterior septal MI with some pathological Q waves in the inferior leads. On further investigations, we did a troponin I for this patient that showed 38.4 nanograms per ml. NT-proBNP, you can see the reference values, NT-proBNP 17,000. The full blood count showed absolute neutrophilia with a PCV of 44% and a platelet of 214. On the urea and creatinine, we could see that the patient has some form of AKI due to the elevated urea and creatinine levels. Lipid profiles, the LDL was okay, but the triglyceride was deranged. Urinalysis, so 2 pluses of glucose, 1 plus of blood, uric acid 10, CRP elevated, ESR elevated. So the plan for this patient, per protocol, we used dual antiplatelets, aspirin and clopidogrel, 300 milligrams start, then 75 daily subsequently. The role of statins should not be downplayed in management of MI, because apart from lowering the cholesterol levels, it also has anti-inflammatory effects and also plaque stabilization effects. So we use that. And then for anticoagulation, we used heparin, 5,000 IU 6 hourly. Some of us can ask, why heparin over Clexine? This patient was being prepped for percutaneous coronary intervention, and it's always advisable to use heparin in that case. Furosemide 80 milligrams, then 48 hourly, rabeprazole, ceftriaxone, antibiotics, then the GDMT, spironolactone, and EMPA. The patient was then planned for an urgent CAG and PCI. And then following CAG, the patient was noted to have 50 to 60% occlusion in the mid left anterior descending artery, 99% stenosis in the distal LAD, diffuse lesions in the right coronary artery, and then 1 stent was deployed. The procedure was well tolerated. So subsequently, this was the plan post-MI. The patient was meant to have 75 milligrams of clopidogrel and statins for at least 6 to 9 months, high-dose statin therapies, IV normal saline infusion. Can ask why normal saline in this patient who is obviously in failure to clear out the creatinines used in the procedure and to avoid metformin. On day 3, the patient was still breathless, however, was now on moderate exertion, no complaints of chest pain. He was weaned off ionotropes, had been ambulating, still felt bloated, was said to be resolving. Vital signs were all stable. He was no longer on non-rebreather face mask, now steps down to nasal prongs and saturating at 96%. Still had coarse crepitations in the middle and lower lung zones. At that point, the patient was transferred from the ICU and moved to the ward. We did a septic workup for him, changed his heparin to Clexane 40-12 hourly, increased his furosemide, and also placed him on suppository prophylactics and dosage to encourage liberal fluid intake and intermittent oxygen therapy. Subsequently, 4 to 6 days, the patient was doing very well. The chest x-ray done for this patient at this point showed cardiomegaly with clear lung fields. So it was obvious that the heart failure was resolving, and then the creatinine and urea were on a downward trend. However, the patient was still bloated, although it was said to be subsiding. The BP was stable, vital signs were all stable, and then the heart sounds 1 and 2 with tachycardia. The patient was now saturating at 95% in room air, residual crepitations in the right lower lung zones laterally. So our assessment was resolving decompensated heart failure secondary to DCM with background coronary artery disease. The plan was to increase the busuprolol to temporize on the euperio due to the low BP and to monitor vital signs. 7 to 9, the patient was still bloated. However, abdominal ultrasound showed distended bowel loops. Placed him on tenidazole as discussed with the gastroenterologist. By day 10, the patient was okay, bloating had subsided. Vital signs were all stable. We did a full blood count and UCR that had all normalized. And by day 11, the patient was discharged. Follow-up was done 2 days after discharge. The patient was doing well, and a back referral was wrote to the patient, who continued his management with his cardiologist in India. Thank you very much.
Thank you. Any questions? Any questions? It looked like typhoid, Abi. It looked like typhoid, Abi. This is why you are here. It's cases like this that started Abuja Cardiovascular Symposium. Bloating, chest infection, fever, and everybody just says, okay, that is what it is.
Okay, good afternoon, everyone. My name is Dr. Alfia Job. I think I had a question in the previous topic, but then I think it's still going to go on here. In the previous patient with the PE, the BNP and troponin are elevated.
Yeah.
Same thing in patient with myocardial infarction. So I was just thinking, patient that, and of course these are close differentials.
Yeah.
So patient that has, let's say, non-STEMI and patient with PE, is there a way to just, maybe is there like a cutoff for this BNP and the troponin that will make me suspect maybe one over the other? Because of course both of them are elevated in the two conditions. Thank you.
Okay, so what I would just say is that don't forget that by the time you are dealing with these things, you should really consider a role of a specialist at this point, because these are life-threatening, high mortality cases. You should really have a specialist look in. That's number one. Number two is to say that more often than not, when troponin is elevated in PE or the like, which is not primarily from a cardiac arrest, from MI or the like, it's not as high as that. Did you see how high it was? It was 38. Normal is 0.3. That's over 1,000 times the upper limit. So that kind of one will also give you a pointer. Number two is the ECG. The ECG in STEMI and N-STEMI are characteristic together with that troponin. While in PE, you will not see it like that. In heart failure, you will not see it like that. Number 4, BMP is to remind yourself that BMP is for heart failure. It just tells us that the left atrial filling pressures are higher and the heart's left atrium is stretched. That's all it tells us. I mean, the atrial are stretched. That's all it tells us. So it will be raised in all of them. Once somebody has any heart failure, BMP will be raised. So in PE, BMP is just used to help us prognosticate and say this patient will do worse or better. In MI, patients are always developing heart failure and it's to prognosticate. In heart failure is to help us with our diagnosis of heart failure. So you cannot use the BMP to differentiate between the three of them. So then by and large, the clinical presentation of all of them will be very important in taking a decision. I hope that helps. And I think we should end now.
All right, thank you so much, Dr. Fortune. Please, a round of applause. All right, so moving on, a quick announcement. This is about your certificate, so please pay attention. Please pay attention to where you're sitting now. Maintain your seats. So when we go on lunch or breaks, another seat, please. Remember earlier on they passed the form along all the tables where you had to fill in your name according to how you wanted it on your certificate. So please make sure you maintain your seats. It's not the time for you to start moving up and down, please. When we return back, please make sure you go back to your seat. Now this is a good time to turn to your neighbor and make sure you know their faces. It's good to be our brother's keeper, okay? All right, so the next session item on the agenda is the ECG classes. Now, personally speaking, I always look forward to ECG sessions during ACS, okay? And this is because our lead facilitator, I personally refer to him as a grandmaster of ECG classes. So if you have, yes, please, a round of applause. A round of applause. If you've never attended any classes by Dr. Please, today is your lucky day. So let's take a breather. Breathe in, out. And tell your friend, my friend, focus, focus. All right, so please, without much ado, a wonderful round of applause for Dr. Iseko as he comes up to lead the ECG class.
All right, so before we start giving some confusing stuff, can we just stand up? Stand up 1 minute, stretch. Stretch a bit, okay? Stretch. Good, stretch. Good, 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 good. Take a deep breath in and out. Stand on your toes up so that you can flex your calf. We don't want DVT and PE, Abby. Up, down, up, down, up, down. Beautiful. Now, turn to one side while your legs are in one position. Turn to one side and then to the other side. Turn to the other side. Very well to the very end. Again, to one side and to the other side. Now we can sit down. Clap for yourselves. Some people don't even clap for themselves. I don't know. If you don't clap for yourself, who will you not clap for? Nobody is clapping for you and I say clap for yourself. You don't even clap for yourself. All right, great. So let's do ECG. Hopefully, blood has moved to your brain small. So now let's make it a little bit complex. All right. So the first thing I want you to know is that today you read ECG. Tell your neighbor if you never read ECG that today I will read ECG. So I have a methodology by the grace of God. Now she said I'm a grandmaster. I don't know about that. Now the reason why I teach ECG is that when I became an SR in cardiology, they just gave me a pile of ECGs to start reporting. They did not teach us anything. Oh boy. Rubbish are just the rights. Okay. Then I had to learn the hard way and say there must be a simpler way. So that's why we did this. So we're going to do ECG in what I call ECG in 90 minutes, or more or less 60 minutes. Everybody will be able to read an ECG. So where's the pointer? So before that, my commitment to you is that if you can see, you can read an ECG. Now, I need a volunteer among the media team. I need a volunteer among the media team that we will use to learn ECG while we are here. Not a medical person at all. To show you that anybody can read ECG. One volunteer for the media team. Volunteer, perfect. So we'll ask her question and you will see she will read ECG. So if you're not reading ECG, now you know. Abi, she doesn't know anything medical. She's not in medical field at all. Good. Another volunteer, you go fit. You never know when you can use and make money small. Oh. I'm joking. All right, fine, beautiful. So we're going to do ECG. So, few caveats. Caveat number one. Caveat number one is that you should believe. Caveat number two is that you must write. It's not a snapping session. You must write. If you don't write, you will not read an ECG. Just take it from me. I'm not cursing you. Now so it be. You must write. So take your pen, your paper, and write. Don't type in your phone. It's not the same thing. You will not. Maybe you have been doing before. You are not reading. Now you have come here. You must write. Some doctors cannot read ECG. A lot of people say, look, when it's time for what they call it, final exam. If you give me ECG, just don't worry. Sir, don't worry. I'll come back next time. Just fail me. Don't bother. Okay. So, number 3 caveat is that you must practice. Today, you practice. When you get to your hospital, gather like 20 ECGs and practice. You will be in our WhatsApp group. There's a scan code. You'll be in the WhatsApp group. If you find any ECG you cannot answer, try and send to the group. We will help you. Any of the consultants will help you. Okay, so you must practice. And if you have the possibility, teach somebody. Even if it's your 5-year-old son, sit them down and start teaching. Teaching makes you understand. These are the principles. Now, if you teach it to somebody, you will, and you do 50 ECGs between today and Monday, you will never need to read ECG again for the rest of your life. However, only 5% of you will do it. I'm not cursing you. That's just how it is. As we finish, some people will snap picture and that will be the end forever and ever. So, say I refuse to be in that number. Good. We have motivated people here. Now, there are some things you must cram. Yes, I'm not telling you up front. You know those people that tell you that math is not hard. You know they are trying to lie to you. There are some things you must cram. And you are going to write down the formulas, try and memorize them, and we'll use them. And finally and most importantly, till tomorrow I still do number 5. You must have a picture of the heart in your mind when you are reading an ECG. No matter how confused an ECG is, and we have many confusing ECGs in cardio care that we have to send to ourselves, I just go back to these very principles. Nothing else. All right, so you will read an ECG. So let's go on. ECG is very important. It's cheap. It's widely available. Does not cost anything to do an ECG. Right? Besides the machine, it's just gel. So those of you in private practice, sharp, everything on top of it, now your own. Even paper, if you are using the computerized one, you don't even have to print. Abi? You can just send it via PDF or use normal paper. That's your highest cost. Paper and gel. Okay, so very important. Widely available. It can be any part of the world, any place, and it's very useful in everything. So let's start. What do the lines mean? How many people feel that they are like this big picture? All right. So these are what the lines mean. The ECG essentially contains these letters: P, Q, R, S, T. Simple. P, Q, R, S, T. The P represents when the atrium is contracting. Now let me move. Good. Remember I said you put the heart in your mind. This is how the heart contracts. From the SA node, the ticker, it sends an impulse. Right? Stop writing, listen, understand this. Once you understand this, the remaining will be easy. Once you don't understand this, you will never read an ECG. So just listen and understand this. Starting point, the ticker sends boom, and a signal. That signal goes round the right first. You see where it is now, so right must chop first, Abi. To the left. Now, atrium will now contract. It will now come here to this AV node. This AV node is like customs. It will delay everything and gather all the impulses together. So that impulse don't come to the ventricle anyhow. It will control it. Now, after it passes there, it will now pass it down towards the right and towards the left. This is essentially how the heart contracts. Is that clear? Again, electrical activity starts from the SA node. The SA node is the one that gives the beat. That electrical activity goes round the right and the left, and then it gives a contraction. When the electrical activity comes round, it comes to the AV node. Say AV node. The AV node is like customs. Everybody park here. Gather everything together. Then that causes a delay. And then it now takes it down the right and the left. Electrical activity goes first, then the heart contracts next. Is that clear now? Good. Every time the heart contracts, the heart relaxes. The person of relaxing too, we see something on the ECG. Is that clear now? We'll go over it again. Don't worry. We'll go over it over and over again. So, based on these things now, we now have the ECG. The ECG is now PQRST. The SA node impulse is not on the ECG. What we are seeing is atrium. P wave for atrium. Say P for atrium. I know it's P for pineapple, but this is not the case. P for atrium. So P for atrium. After atrium, where do we say to go next to? To where? AV node. Perfect. AV node customs, Abi, delay. It must delay. So nothing is happening. You can see it's delay. After AV node, where does it go to next? Ventricle. QRS for ventricle. QRS for what? Fine. And then afterwards, ventricle relaxes. T for relaxation. Say T for relaxation. Good. Very simple, isn't it? Very simple. Now, don't get anything you knew before, forget it. Just focus on what we are saying now. What I've said now, is anything hard inside? Pharmaceutical, it's very easy, Abi. Fantastic. So don't forget every other thing you have said. This one now, understand it. So P for what? PR for what? AV node. QRS for what? Ventricle contraction. T for what? Ventricle relaxation. Beautiful. So we have this PQRS. In between, we have segments. PR segment and ST segment. These are going to be very important when we are diagnosing MI and other things. So now we have sorted out the main parts. Are we clear? Good. So now when we have an ECG, the ECG is looking at the different parts of the heart. If I am looking towards her, two other people are looking towards her, we will all be saying the same thing. So hopefully, Abi, except we are APC and PDP. Abi, we should all be saying the same thing since we are all looking at her from the same direction also. So from here, she's wearing glasses. From the back, she's not wearing glasses. Not so? Hello? From the back, she's not wearing glasses. But from here, she's wearing glasses. So we have groups of ECG that look at the heart together. 2, 3 AVF, you have to write now. This is one of the things you must write. If not, you will forget and you must cram. 2, 3 AVF are looking at the inferior part of the heart. So when you see a problem in one of them, the other ones must also say yes, they saw it too. If only one person is saying it, that person was bribed. Not be so? Hello? So 2, 3 AVF. 1 AVL, V5, V6, lateral. Looking at it from the lateral wall. V1, V2, V3, V4, anterior and septal. You need to write this one down, please. You need to write it down. Don't snap, write. And fast. Start again. These groups of leads, ECG has several leads connected to the body. And it gives out all of these. About 10 of them. Is it 10 or 12? 12 of them. 12 of them. In these 12 of them, they are looking at different parts of the heart. These ones that we have grouped together, they are looking at the same part of the heart in the same direction. So when we see a problem in them, there must be something. At the voice of two witnesses, a matter is what? Confirmed. So whenever we see that problem, two people at least must agree. So we are telling the people that must agree. In this case, 2,3 AVF is what? Inferior. V1 and V2 is which one? It's still on the board. Don't worry. Just say it. I know it's there. V3 and V4 is which one? Fantastic. Lateral. AVL, V5, V6. Write it down. Memorize it. We are going to use it later. Everything we are writing and memorizing is going to get more complex. So this is the one you are going to fall back on. And you're going to fall back on that writing that you wrote. Hello at the back. You know I can't see you very well. But are we all together? Consultants, please, I want you to just spread around so that if somebody has a small question, they can just call you aside and you can help explain. So they will stand near the screens, and just in case they need to explain, that's Dr. Inowa, Dr. Adefila, Dr. Taiwo, Dr. Eze, everybody. So, but you know, maybe you go towards that side. These people, I can see them here. You can go from the halfway towards the back. Yes. What about the AVR? For now, just leave it. For now, just leave it. So in this ECG class, I am not teaching you everything. Because if I teach you everything on one day, that is how come people never understand ECG. So I have picked out some things. You understand this one. Then we will now go to the next level. The reason why everybody does that, they teach everything, boom. Eventually, you now live with nothing. So leave something. Anything I did not mention, just delete it from your mind. We will soon start a certified ECG provider course where you get a certification. That one will be a 20-hour module. You will do, you read, you will pass. You will now go to some of those ones. Okay, but for now, let's just do this. All right, is it clear so far? Is it clear so far? Who is it not clear for? It's not clear for me. Say aye. That's it, some people. What is not clear? What is not clear? Oh, we have talked about P wave. P is for what? PR is for what? QRS is for what? What? What is not clear there? It's not yet complex. It's your trauma. Oh. It's not yet complex. We've not said anything yet. The complex time is coming. Don't worry. Just be coming down. All right. And then we now say that things are looking at it together. And we say that there are 12 different leads. We say that there are 12 different leads involved. Not so? And that they are looking together at each other. And we say, okay, these ones are looking at particular person. Yeah, medium person, you're not writing, no. You are my element. All right. So what's not clear there? It's very clear now, not so? Please, leave your trauma beside. Not hard. All right, so how do we now do is read ECG? Having this background, 6 steps. 6 steps. Make sure you're reading the correct ECG. That's the first one. Number 2, rhythm and P waves. QRS, ST, Q, and T. The same thing we just went. We're now going to see how to read them. Okay, Nano? Do we understand? So we're going to just follow it. But the first thing is that we must make sure that we are reading the correct person's ECG. Some people have been rushed in with the wrong ECG. Hey. All that the name is different. Please. So first things first, make sure you are reading the correct ECG. Make sure it's correctly calibrated, because if it is too high, too low, too fast, it might make you read it wrongly. So that's the first and most important thing. Please don't make that mistake. Don't go and give somebody thrombolysis and it's for the next patient's bed. Please make sure you are reading the correct ECG. So now let's move in. If you look in your book, you will see on one of the pages on your jotter, you will see a page for a quick summary of reading ECG. You can refer to that afterwards as well in your jotters. My gift to you. Yes, now. You will have to read maybe 15 chapters to come up with that thing. So, my gift to you, just a 2-page. Thank you for those that know the sweat that came into it. All right, fine. So, now, rates. We want to know whether the heart is moving fast or the heart is moving slow. For starters, most ECG machines will give you this automatically. The remaining they may be wrong, but this one they're likely right. So, very simply, you can follow that one. But we need to know that. To calculate the rate, we have big boxes and small boxes. Simply, we find the number of big boxes between R and the next R. So, can we see PQRS? Abi, this is R, Abi. PQRS, ST, Abi. Can we see that? PQRST. Can we see that? Maybe I should use this one in case of people at the back. People at the back, can you not see the pointer? I hope it's pushing there. PQRST. Now, the distance between one R wave peak and the other R wave peak, we count the number of big boxes in between. 300 divided by the number of big boxes in between will give us our rate. So in this case, there are 4 boxes in between. 1, 2, 3, 4. 300 divided by 4 is what? 75. Please participate. If you don't participate, you cannot learn too. If there are 2 boxes, 300 divided by 2 is what? 150 on the Muse score is what? Who remembers from yesterday? Muse. People that would like to have a cardiac arrest. MEWS. Modified early warning score. Was it 3, 2, 1? 3 above 30. Above. So you see somebody with 150. You are very close to having a cardiac arrest. So you must know this one before you start having cardiac arrest. Beautiful. Is this simple or not? This is mathematics. 300 divided by 5 is what? 300 divided by 6 is what? 300 divided by 7 is what? 33. All right, very simple. So now we're going to the next one. So what's the rate here? Yes, we're now getting complex. Please, I just want to be with the mic. 2 people to be with the mic so that we can easily interact. 2 people, you hold the mic and be ready. Yes, anybody? 150. How did you arrive at 150? Does everybody agree with 150? I don't know. Say A. Good. Thank you very much. I don't know. So can we see? This is called the rhythm strip. Can we see our PQRS? We cannot see the T very well, Abi. Can we see that PQRS? So between one R and the other R, we count the number of big boxes. Look for one that is very close, like here, Abi. Can we see between here and here? It's about 2 boxes with small. So like 150 or maybe 140, because there's some small there, Abi. Correct. So that is the rate. Isn't it simple? It's not simple. How many boxes between here and here? 300 divided by 2 is what? What is the heart in there? Yes. Why did we have to go down instead of counting up is her question. The reason is that we can count anywhere actually, but we have this strip called rhythm strip, lead 2. It's the clearest and it is the longest. That is why we went down, so that we can see it in its entirety. That's why we just went down. Nothing. We can also have counted here, and because we're looking for the one that perhaps lands on a line that is easy to count. That is why we also went down. Nothing special. So we have sorted out rates, Abi. Good. What is the rate here? 48-year-old woman, dizziness while walking, even collapsed once. Yes, those at the back, I can't hear you. Give somebody.
50. 50.
How did you arrive at 50?
There are 6 big boxes between.
There are 6 big boxes. Yes. So let's look at this. 1, 2, 3, 4, 5, 6. 300 divided by 6 is what?
50.
Everything is easy now. Is it not easy? Clap for yourself. It's easy. You're not convinced, ma. You're not convinced. What's the question? Ask. You're just counting. You're not convinced that it's easy or that it is. Which one? What we have taught so far is easy. Forget the trauma you have before. Right now, we know what PQRS means. We know how to say rates. Abi? Shikena, don't bother yourself. Don't worry. Today, not today. Okay? So let's go to the next one. So I think we have enough. So now, we're getting complex. We are going to reading. This reading is very important. When you are a nurse and you are managing somebody and they have a monitor, so that monitor is not like DSTV, that you'll be able to know whether that person is going to die or not. It is reading that you will likely see. Because heart rate and pulse you may likely be able to count already, even though. You need to know the reading, otherwise that monitor on a TV, they should not replace it with TV. You don't need it. So reading. There are 5 questions you must ask when you want to determine reading. 5 questions. Question number 1. Are all the RR intervals regular? That is why I went to that lower one. Question number 2. You need to write this one or the things you're going to use when it starts getting complex. Even me till tomorrow, I go back in my mind and I try and ask myself these questions. Please, there are consultants near you. Towards the back, if something is not very clear to you, you can raise up your hand. Somebody will come to you and explain to you in detail. Okay? Dr. Anyway, there's somebody raising their hand up. Like you have to turn your chair in that direction and face them. So someone is in the back at that very corner. So you just point. So there are consultants around the hall so that they can just show you. Today you must learn it. So the first thing is that are all the RR intervals equal? Second question. Is the P wave upright in lead 2 and inverted in AVR? Third question. Are all QRS preceded by a P wave? The fourth question sounds like the same thing. Do all P waves have a QRS after it? There are 2 different questions. When we get into the thorough, you will know why they're different. And question number 5. Are all the P waves similar and normal looking? Those are the 5 questions. Is it not a simple question? Somebody say no. You go see that it's very simple. Do you agree? You need to write. The phone does not equal it. Does not equal. It's not the same thing. If you are using phone and you are not writing, it means that we will not agree. I'm going to dance today. I'm going to be very happy today. All right. Great. We finished writing, right? All right. Great. So no matter what, you have finished writing by fire by force. If you have not finished writing, you write as we are going. What is the rhythm here? What is the rhythm here? First of all, what's the rate here? What's the rate? Yes, ma. What's the rate? 60. How do you arrive at 60? 5 boxes in between. Where did you see the 5 boxes? 1, 2, 3, 4. 300 divided by 4 is what? I see people reading this CG like it's water. Come on. 75, Abi. So now, what is the reading? Question number 1. What question number 1? Are they equal? They look equal, Abi. Correct. So that's why we are using this strip. This lead 2 now is our reading strip. Can you see it's long across the end of it? They are all equal also. These are real ECGs. I did not, most of them are ECGs from Cardiocare. We must have over 30,000 or 50,000 ECGs by now. They are all equal. That'll be question number 2. So this is lead 2. Is the P wave facing up or facing down? Here, PQRST. Is it facing up or facing down? Bam. Are we not fine? Is it hard so far? You see, it's not hard. That's what they say, something is not hard. Just know that it's hard. Question number 3. Every QRS, is there a P wave before every QRS? After every P wave, is there a QRS? Correct. Question number 5. All the P waves, do they look alike? No away match, Abi? They look alike. So, is this a normal rhythm or not? So clap for yourself. Who is saying that this thing is hard? Do you agree? Or you have a question? That's why I started with maths, Abi. It's clear, Abi. If it's not clear, yes, please ask. Okay, he's asking, how do I know which one is lead 1, which one is lead 2? If you look very carefully, you can see 1, 2, 3. Can you see that there? And you can see AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. Can you see that? Which one is inferior lead? 2, 3, and AVF. Which one is lateral? 1, AVL, V5, 6. Can you see? Come on. Come on. Yeah. I'm making progress. Kadang. All right, sinus rhythm or not, let's get deeper. Again. Question, who wants to try? Give her, yes. Those people that try, they will always read ECG. In every conference, those people that try, even 5 months down the line, 5 years, they can read ECG to tomorrow. And those that don't try, that's what they go look at.
Okay, the first thing we have to check is the P wave. Is there P wave in the strip, which is there? There's P wave. Then second, we have to check the QRS complex, which is also present. Then we check the T.
What do we talk? This is trauma speaking.
Sorry, the RR.
What did we say? Question 1.
RR interval.
You know that you are not wrong. You are correct. You are just using your previous memo.
Okay.
Just use only the one I'm speaking you today. Keep all those ones. That is why you're not reading ECG yet. Just focus on this one.
Okay.
I know there are many deep stuff. Don't worry. I know them.
Okay, so the first one we know, you said the R to R interval.
Are they equal?
No, they are not equal.
Not sinus rhythm. That's the first question. We have failed it already. Okay? Yeah. Second question.
P wave, is it upright?
Is it upright here? There's P wave there. There's a P wave there. Yeah. We can't quite see it here. Yeah. And it's even upright if it at all is even there at all. We can hardly see any P wave actually.
Yes.
You can hardly see a P wave. There are some P waves though, but you can hardly see any P wave. So no even P waves first. So is it a sinus rhythm or not?
No.
Any reading problem is a serious problem. Anytime your reading is not sinus, is a serious problem. That's the first thing I need to just know. So in this case, we can hardly see P waves. We study P waves in lead 2. We can, if I look well, I can see some P waves, but don't worry for you. You can hardly see P waves. Can you see any P waves here? Not really. You can see maybe one here, Abi. That's one there, Abi. But apart from that, you can hardly see P waves. So we cannot tell whether the P wave is upright or inverted here. Before every QRS, is there a P wave? Is there a Q wave before this QRS?
No.
Is there a P wave before this QRS?
No.
Before this one? After every P wave, we can't see any P wave. So is this sinus rhythm or not? What rhythm is this? If you open your notebook, on the page, there's a type of rhythm that has no P waves and irregular RR interval. No P waves and irregular RR interval. Under those rhythm examples. Or somebody give me a jotter.
V5 or something?
No, not the page, that the summary page.
No P waves. With irregular.
Must be. Basic ECG patterns. The page that said basic ECG patterns at the top. Basic ECG patterns at the top. You will see down under urgent atrial fibrillation. On the right hand side it says irregular, no P waves. Irregular, no P waves. If you are nice to us, we'll give you a banner so you can paste it in your eyes so you can be looking at it every day. Irregular, no P waves. So this is atrial fibrillation. Anytime your RR interval, you need to write this one down. Anytime your RR interval is irregular and there is no P waves, you are dealing with atrial fibrillation. And how will you sit on the bedside? When you are counting the pulse will be irregular. Ba, 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 ba. Have you? I'm sure some of you have felt it. The pulse will be going boom, 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 boom. By the time you do that, this is what you are seeing. So this is not a sinus rhythm. Question. Your forehead is furrowed. You have a question. Is it clear? If we check this RR interval, is it regular across all of them? This one is very short. This one is very long, Abi. So it's irregular. And also we cannot see any P wave very clearly. Can we see any P wave here? So the combination of those two is equal to a rhythm, what you call atrial fibrillation. And atrial fibrillation is very important in causing stroke. Very, very important in causing stroke. Anybody like this must be treated. So it's clear now. If you have any question too, we have consultants that can come to you and break it down for you if you need special this thing. All right. Next, I need somebody else here now. Lady, center. Yes, yes. Don't worry. Look away. No matter what. Aha! You know I'm talking to you. Give her. See her now. Don't worry. Let's clap for her. Woo! Eh? Don't worry. You can sit down. Go ahead. No excuse. Sinus rhythm or not?
It's not a sinus rhythm.
It's not a sinus rhythm. How did you arrive at that? What's the rate here? Is 3 Abi or thereabout? 1, 2, 3 and some. So it will be about 80 something. So let's say 3.5. 300 divided 3.5 will give you about 80 something. All right. So what's the rhythm? First question. Answer now.
Not a sinus rhythm.
All right. So based on what?
RR interval is not equal.
RR interval is equal now? No. Is equal. See, look at this place down. This is our rhythm strip. RR interval virtually equal across all of them. Similar. Okay? So equal. No, second question. You read your notes. The notes you wrote. You can see why you have to write. What's the second question?
There's no P wave. P wave.
Upright where?
Upright in lead 2.
So where this lead 2 Abi, is it upright or facing down?
Upright, sir.
Upright. Fantastic. In AVR, is it upright or facing down?
It's facing down.
Correct. So question number 2 passed. Question number 3.
QRS interval.
QRS. Is there a P wave before every QRS?
Yes.
Yes?
Yes, there is.
Is there a QRS after every P wave?
I'm not saying. No.
See P wave, QRS, P wave, QRS, P wave, QRS, P wave, QRS. Is there any P wave you can say does not have a QRS after it? No. All the P waves have a QRS after it. So it's fine. Final question. Do all the P waves look alike? Yes, they look alike. Is it sinus rhythm or not?
Sinus.
Awesome. You see? Thank you for putting. I put you on the spot, Abi. You will never miss it again. Anybody? I don't understand. Just raise your hand. I don't understand. Good. Everybody understands. All right. Going deeper. deeper. Yes. Sinus rhythm or not? Please pick anybody you like. Pick anybody you like. Anybody want to try? All right, go ahead, ma. Question 1. Talk now, or sir. Talk.
Okay, so from what I can see, the eye interlocks are not really regular. I counted 1, 2, 1, 2, then further I'm
correct.
Counting.
So it's not regular, Abi?
Yes.
So it's not sinus rhythm. What? Let's go on. P wave for every QRS. Is there a P wave for every QRS? Yes, more or less. Is there a QRS after every P wave?
Yes.
Is the P wave upper in lead 2 and inverted in AVR?
Yes.
Do all the P waves look alike?
No.
Correct. That is the clincher. All the P waves do not look alike. This one is more rounded. This one is more sharp. You get or go? Abi? This one, his head is round. Away match, Abi? So, and you see that all the ones that the head is sharp, they look alike, Abi? And they are the ones that are making it not to be irregular, not to be regular. Can you see this sharp one, sharp one, sharp one, sharp one, sharp one? The same person, the same adulterer, Abi, is the one bringing, but that's why all the children are looking alike. Meanwhile, the other one is coming normal. This one spoils it, normal spoils it, normal spoils it, normal spoils it, normal spoils it. So this P wave comes from where? P wave, P is equal to? So when we see an abnormal P, it's coming from where? Atrium. So that is an ectopic atrial beat. Say it, ectopic atrial beat. That is why it is looking different from the normal one. It is sharp like that. This is an ectopic atrial beat. That is why it's giving us this abnormal rhythm. It's coming from the heart, all right, but it's coming from another side. It's not coming from the main place. It's not coming from the SC node. All right. Is it confusing a little bit now? That's yeah. That's why sometimes you need to refer. All right. Is that clear so far? Clear so far, not so. But you can read this one now. All right. All rhythm problems should be referred to a specialist after the initial care. All. So, remember what we said? If it's not regular and there are no P waves, we are dealing with what? Atrial fibrillation. If it's regular or not, and you have multiple P waves, we are dealing with atrial flutter. Okay? Now, these other ones are emergencies. In ventricular fibrillation, you can't even bother about all of it. It's so fast, and you're just seeing things that look like jaga jaga. If you see that on your screen, if you look at the patient, this is what you see the patient doing like this. If you don't see that, maybe your wire is disconnected. That's the other reason. Otherwise, this is a cardiac arrest rhythm. You need to shock immediately. That patient is going to die. We had this 2 weeks ago. I believe Victor, 2 weeks ago. Took a patient, acute MI, very sick. A foreigner came in, rushed into the cath lab. As we just tried to open the vessel, bam! The heart rate just had this complete heart block. This complete heart block became very slow, not regular. Heart rate went to 40, so we put in a temporary pacemaker. Stabilize first. Before we know it, next thing we saw this jaga jaga. Then we turn to, immediately you see jaga jaga, there are only two things that can happen. Either the person is about to die, or the wire is off. We turn to the man and it was like this. So what do you do next? What do you do? AED, say AED. Abi, well, that's for you. For us, we don't use AED. AED takes too long. Put it, analyze it. Waiting. We have already seen the rhythm, we can analyze it. Time to shock determines life. Remember? So immediately, less than 5 seconds. Bam! Everybody clear? Bam! The man came back. I said, what's happening? He's feeling some pain on his side. I said, no, nothing happened, nothing happened. So now you are in the ICU or in the ward, and you see the heart rate going to 150 very fast. You see it's regular, and the QRS is wide and busy. It's a matter of time. You must recognize you are doing dialysis. You must recognize it. You are about to do what they call it, physiotherapy for somebody that is very sick. And you look at the ECG, and you saw this one, oh boy, run, oh, now you kill him. Not run. Call for help and start. You are ACS. Okay, so very important. So have we got this so far? So reading level. What is the reading here? We must go deeper. Who can I give now again? Who can I trust? Why am I always going here? Somebody is pulling me here. Let me come here. Yes, Dr. B, Mama. Yes. What's the reading?
Okay. Reading 1, 2, 3, 4, 5. That's 5.
That's for the rate, Abi?
That's for the rate. 5 divided by 300 divided by 5.
That's 60.
That's 60.
Right.
That would be the rate. And then for the reading, the first question we want to ask is RR interval. Are they
equal?
Are they equal? I think yes, they are. And then the next question we want to ask is there P wave before?
The P wave upright?
Upright in lead 2.
Is it upright?
No, it's not
What
upright.
about here? Is it upside down here? It's facing upright.
It's facing up.
Not reading, Abi? Not sinus.
It's not sinus.
Is there a P wave before every QRS?
QRS.
Every time there's a QRS, is there a P wave?
Yes, there is,
Correct.
but there are multiple P waves.
Multiple
P waves.
Thank you very much. Multiple P waves. What did we say that is? Atrial flutter. So this is atrial flutter. Multiple P waves. I saw this patient being seen. Nobody recognized this. And without this patient, will never get better. I think we delivered a shock for the person to get better. Do we understand this? I should go right again. RR interval. Are they equal? Are they equal? They are. Fine. Is the P wave in lead 2 upright or upside down? Upside down. Abi? It's supposed to be upright in lead 2 and upside down in AVR. In AVR is facing up. So it's doing the rest, so there's a problem already. Abi? So it's not sinus rhythm. At least you should be able to say that it's not sinus rhythm. If you've gotten that one, we are already happy. Okay. Now, before every QRS, is there a P wave? Yes. Abi? QRS is a P wave, but after every P wave, is there a QRS? No. P wave, no QRS. P wave, no QRS. P wave, no QRS. P wave, QRS. P wave, no QRS. P wave, no QRS. P wave, no QRS. P wave, QRS. Can we see that? So this is how we arrived at the atrial flutter. And this is what we call a 4-to-1. It takes 4 times of the atrium to contract before the ventricle will collect 1 and send. Question? If you have a question at the back, just raise your hand. Dr. Adefila is there. Dr. Inowa is there. They can come directly to you and then come and explain to you if you are too afraid to talk publicly. All right. Isn't it simple? The yes is going down. Oh. So far, is it simple? You know the rate, right? You know the rhythm, right? So what are we talking about? What about this one? Let us go deeper. Yes, ma.
I said I can't make out the R.
What's the rate?
Maybe like 2.
300 divided by 1.5.
1.5.
What would that be? 200 or so, Abi?
Less than 150.
No more than 150.
300 divided by 2.
300 divided by 2 is what? 150. However, this is less than 2 now. It's less than 2. So this rate is going to be higher. It will be like 200 at least. 300 divided by 2.5 is what? 1.5 is 200, Abi. So tachycardia, this person is about to die. If you saw this on your monitor and you did nothing, you are part of the problem of Nigeria. Hello? Nothing like calm shift. The ship was not calm. If you saw this and you did nothing, so correct now. So let's continue.
So I'm going to look at lead 2 to check the P waves. Okay. The P waves are not really clear, but they are not looking upside down either.
All right. What do we think? Are there P waves there or not? Are they upright or facing down? All right. So let's look at it together. Can we see it here? Small, Abi. Small, 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 small. Can we see that? So before every QR is there a P wave? Hello? Before every QR is there a P wave? In AVR, we cannot quite see it. You are right. You can't see. But in this lead 2, we can see a small notch before it goes, Abi. This QRS is also wide and bizarre. This QRS is also wide and bizarre. So we have a very fast heart at 200, Abi. And we have wide QRS. So let's go back to that our table. Very fast, regular, no P waves, or sometimes we saw P waves. Wide QRS equals to what? Emergency ventricular tachycardia. What you have 2 options in this case. We're going to ACLS. You need to remember this thing. That's why I'm going over it again. If the person has a pulse, you need to start IV drug immediately, or that person will die. Sometimes you don't even have enough time to call the doctor. That is how much, or to call the consultant, or to call somebody. If the person has no pulse, you need to shock. You're not waiting for the person to stop breathing. No, he's still breathing first. I can't feel pulse, but, okay, are you alive? All right. So let's go on. We have spent time. So what rhythm is this? V-fib. V-fib, I said, is what? Like Jaga Jaga, Abi? Everybody Jaga Jaga. Who remembers Idris song? V-fib, rapid. What must you do in a V-fib? What must you do in a V-fib? Shock. Just shock immediately. And I gave you a story. I'll leave all of this one. Now, step 4, QRS. So far, do we understand it? Perfect. If you don't understand it, it's trauma. What we have said today, you understand it, Abi? Leave the remaining. Today, so far, you understand it. And if you are writing, you are following us. We're going to go into deeper ones now. In the QRS, we said QRS is what? QRS is what? QRS equals to what? Ventricular contraction. So in the QRS, we are looking whether it is narrow or wide. First. If, and I said remember the heart, if this thing is wide, it means it took a longer time for that electrical impulse to go around the heart. And there are 2 reasons why it will take a longer time. One, there is a block in the wire going around, or the heart is too big. Not so? So are the only 2 reasons. So if it takes you 6 hours to go from Abuja to Kaduna, so that there's a block on the road, Abi, or they'll move Kaduna further. Those are the 2 reasons also. So anytime we have QRS that is wide, we have either a block, or the person will become further, or we are dealing with an emergency that is causing a problem. So every time we say it's narrow, 3 small boxes, or broad, more than big boxes. Then we look at whether it's high or low. Now this is where we're getting a little bit tricky. If it is more than half a big box, it is wide. QRS, what's normal QRS size? Half of a big box. Again? Please, how big is a normal QRS? If it is bigger than that, it is wide. It is wide. Fine. Now we look at whether it is high or low. And that high or low is to see how much. So if the ventricle has a lot of muscle, where will it be, high or low? What do you think? High, because it's generating a lot of electrical activity and also it has more muscle. So higher muscle, higher. Hello? Higher muscle, taller, be very simple. Smaller muscle, smaller. So we now have two types of ventricular hypertrophy. Hypertrophy just means the muscle is thick. Two types, right or left. Please write it down. Right or left. For right ventricular hypertrophy, we simply come to lead V1, sorry. We simply come to lead V1 and we look at the QRS. In this lead V1, is this QRS facing down or facing up? Down. If it's facing down, there is no right ventricular hypertrophy. If it's facing up, there is right ventricular hypertrophy. Is there right ventricular hypertrophy here? Where is he facing? So is there right ventricular hypertrophy? Where is this one facing? Is there right ventricular hypertrophy? Very simple. Do you understand that? Write it. V1 facing up equals right ventricular hypertrophy. V1 facing up equals, we are adding on top. Right. Up. V1 facing up, right ventricular hypertrophy. Like this one now, facing up, right ventricular hypertrophy. Those people that come with PE, that's what we're looking out for. Those people that have real pulmonary hypertension, that's what we're looking out for. Anytime you see V1 up, that ECG is abnormal. Hello? Is it simple? Some people say no. Do you know the difference between up and down? Is up and down simple? Is this up? Up equals? What is hard there? Or I should go for deeper ones? No, this one is okay. What is hard there? Okay, now let's go to left ventricular hypertrophy. That's one that is a little bit hard. In left ventricular hypertrophy, we simply should I bother? In left ventricular hypertrophy, we come. Are you all with me? These are abnormal beats, so leave this one. We take this wave here, QRS. We take this wave here, this wave pointing down, which is normally pointing down. How many big boxes are here? 1, 2, 3. Then we come to V5 or V6. Which one is taller between V5 and V6? V5. How many boxes are here? 1, 2, 3, 4. 4 plus 3 is what? Anything 7 and above, left ventricular hypertrophy. You don't understand? I'll go over it again. Don't worry, just be calming down. Do like this. Pointer. Oh, for the photos are fine. Again, V1, the one pointing down in V1 and V2, we count the number of big boxes. V1 or V2, which one is taller? They're about the same, Abi. So we take how many? 1, 2, 3 big boxes, Abi. V5 and V6, which one is taller? V6 is 1, 2. V5 is 1, 2, 3, 4. So V5 is taller, not so. 1, 2, 3, 4. 4 plus 3 is what? Anytime you combine V1 or V2 plus V5 or V6 and it's 7 or more, the left ventricle is hypertrophied, is big. If somebody has hypertension and has that, that is a risk factor for a lot of problems. Again, V1 or V2 plus V5 or V6, the QRS, if we add the number of boxes there and it's 7 or more, we call that left ventricular hypertrophy. write it. I know it's on your paper. I know it's on the slide. I know you get the slide. But if you don't write it, you shall not read ECG. So write. I don't understand. Raise your hand. Somebody will come to you. I don't understand. I need special explanation. Somebody will come to you right now. Just raise your hand. Somebody will come to you. Fantastic. Right ventricular hypertrophy. Sir, what's right ventricular hypertrophy? Right ventricular hypertrophy. So what is right? V1 is up. This one is SR cardiology, no. What is left ventricular hypertrophy?
So when you calculate the boxes in V1 or V2 and add it to those in V5 or V6, if that's greater than 7, that's left ventricular hypertrophy.
Fantastic. Fantastic. So let's go. I'll leave this one for now. Is there right ventricular hypertrophy or not? Hello? V1 is pointing up or down? Up V1 is what? What is so hard in ECG, for God's sake? Not so hard. Oh yeah, go to diagnosis center, start reporting. Sign. Certificate ACS 2025. Okay, if police catch you on your own, sha. So I'm going to go deeper a little bit now. Hey. Should I go to bundle branch block or should I leave it alone? Is that no or yes? Okay. Oh. All right. So what have we learned so far? We have learned rate. We have learned rhythm. We have learned what? QRS, when it is wide or when it is narrow, and when it is tall or when it is short. We have learned right ventricular hypertrophy, which is what? When V1 is facing which direction? Up. And we said we have learned left ventricular hypertrophy, which is what? V1 or V2 plus V5 or V6 greater than 7. Fantastic. Now we are going back to whether it is wide. Anytime the QRS is wide, there is likely to be a block. Or very big, Abby. But in this case, let's take it for the block. And those blocks may be left bundle branch or right bundle branch. Now, how many people can remember that our ECG? I don't have the diagram again. Remember, it's coming from the AV, from the SA node, right? Goes down the ventricle, right? Goes to customs. AV node is customs, not so. Waits there for some time. Then goes to the left and to the right. When it is blocked on the right, it gives a different pattern. When it is blocked on the left, it gives a different pattern. That is the difference between left and right bundle branch. This is the pattern. Those that have tried to go to the US, I've tried before. I changed my mind. That's why we are here. If not 2005, 2006, I just felt that there was no point. If not, there will be no ECS now. Those that are going to US, they will ask you this question in the USMLE. They will ask you. And this is the, what they call it? The mnemonic. So let me teach you this mnemonic so that you can remember. William and Marrow. Say William and Marrow. Dr. Fortune, you know that ECG well, though. That was the left bundle branch block. I didn't want to spoil your show. This is V1. This is V6. In V1, we will see something that looks like a V or a W to be wide. And in V6, we see something that looks like an M. That is a left bundle branch block. First of all, QRS is prolonged, Abi. Hello? QRS is prolonged, likely a bundle branch block. Yes or no? Now, in V1, we'll see something like this. In V6, we'll see something like this in the left bundle branch block. In the right bundle branch block, in V1, we'll see something like this. In V6, we'll see something like this. Now, let's go. Let's enter the thing now. Does this look like an M or an R? M or a V, sorry, or a W? M? M. M, R, this is a V sharp, but W. Marrow. M in V1, V or W in V6, marrow abi, right bundle branch block. Till tomorrow I still use mnemonic. In V1, is this looking like a V or an M? V, William. And in V6, is it look like an M or a V? M. So in V1, V or M or W. In V6, M, William. That is a left bundle branch block. Don't worry, hold on. We have seen it before. In this one now, what can we see? What can we see? Here, is this M or V? M. Here, is this a V or what is this? Or a W? V, Abi? So what is this one likely to be? Right bundle branch block, Abi? M for marrow, Abi? Right bundle branch block. Hello? I need you to understand this very well. The reason you understand this is simple. Hello, just listen to this. Calm down, listen to this. Don't get confused. Sometimes, acute MI, like in that patient he presented, comes as a left bundle branch block. Not like anything else, just left bundle branch block. And you must treat it. Patient chest pain, and you see left bundle branch block, it's an MI. So let's look for another one. Let's see. Do I have any? Well, I can't find the left one, but I didn't put one here. Sorry about that. But I'll just move fast like that. All right. Step 5. We want to do more on that one, Abi. We'll do it later. In left bundle branch block, the only difference is that this M you are seeing here will be here, and this V you are seeing here will be there. That's the difference. I'll find one for you later, don't worry. That's the only difference. This thing you are seeing in V6 now, it will be here, and this thing you are seeing in V1 will be here. That is the difference between left and right bundle branch block. No other difference. Which is why I showed you that marrow. No other difference. Sorry, I thought I had a slide on it. Okay, let's go to ST segment. Hello? Don't worry. We are getting to the end now. We will use a lot of examples and we will catch up on everything now. You will see that everything is so simple. I'm going to put everything together now. If you have been following till now, don't lose heart. In a few minutes, you will see that your eyes have been opened. Just a few minutes. Give me a few minutes. Now we are in ST segment. This part between QRS and T is ST segment. This part between QRS and T. Hello, stop talking though. Just listen for now, please. Between QRS and T is ST segment. This is very critical. This ST segment, we are not looking whether it is up or down. In comparison to this line. See the general line. Can you see this general line? Whenever this line goes up, we have an ST elevation. If the person is having chest pain, you have a heart attack. You must see it. The nurses in our hospital can see it. A lot of them, all of them, yeah. Can you see it? A lot of them can see it. You are doing a procedure, somebody will say, sir, ST elevation. Maybe that is some, you'll be able to recognize it before you can see anything. Okay? So all we are looking at is in this ST segment, is it up or is it down? You know the difference between up and down, Abi? So so we look at it here. This is the okay, so QRS, just one small box there we assess at that point. Is this up or down? Is this up or down? Shashikena? If it is down, we call it what? ST depression. If it is up, we call it ST shaking. If it is up, ST elevation, MI. Abi? Now we said it must, two people must agree. For a matter to be confirmed, how many people must agree? But not any two people. The two people must be in the same region. So let's go on. We'll leave that one. What can we see here? Is this up or down? So this is the line. Can we see the line here? That's the line, and it's above the line, up. If you see it in 2, where else must you see it? In where? 3 and AVF. 2, 3 and AVF represent which part of the heart? Inferior. 2, 3 and AVF elevation, inferior ST elevation, MI. Hello? I should go right again. Remember those things we wrote down before. Can you go back to that page where you wrote it? Where we put the list that must talk together. Which ones do we say are lateral? V5, V6. So if we see it in one, we must look for it in, somebody else must agree with it. Between AVL, V5 and V6. In this case, we saw in 2. So where else must we see it? 3 and or AVF. Is it here in 3? AVF unko? If we see it in V1, where else must we see it? V1 and V2 is for which one? V3 and V4 is for which one? So we can see anterior and we can see septal. Can we all see that? Okay. It's simple, not so? Sir, it's simple, Abi. What we have said is simple. Forget about ECG. What we have said is simple, not so? Ma? Good. All right. I can never forget this patient. NSCDC man. Slender guy. Good looking. 45. About 10 years ago. I've been around for a while. I know I'm looking young, Abi. All right. Yes? Somebody? What is the rate? Who should I give now? Dr. William. My friend. Dr. William of my class was my roommate at the time.
Okay, the rates, the RR interval, we have
1,
2, 3, 4.
4.5.
4.5.
So that's like what? Like 80 or something?
Yeah, something like 300 divided by 4, 75 or
correct. So, what else? Reading?
The reading are all the RR interval, are they regular?
Are they regular? Correct.
The P wave, is it upright in lead 2?
Is it upright?
And inverted in AVL?
Is it inverted here?
Yes.
Correct.
So the reading, then are all the QRS complexes, are they preceding a P wave?
Is there a P wave for every QRS? After every P wave, is there a QRS?
Yeah.
What's the reading?
Normal reading.
Correct. Now, we went on to the next thing. QRS, Tabi. V1, is it up or down? Is there right ventricular hypertrophy? Okay. What about V2? V1 and V2 is taller.
V2.
1, 2, Abi?
Yes.
V5 and V2 is taller.
V5.
3, 4, 5, 6. Is there any hypertrophy?
No.
Correct. Now, ST segment. Is there any ST segment elevation or depression? Yes. Where?
V2.
Lead 2.
Lead 2.
So where else will we check?
3 and 8.
So what is this? ST elevation MI in the inferior lead. So inferior STEMI. Even me, I did not, because the man was looking so healthy. If not for protocol that made sure we do ECG for everybody with chest pain. Can we see that? Everybody that has ulcer must have an ECG. Everybody. The other people that we have seen, some brought in dead, some brought in and died within 30 minutes. Treating for ulcer for 2 weeks. Please. And most times, inferior MI, because it's inferior, inferior means below. It can feel like epigastrium. And you know the funny thing, the wicked thing, when they take antacid, they may feel a little bit better. That's even what makes it worse. All right, so did we all see this? Or should I go over it again? Should I go over it again, ma? What do you want me to go over? William Amaro. Okay, we'll get to William Amaro. But ST elevation, can you see the ST elevation here? Where? Two, 3, AVF, Abi. This is the line that you're supposed to follow and see it above that line. This is an MI. Nobody should miss it again. All right, I'll leave this one. I'll leave this one too. Okay, let me stay with this one. Q wave. This is the final, more or less, almost the final one. Q wave. Q wave is the first negative deflection after P wave. Remember, I will say PQRS. But anytime that Q wave is very big, there's a problem. There is a problem. So let's look at the P wave. Q wave. If you see a P wave like this, and you see nothing that goes up before it, what you have is a Q wave. And anytime the Q wave is big like this, that person likely has had an MI. I remember this patient. It's an Indian woman. She didn't make it. I remember. It's about 9 years ago. Why is there? First of all, we can see Q waves. Oops. We can see Q waves. After P wave, there is nothing that goes up. Can we see that? Here, is there a Q wave? No. Can you see this small thing that went up? Can we see that? So it's not a Q wave. P, there's hardly any Q, R, so this is an S wave. RS. In this place, nothing went up, so this is Q. No significant R or S. So as soon as we saw this one, is there an S elevation here or not? Hello? Any S elevation? So let's take it. Look at this line here. Is this elevated or not? Can we see that? Is this elevated or not? Here too, is it elevated or not? Here too, is it elevated or not? Correct. So this number of Q waves here, and even here that is looking almost, this is a Q wave too, told me that it's an extensive MI. That time we didn't have any cath lab, there was nothing. She said, I'm going to India. Went to India, all the vessels were blocked. She refused surgery, hoping for divine healing. Okay? So I remember her, I can never forget. I can never forget. All right, and the final one, T wave. In the T wave, what does T wave equals? Relaxation. And all we are looking at is whether the T wave is up or down. Shebu no up and down, Abi? Good. So, up or down. Don't worry about this big grammar. The T wave typically is up in all the leads except AVR. Is there any T wave that is facing down here? Can we look? Any T wave facing down in this ECG? Yes. Any T wave facing down? V6. If you see something in V6, where else must you look? V5. And where else? V1 and AVL. Not V1, no. 1 and AVL. So, as you saw that V6, next to your place you go, should go. Is it up or down? This T wave, is it facing down or is facing up? Down, correct. V5, V6, where else will we check? 1 and AVL. AVL, is it facing up or facing down? AVL, is it facing up or facing down? And that is not supposed to be. So there's a problem there. And it's in the same area that is telling you that there's a problem with blood supply to that area. All of them. What area is that? Lateral. We are finished with the ECG. Clap for yourself. Clap now for your. I'm not clapping for you now. You clap for yourself. Now, are there deeper levels? Yes. Are there how to read ECG when there's a pacemaker? That one is for my friend from Sokoto. That one, he will struggle. All right, so we are finished. Now we want to do, remember what I said, if you don't exercise, you will forget. In fact, if you don't exercise between today and Monday, you will forget everything. By Monday, it will be like a new thing. What is this you are talking about? But some of you will not only exercise, by tomorrow you will gather some people together, maybe your gatesmen, and give them food and sit down and start teaching them. Just to make sure that you remember. If you do that, I guarantee you, for the next 5 years, you will never forget ECG. So let's do a few, then you do 20 by yourself at home. And you have a book where there are some ECGs. T wave is up. When T wave is up, that's normal. It's only when it is facing down that's abnormal. But in AVR, it's the opposite. Okay, so let's use what we have learned. Yes, can anybody try this ECG? You're about to sign an ECG out. You just came from ACS. Your CMD is telling you, somebody is here. Your CMD say, come and prove yourself. Please. We are about to have a certified ECG provider from our Primary Cardiovascular Society of Nigeria. Go ahead. Our 6 steps now. And that's how you're going to write it on your report when you sign. Step 1.
Identify the name and calibration.
Identify the name and the calibration.
Check for the rhythm and the rate. Sorry, rhythm and P wave.
All right, so?
There are 4 large boxes between the RR intervals. Okay.
1, 2, 3, 4. Okay, don't worry. 75, 80, same thing.
Okay.
300 divided by 4 is what?
75.
Correct. Next. Rhythm.
Check rhythm. Normal.
Sinus rhythm or not?
Sinus rhythm.
Based on what?
RR interval.
Is regular. What else?
P wave is
upright and upside down.
Yes.
After every P wave there's a QRS. Before every P wave there's QRS. Fine. Next. QRS, Abby?
Yes, QRS.
QRS, is it widened?
No.
So QRS, it should be, how big should a normal QRS be? Half of a big box, which is correct?
Yes.
Okay.
Then for ST segment?
No. Is there hypertrophy? Is there right ventricular hypertrophy?
No.
Why do you say there's no right ventricular hypertrophy?
The V1 is...
V1 is pointing down. Good.
Yes.
Is there left ventricular hypertrophy?
No.
No. 1 plus 2 or so, I mean, doesn't reach heaven. Yes? What else? ST?
ST, there's ST elevation.
Elevation where?
Lead 1. Sorry, lead 2.
Lead 2. Where? Here?
Yes.
No. So see this line. Can you see my line? Line. It is only when the T wave is coming up that it went up. So just when the T reaches here, at this point, it's still very much. And if you're not sure, go to the brothers. In the brothers, is it there? No. In this brother, is it here? No. So it's very likely that nobody else saw it. You're doing well. You're doing very well. You're about to sign. You're not finished signing now. T wave now. Q wave. Is there any Q wave?
No.
Any Q wave? Are you sure? Very tiny, but it's not significant. Okay, what's the last one?
T wave.
T wave. Any T wave that's upside down. AVR is supposed to be upside down. Any other place? Look very well.
No.
Eh?
There is no.
This T wave, is it facing up or facing down? Down. So it's upside down there.
Oh, I cannot see it. It's blocking.
V1, Abi?
Yes.
But there is, who else must see the same thing?
V2.
Is V2 doing that?
Yes.
No, not really. So we'll just keep it down. But we'll write it that there's a T, but it's not really significant in this case. So can we clap for her? She has signed out her first ECG. Woohoo! Yeah, I told you if you can read, you write. All right. Again. Don't run. This man looks like a serious person. No, that's why I saw him. When you know what's going to ask you a question, look at the person straight in the eye. If you look away, they will call you. What are they looking? Hope you are doing fine, Abi. Go ahead now.
So, I'll first start with the rate.
You don't enter today.
The rhythm is irregular. Let me start with that.
Okay, so it's not sinus rhythm.
It's
What
not
rhythm
sinus
is it?
It is irregular.
Oh, we know it's irregular. If my son knows it's irregular. Media person, you're going to read ECG now. Get ready. Just to, it's my experiment to see whether it's working. Talk now.
Atrial fibrillation.
Likely atrial fibrillation.
Yes.
Although some people will argue that it could be atrial flutter, but for the sake of this class, atrial fibrillation. Why do you say atrial fibrillation?
Because it is irregular.
Because what? Why do you say, when you say atrial fibrillation is in two things? No P waves and irregular. So in this one we are seeing now, can you see any P wave here? No P waves. And are the RR regular or irregular? So atrial fibrillation. Fantastic. You see?
Then the QRS It is not.
Is it wide? Is the QRS wide? Is it more than one big? No, look at here. Is it more than half of a big box? Not quite.
No, it's not. It's narrow.
It's narrow. It's narrow. Not quite. Yes.
It's narrow. Then there is no right. There is no.
Is this facing up or facing down?
It's facing down.
So is there right ventricular hypertrophy?
No.
What about left ventricular hypertrophy? Is there left ventricular hypertrophy?
Yes.
How do you know?
Because it is. If you add
1, 2, 3, 4, 5, 6, 7, and 8. Okay,
it's
fine.
more than 7.
So is there left ventricular hypertrophy?
Yes.
Perfect. What else? ST.
ST segments.
It
is not elevated.
But I like that. Correct. So I know some people think it's elevated, Abi. It's slightly elevated here, really. V2 and V3. Which one V3 must communicate with which one? V4. Is it elevated in V4? No. V2 must communicate with which one?
V1.
Is V1, is it elevated there? So even though it is slightly elevated in V2 and V3, this is likely not to be very significant. This is likely not to be very good. But if you are not sure, send for help. To the group. When you send to the WhatsApp group, we don't answer ECG anyhow. Not going to make money on my head. You will send it to you will report it. You will report it based on the way we have outlined it. Then we will now correct you whether you are right or wrong. That's our rule in the group. If you don't report it, we will just delete you from that group. You want to use my head. And it's an emergency, don't put it there, I'll go sleep. Well, it's not only me, there are about 5 of us. So one of us will report it. Okay, great.
Then the final step is the
Q wave.
The Q wave.
Is there any Q wave? There appears to be here. If there is Q wave in lead 3, where else will we be looking for Q wave?
4.
Lead 3.
Lead
2, no Q wave. What about AVF? Not quite. So maybe we're not put too much into it. What about the last one?
Then the T wave.
T wave. Anyone that is upside down?
Yes.
Here. This one, is it facing up or down?
Down.
Down. But is it like that in the other ones? Not quite. It's flat a bit. Maybe a little bit down. So maybe there is something going on in this inferior lead. But we'll just talk about that. So now you sign ACS 2025. Can we clap for him? Is the ECG not easy now? What we have taught today, is it not easy? Leave your trauma. Today on, is it not easy? Mark, can you read ECG? Sir, can you read ECG now? Small. No. This one we have taught. We can read it now. Do you want to try this one? You don't want to try? That means you will try. All right.
So first of all, you check for the name and the calibration. And
so the way we normally check calibration, if you look on this ECG, can you see one small square that is going up like this?
Yes.
So that square should occupy 2 big boxes. That temperature is high enough. Very important. And it should occupy 1 big box on this direction, but we cannot see the full thing. So very important. Yes.
Okay. Then after that, we check the rate.
So what is the rate here?
1, 2. Sorry, I said from the other second one. 1, 2, 3, 4.
Okay, so what's the rate?
Was 75.
Correct. What's the reading?
Is it regular? No, it's not regular.
Is it we're not saying whether it's regular or not.
Sorry.
We are saying, is it a sinus reading or not? Is this a sinus reading or not?
It is not a sinus rhythm.
Based on?
The R and R intervals are not regular.
They are regular. R to R to R. No, that one,
yes.
maybe the person shook a bit. R to R, all these were regular, not so?
Okay, yes.
Correct. What's the next question we ask ourselves?
Is the P wave upright in lead 2?
Is this facing up or facing down?
Yes, it is. And inverted in AVR. Yes,
correct.
It is. Then are all the QRS complexes preceded by P waves?
Yes.
Yes, they are.
Is there a QRS after every P wave? Do all the P waves look somehow what I like? Sinus rhythm or not?
Sinus.
Yes, it's very simple. Now, when you are reporting, you will not write all these things, so that one is for us. You will just write rate 75, normal sinus rhythm, QRS. That's how you report it. Don't give out all your secrets. This is my secret. I did not teach you everything too, so that you can refer some things to me, my job too.
Are there, so is the interval between R and R irregular and are the P waves absent? No. The P waves are present. But and the intervals are regular as well, so there's no atrial fibrillation.
Correct. So we are finished with that one. It's sinus rhythm we have said. So now we go to what? QRS.
QRS.
QRS. Is the QRS prolonged?
No.
Is it prolonged?
No, it is not.
It's not prolonged. All right. Is there right ventricular hypertrophy or left ventricular? I remember this guy. He works in telecoms.
Yes, there's right ventricular hypertrophy.
How? Are you sure?
Yes.
Are you very sure?
Yes.
Are you sure?
Yes, sir. The QRS is facing up.
Where?
In V1.
In V1 is facing up, Abi? Can we all see that?
Yes, sir.
Facing up, so right ventricular hypertrophy. Okay, what about left ventricular hypertrophy?
Then for left.
Virtually nothing facing down. This one facing up, nothing there, Abi?
Yes, sir. So
correct.
There's no left.
What is next?
Then
ST.
ST, elevation. Or
is there anyone facing up or facing down?
There's ST depression.
Where?
V3.
She said V3. If we see in V3, which is correct, where else will we be looking for?
V4.
Is it there too?
Yes.
Correct. Where else is there ST depression? V2, Abi, is depressed. If you see in V2, where else are we looking for? V1, is it there? Yes. Correct. So we have right ventricular hypertrophy with ST depression and T-wave inversion. T-wave, Abi, is it facing up or down?
Down.
All the way. Is it facing down here too?
Yes,
here
sir.
too, here too, here too, only V6. So all the way. This is very classical sign of pulmonary hypertension. The right ventricle is dilated, is enlarged. Whenever I saw this man, I said, you have this thing. The man said, how do I know? All right.
So
Q wave, any Q wave? No Q wave, Abi?
No.
Perfect.
I want to confirm, when ST is depressed, what is the interpretation?
So when ST is depressed, it actually means there's what we call a relaxation or repolarization abnormality. It could be a number of things. The first thing that it could be is that there's ischemia to that region. It's not infarction. Depression equals ischemia. Elevation equals infarction. MI. So the first thing we think about is that is there ischemia to that region. The second thing we think about, if there's associated ventricular hypertrophy, is if the heart is under a lot of strain, because the muscle is so thick, when it contracts, it's unable to relax so well because of too much. You know, those people that do bodybuilding, they're always working like this because their heart cannot relax. So whenever we have hypertrophy and we see that sometimes it's just strain on an enlarged heart. So those are the two common things. Now there are other things, from electrolyte derangements and the like, but let's leave that one. Okay? Thank you. So you can sign now, Abi. Aha. Isn't this simple? Hello? It's not simple. It is. She said it's this quickly, so I will not call her. Yes. Somebody should volunteer for the next one. We are rounding up in the next 3 minutes so that we can take lunch and UMAT. Then we'll come back and do ACLS and ACS. Yes, please. Shoot. Besides.
Yes, sir. So, for us to check whether there's left ventricular hypertrophy, must the QR segment be inverted in V2, V5, and V6 for us to detect that?
So we are doing S. Remember, it's QRS. We are doing S in V1 or V2, which is the one pointing down. So this S pointing down, there's hardly any S here, Abi. This one pointing down is just 2 boxes. Not so? Then the one that is pointing up, which is R, is how many boxes here? 2 boxes and 1 box here. So we are adding this one pointing down here plus this one pointing up in V5 and V6. That's what we are adding to get whether it is 7 or more. So that's how we arrive at it. All right, I need a volunteer for the next one. Volunteer? Thank you. I love that.
Okay, so to check the rhythm, first of all, the RR interval. There are multiple P waves.
What's the rate first?
The rate, 1, 2.
So if you see that the RR is not regular, pick the one that is the most regular and use it on the average. So what's the rate of this ECG?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11.
This is PQRS. PQRS. So between here and here.
Okay.
1, 2, 3, 4, 5, 6-ish. So about 50 something, Abi. 300 divided by 6 is what? 300 divided by 6 is what?
About 60.
About 50, 60. Okay, good. So that's the rate. What's the rhythm? Is it sinus rhythm or not?
So this is not sinus rhythm.
Why? Are you sure?
Because QRS, there are some QRS, the P waves are missing in some of them.
Okay, so we have a P wave for every QRS here. P wave is upright here, Abi, and inverted here.
Yes.
But now we have P wave, QRS, P wave, QRS, P wave, QRS, QRS, no P wave. Abi?
Yes.
We have another QRS, no P wave. We have another QRS, no P wave. On the other ones, we have more or less. So this is virtually a sinus rhythm with an occasional ventricular ectopic. So this comes in once in a while, and otherwise, then this comes in once in a while, and otherwise, this one comes in, and this one comes in. So this is a sinus with an occasional ventricular ectopic, an abnormal QRS here. Is that clear?
Yes, sir.
So predominantly this is a sinus rhythm, and then we say sinus with ectopic. Now this ectopic here and here, do they look alike? And this one, do they look alike?
No.
So they are coming from different parts. We call this a multifocal ventricular ectopic. But don't worry, don't go that far. Right now, sinus rhythm with ectopic beats. So when you are checking this pulse, it will be normal. It's doing boom, boom, boom. The something will just shake. Have you ever felt that before? You're doing boom, boom. The something will just shake a bit. You have to continue again. Hello, I want to go deeper now. Please listen, pay attention now. Whenever you see 3 of these abnormal ectopic beats ventricular together, we call that a ventricular tachycardia. Ventricular tachycardia is a combination of 3 abnormal ventricular beats together. And we can see a ventricular beat, a PVC, a premature ventricular contraction. It's coming premature without a P wave. Whenever we see 1, 2, 3 of it together, we call that a ventricular tachycardia. Write that. Let's take a second thing. And particularly for the nurses and the doctors in the ICU or in the theater, you are doing a case and you saw this thing. You can see one once in a while is okay. Once you see 3 together, it is now a ventricular tachycardia. You should be worried. If that abnormal wide, can you see that is wide and is bizarre? Is that one wide and bizarre? This QRS started from here and it ended. Is it more than one big box? Is it more than half a box? Sorry. Is this more than half a box?
Yes.
So it's wide. This one too. It started from here and it ended somewhere here. More than half a box too. So by the time you see those coming together, 3 or more, we call that what? Hello? 3 or more, we call that what? Correct. Now, when that ventricular tachycardia stays for more than 30 seconds, we call it sustained ventricular tachycardia. Sustained ventricular tachycardia. So again, ventricular tachycardia, 3 or more wide abnormal QRS beats. When they come together, 3 or more. Once it lasts more than 30 seconds, we say it's sustained. If it lasts less than 30 seconds, we say it's non-sustained. Most times before patients die, they will be showing these things on and off on their monitor. but people will be looking at Instagram or other things, or be looking at it and say this thing is fine. No? Please. Yes, ma'am. So go ahead. So we have done. So what's next? Yes.
So we've done the QRS now. You said that there's ventricular tachycardia from your explanation. We did when we have three or more
consecutive. 3 or more consecutive. That is 1, 2, 3 together at the same time, not one beat. Once there's a normal beat in between, it's not a cardiac again. Thank you very much. 3 or more consecutive. That is, if this thing happened 1, 2, 3, we will say, and it stopped. Would that be sustained or not sustained? Hello? Non-sustained, Abi? Sustained is more than how many seconds? So more than 30 seconds of that thing happening. Now this one just happened once and we had normal beats. So it's not consecutive. So this is just a ventricular ectopic. Hello? Thank you.
So we're going for the ST segment now.
We have done QRS. Is there a right ventricular hypertrophy?
No.
Is there a left ventricular hypertrophy?
Right. S1, 2, 3 in V2 and then V6.
So it's not up to 7.
There's no.
Correct. ST segment. ST segment.
ST segment. In.
Now, when you are doing ST segment, don't count ectopics. So don't look at the ST segment in ectopics. Leave that one alone. Look at the rest. Is there any ST elevation or depression?
No, there's none.
What about T wave? Any T wave facing down or facing up? Any T wave facing down, facing up is normal. Anyone?
No.
Are you sure? This one, where is it facing?
V5 and V6 too.
If we have V5 and V6, where else must we check? One and
AVL.
In AVL, is it facing down or facing up?
Down.
Down. In one, we can hardly see, but at least it's here. So there is something, it's a repolarization abnormality. In which set of leads are those?
In the lateral leads.
Awesome, awesome. Q wave. Any Q waves?
3.
Where? No Q waves. Q wave is the first negative deflection. This is like a Q wave. But remember, we don't use the ectopic to determine. These are the ectopic all the way. So this is what a Q wave would have looked like if it was a Q wave. There's no Q wave anywhere. All right?
What differentiates the Q and the S?
The differentiation is that there's a small upward stroke before it comes down. See this one, something came up before it came down.
That would be an S?
That would be an S. In the Q wave, there will be nothing going up to just come down immediately.
Okay, thank
That's
you.
the differentiation. Can we clap for her? Fantastic. I'm so happy. I'm so happy. All right. Anybody willing to try? Let me look for one final one. Yeah, somebody should try this one. You know, if you are looking away, I'll be looking more towards you. Go ahead, give her. Only women are trying. Where are the guys now? Maybe you're checking somebody out. You don't want them to know that you don't know anything, Abby. Don't worry, just keep quiet.
Okay. Should I?
This is simple, not so. Abby? Anybody have any questions? Yeah, somebody has been answering for you, Abby. Dr. Noah, where Dr. Noah?
The reading.
Mr. Dokada? Audrey? All right, who's
okay.
Go ahead. Go ahead.
Okay.
Yeah.
First of all, I'm
graduate.
checking for the rates
Correct. Rate is what? Now let's move fast. Let's move fast. We are now seniors.
3, 4.
What's the rate?
I'm seeing 4.
75. Just say it
75.
straight. No need to waste time. Read him.
Then for the reading.
Sign us with him or not? Sign us with him or not? Do the calculation in your head. Sign us. Awesome.
Sign us.
What's next?
QRS segments.
Is it wide? Anywhere that is wide?
Half a box. No.
About, yeah, it's slightly wide, but just about half a box. Okay.
Half a box for all.
Any right ventricular hypertrophy?
1, 2.
Right ventricular hypertrophy.
2 there and then.
Right ventricular hypertrophy. V1. Is V1 facing up or facing down?
Down.
So is that right ventricular hypertrophy or not? No right ventricular hypertrophy, Abi?
Yes.
So left ventricular, you're doing left, Abi? So left, is there left ventricular hypertrophy?
For left, 2 plus V2 we have
just say yes or no. Yeah, senior now. You cannot share everybody with all your secrets. Is there any?
No, sir.
ST segment, any elevation?
Between QRS and T. Yes, sir.
Where? Are you sure? Are you very sure? Are you really?
There's one in V3, so I'm
in V3. V3. Not quite. That is the line there. So the point we're checking is here, so it's not quite. Any ST elevation?
ST elevation.
Just look at the ST segment. Is anyone going up or going down?
It's going up.
Where?
ST, V3.
Yes. In where?
V3.
V3? Well, but okay, in V3, where do we check after if we see V3?
V4.
Is it there? Is it corroborated here? No. So not particularly serious, Abi. Any other place? Is there any elevation or depression anywhere? Huh? Let her talk now.
AVL.
AVL.
No, it's not significant.
Okay. Look well, look well. Is there anyone where the line passes and is above? Is there anyone where the line passes and it's above? ST segment is above? Yes, what do you think? Huh?
I don't think there's ST elevation.
Okay, let's look at it together. Here, can you see this line? Are you with me? Can you see this line? Okay, let me come up here. Can you see this line?
Yes.
This ST segment between S and T, is it above this line or below the line or the same line? Hello, lady. Is it above or below?
Above.
Above? If you think it's above, where else will you check? This lead 2, where else will you want to check? Lead 3. Is it above there? This is their own line 2. Is it above 2? Where else will you want to check again? AVF. This is the line again. Is it above or below? Above. So you have it above here. You have it above here. You have it above here. So this is what? Inferior stemi. Where is she? You can see her. How far? Do you understand?
Yes.
Did you see it or you did not see it?
I don't really get what you said.
You didn't really see it?
Yes. Can you just explain again?
Can you see this line that is passing here?
Yes, sir.
Can you also see this line that is here?
Yes.
This line that is here, which is the ST segment, and this line, are they at the same level?
No.
Is this one above or below the line?
It's above.
So that is an ST segment elevation above this line. ST is elevated. Do you understand that?
Okay, yes.
Correct. Now we have seen this. We come again. Check another lead. This line, another bit. This line and this line, are they at the same level?
No.
Is this above or below?
It's above.
So it's elevated, not so?
Yes, sir.
So we have seen it in lead 2. We now want to check where else. Lead 3, Abi. Now let's follow this line. And this line here. This ST, between S and T. This line and this line, is it above or below?
It's above.
Above this line, Abi.
Yes.
So that's how we see this ST elevation. So we can see it in lead 2. We can see it in lead 3. Where else we want to check? AVF. See the line again. Is it above or below?
It's above. Yes.
Above. So 2, 3 AVF. That's how we arrived at it. You understand that? Perfect. You see, if she did not try and answer, she may not have. Can we clap for her, please? Some of you, the thing that you don't know it at all, oh, please, oh. And let's take one final one. I think we have more or less ended, more or less. Okay, few alarm signs. Heart rate less than 150 or greater than 130. Put up the other microphone. Less than 150 or greater than 130. Even if you don't know anything, once you count the rates and you see this one, something is wrong. Abi? I don't know what is wrong, but something is wrong here. Number 2 alarm sign. Whenever there is ST elevation in 2 or more similar leads, alarm. Number 3, whenever the reading is not sinus, it is an abnormal thing. Don't keep that patient. Don't keep that patient. You will not like what will happen. Number 4, VT. Those ectopics I will show Dabi, when they occur together, especially more than 3 or more together. Number 5, for people who are snapping, I want you to write. That is how this thing works. Now, as we are going for a break, can food start coming, please? Food. I've taken enough energy from their brain. I need to give it back. So that as we are eating, in your notebook, you will see other ECGs that you need to try. So that when you are doing your final assessment for today, you must pass. So, VFib is like Jaga Abi. You see that one, Nadeto, you need to shock. You don't even have time to call anybody. Everybody here will be able to identify it. I'm going to go to ACLS very soon. So, you cannot do ACLS without learning ECG. And ECG is not for cardiologists. It's not for nurses. It's not for doctors. For everybody. If you are working near healthcare, you must read ECG. Otherwise, go and sell spare parts. You will make more money. If they make me a senator today, I will pass that bill. I swear. No healthcare worker should continue working without learning ECG. That's what I will do. Everybody, they are doing their own, Abi. Me, they are doing social media bill. They are doing which other one are they doing? Me, the one I will pass. No building should be standing that catch more than 200 people without an AED. Those are the 2 bills I will pass. First. So, those of you that are in power, please, find a way to arrange me. But Nigeria will be better for it. Yeah, they will go to public hearing and we'll make sure it passes through. All right, any new ST segment elevation or new level band block, you are likely the new elevation or depression. You imagine depression before, and all of a sudden you saw it. In PE sometimes, that's all you will see. Patient got breathless, you now see this one. You are not trying to differentiate between PE and MI. And then when you see Q waves, especially when there are new Q waves, these are red flags on the ECG. All right, we have come to the end of ECG. Can we clap for ourselves? Now, is ECG hard or simple? Is it hard? But can you read the ECG? Yes. Now, my final thing, I told you, you must practice. I have put about 5 or 6 ECGs. Last year we put plenty. Okay, but you know how economy be. So we put less ECG this time. So in your break time, while they are bringing food out, and then for those that are going for Jumat, please, in between on your way going, be solving those ECGs. And you should have some questions as you are doing that. So we'll take a short break while we eat, and then you continue doing that. Can we clap for ourselves, please? And don't go for Jumat, you can quickly come, or pick your food on your way going, or I don't know how you do it, or your way coming in. Please don't take more than one. I take God beg you. I take God beg you. We can't solve all your problems. Please. All right, thank you so much. Let's have a short break. Meet new friends, snap pictures, hashtag ACS2025, hashtag CardioCare. They are consultants around the building, so you can ask them particular questions if you have. They'll be very glad to assist you. Please practice. Practice. I will be here. People will be here. You can still ask questions. I will be here. Lunch will be served on your seat. If you move out of your seat, now you know we're not going to answer you.
Please, at your convenience, don't forget to check out our sponsors. They have booths at the back with your products. Please, please, if you're going for prayers, don't forget to pick your food on your way out. The rest of us, please, let's remain at our seats so that we can orderly share the food. So as we were saying, we have a couple of sponsors with their booths out there. We have Darles, we have Edge, we have Airtel at the back, we have Medtronics, we have Novartis. So please, please feel free to go there and explore them. So we'll also take this moment to give a shout out to the rest of our sponsors. Women Bank, Gebs Pharmaceuticals, Berzik Pharma, Medilab, Hafak Surgicals, Nigerian Cardiac Society, Getz Pharma, New Heights, those are the producers of Omron, GNCI, and the Limi Cardio Care, Limi Children's Hospital, Limi Hospital, and Mortality.
Good afternoon, everyone. Ethel will be coming up shortly to do a brief presentation. 2 minutes. All right. Ethel representatives. Okay. All right.
Good afternoon, ladies and gentlemen. Permit me to stand on existing protocols. My name is John Achu. I'm a senior channel manager from Airtel Networks Limited. I'm sure we all know Airtel Networks. Okay. Stop moving. Okay, sorry for the brief interruptions. Okay, so we in Airtel Africa, we are present in 14 countries with over 3,000 staffs. We have about 157 mobile subscribers. About 57 million of them are Nigerians. We have 64 million people that are using data here in Africa. We provide services, mobile data services, postpaid services for staffs, for effective communication. We also provide mobile messaging, mobile money through our smart cash. We provide secure wireless services also. But today, I'm here to just talk about one of our products. It's called Airtel Network as a Service. This, for me, is like good news to our IT teams because instead of focusing on IT infrastructure, they are focusing on providing better healthcare delivery. For us, what this does is we help the hospitals or those in the healthcare sector take care of their infrastructure, internet infrastructure, whereby what that does for us is it gives them reliable, secure clinical internet. We provide them equipment, we provide them routers that are scalable and very reliable. We will also give them what is cost efficient. If you can see, from what we can see on the screen, you can see we have so many of our routers, Meraki routers, that we can use to provide all of this cost effectiveness, all of these security compliances, and also to ensure that if you want to scale up your internet facility, maybe to include new words or to include new wings, that is easy for us to do. It's done in fact within 7 to 14 working days. We have come to deliver all of that to you. Also, you can also see that if you want to do some telemedicine, you want to talk to your patients online, or you want to talk to your pharmacist or take a particular medication, this is something that we can also offer you more of like a communication service that will help you out to ensure all of this is being communicated effectively to your customers. If you want to do every data load, like imaging, sending of scans from one hospital to the other, We also have the bandwidth and the network to help you ensure that's being done securely. And like I said, our service is scalable and very, very, very cost efficient. Also, we are outside with our 5G ODUs for small businesses. If you want to have unlimited internet, 5G ODUs can provide that for you. We're just right behind you. If you want to ask questions, you want to ask about our network as a service and how it can help improve your IT systems and your IT teams, we are behind. My team will also be working around to speak to you about all of this. Thank you very much, and you have a nice day.
Thank you very much, Etta.
Okay, little announcement. So some of you notice on your table there's a QR code for nurses. Please make sure you scan and fill them. It's important for you to get your MCPDP and your CME points. So you don't have that here? Okay, some tables don't have them. Okay. And if there's anyone who hasn't joined the WhatsApp group, you want to just signify when the ushers go past you and they can help you out with that. Also, there are some papers as well for the group on your table, so feel free to use them. You don't have them as well? Remember, feel free to check out our sponsors at the back. We have Medtronics, Edge Plus, Genos has their stand, Dorles, Novartis, Airtel at the back. While you're eating, you can take a moment and stop by there and you can come back briefly. Some of our other sponsors, New Heights, JNCI, Wema Bank, Basic Pharma, Vastovas, Hafak Surgicals, Nigerian Cardiac Society, Get Pharma, MedLab. All right, let's start coming back to our seats. We're jumping right into the next session. To replenish glucose. Those outside, please, let's start to return to our seats as we go into the next session. All right. So our next session is still part of our ACLS protocol. We're going to be going into a deep dive of acute coronary syndrome. We call on Dr. Adefila for that session. Can we give a round of applause, please? Sorry, please, you still have to show me how to use it. Takes you to the next. Which one is that? This one. Okay. Then point at it. Okay, excellent. Thank you.
Good afternoon, everyone. Hello. I think everyone is enjoying their everyone is enjoying our meal now. I hope you'll be able to listen to me. So, good afternoon, everyone. I am Dr. Adefila Rafiu. I'm a consultant physician and cardiologist with Cardiocare Multi-Specialty Hospital. We're going to be discussing a common and life-threatening condition now. Everybody has heard of heart attacks before. So we call it acute coronary syndrome. Are we ready? Are we ready? Okay. My slide, please. Say. So, do you have anybody that want to tell us what a heart attack is? Please, ushers. Among the audience, is there anyone that would like to tell us what they understand by a heart attack? Anyone? What do you understand by a heart attack? No takers? Anybody?
Okay, I think it is abnormal electrical activity of the heart muscles, of the heart, that can be characterized by certain symptoms such as chest pain.
Thank you for your effort. Any other person?
It's true, the people in front are more with us.
Thank you.
So good afternoon. From yesterday's lectures, I understand heart attack differently from heart failure and then heart arrest. Heart attack is more or less a piping problem, supply. Okay,
Excellent.
basically that's it.
Excellent. So he said heart attack is a pipe problem. That's excellent. Any other attempt?
From the back, please. We can't
Anybody want
see
to-
anyone participating from the back.
To say their views?
Any attempts from the back?
So electrical problem is a cardiac arrest. That's for the first person that responded. Heart attack is a pipe problem. Is there any other way you want to refine the definition beyond a pipe problem? So let's just dive in. Okay, there's another person here, please.
Still from the front. Clap for yourselves, people in the front. Louder.
Fatima, one person here.
So just like he said, when there's a pipe problem, simply means when there's a blockage from the, yeah, thank you.
So she said a heart attack is due to blockage of what? The pipe to the heart. That's excellent. Thank you. So basically we are discussing heart attack today. It's common. Everybody has heard of heart attack before. The story is common. You have had somebody collapse in their office after holding their chest. Maybe you heard that people have been complaining of chest pain, then suddenly died. Then from the case scenario we presented earlier, there are instances where people complain of what? Pain in their upper abdomen that is being treated as ulcer, not getting well, then they suddenly die. So it's just telling you that it can come in varying ways, but it's common. The other aspect is that heart attacks are arguably the most common cause of cardiovascular death worldwide. Over the course of this conference, we presented stroke. We've also presented pulmonary embolism. Heart attack is a cause of cardiovascular death and is the #1 cause of cardiovascular death worldwide. So we're going to be going through it now. Slide. How do you do this? Sorry for the delays. So we are back. So we are on heart attack. Firstly, heart attack comprises of unstable angina and myocardial infarction. Generally, it's caused by...
Please, can we pay attention? Please, can we just keep quiet? Thank you very much. Break time is over. There's so much chattering. If you are eating, eat quietly, but your ears open and your hand on your biro. Eat with your left hand, your right hand on your biro. This is war. Thank you very much. Let's pay full attention, please. This is a very critical topic. And then after this, we are going to ACLS.
Heart attacks comprise of unstable angina and myocardial infarction. It's usually caused by fissuring or rupture of a plaque, atheromatous plaque, on the coronary vessel wall. It can come as chest pain, but sometimes as what we term as ulcer pain, and sometimes can come non-specific. There are instances where people present with just difficulty breathing, or sometimes they just feel fatigue. And this kind of so-called silent acute coronary syndrome are common in elderly patients, people with diabetes, female folks, and the like. So we should know the varying way it can present. So it's not all epigastric pain or upper abdominal pain that is ulcer, as was highlighted earlier. So this is the vessel wall. The primary cause of acute coronary syndrome is atherosclerosis. So it starts with damage to the vessel wall. So assuming this is the vessel wall here, you can see this yellowish thing. These are plaques. Before this fat becomes deposited on the vessel wall, there is the initial damage to the vessel wall. It's precipitated by things like hypertension, diabetes, hyperlipidemia, smoking. Now, you can have a narrowing of the vessel wall that is stable. It did not rupture. That can give you chest pain, like angina pain. Chronic pain is only when you exert yourself, you feel the pain. But in terms of acute coronary syndrome, we are talking of a rupture of this plaque that causes a total or near total occlusion of this vessel and impairment of blood supply to the coronary arteries, by extension to the heart muscle. Is that clear? Did that make sense? Thank you. So that's atherosclerosis. So heart attacks is caused by a rupture or fissuring of this plaque that eventually leads to total or near total occlusion of the blood vessel. The patient presents with what? Acute coronary syndrome. So this presentation is to be simplified. If we are to talk of ischemic heart disease and acute coronary syndrome, we're going to take more than a day. But we want you in the audience to be able to make a diagnosis, to be able to do the initial thing for the patient, to be able to refer for appropriate therapy. So we have simplified it into these 5 steps, the diagnostic framework. What's the first step? Chest pain. Patients with heart attacks present with chest pain, sometimes with upper abdominal or epigastric pain. The second thing is, I hope you are writing, please. The second thing is they have a positive ECG. What are we concerned about here in the ECG? Earlier we had ECG presentation where we are talking of the ST segment. We said the ST segment can go up, ST elevation, or what? Down. We also talk about the T wave, that the T wave is usually upright except in what? AVR. And we said once it's down, it is what? Not good. So positive ECG in this instance, we are talking of what? ST elevation going up or down, and a T wave going what? Down. The third aspect is a positive enzyme. By enzyme here, we are specific, troponin I or troponin T. Then the fourth aspect of your initial review and evaluation of a patient coming with heart attacks is what? Assessing their cardiovascular risk. So it's just to know if they are diabetic or hypertensive, if they have a family history of premature death that is likely from acute coronary syndrome, if they have elevated lipids and the like. After that, number 5, we have urgent medical treatment, which we are going to expatiate on. Then reperfusion, if they are candidates for reperfusion. So these are the 5 basic things we'll be talking about. So this is our approach. When somebody comes to you, severe chest pain, sweaty, vomiting, it could also be epigastric pain, as we've been reiterating since, you do a quick check, quick history, physical exams. The history should tell you if it is really typical for acute coronary syndrome. You want to check their blood pressure, be sure they don't have excess fluid, they are not in heart failure and the likes. That's what we mean by hemodynamic status. Then you do the ECG. And that ECG must be done 5 to 10 minutes of first clinical contact. Anybody with chest pain at all, anybody to you, chest or epigastric pain, for the first time, severe enough for them to present to you, you should do an ECG within 5 to 10 minutes. Then the third aspect is what? An initial what? Troponin that should be done. And sometimes the initial troponin can be negative. We want it repeated within what? 3 to 6 hours. Because sometimes you are picking the chest pain early and the effect on the troponin is not shown yet. In the next 6-12 hours, it starts rising. That rise or even fall of troponin is also pointing to a heart attack. So we said earlier that heart attacks or acute coronary syndrome comprise of what? Unstable angina and what? Myocardial infarction. Now, we have this simple table to help us classify it. If someone comes, let's look at the table. If someone comes to us, they have chest pain, typical as we have described. But you did their ECG. The ECG is not showing significant ST elevation now, or Q waves, particularly ST elevation. So that means the ECG is what? Positive, right? Then their enzyme, you did their cardiac troponin. Their cardiac troponin is also what? Elevated. They are going to be what? Diagnosed at what? STEMI, ST elevation myocardial infarction. On the other hand, patients can come with the chest pain we described. The ECG is not showing ST elevation now. You can show other things, ST depression, T-wave inversion, but their enzymes are also what? High. The troponin high or T is elevated. We say is what? Non-ST elevation, myocardial infarction. So what defines MI now? The positive enzyme. Because when somebody has an MI, it's a what? It's a significant occlusion that is causing cell death. The muscles are dying. And the troponins are secreted from the what? From the dying muscles. So myocardial infarction just means that the cardiac muscles are what? Dying. So when you see an elevated troponin in this context, we say the what? It's MI. The only thing that will tell us if it's STEMI or STEMI is what? ST elevation. Is that clear? Are we listening? That's clear. Good. But sometimes patients can come acutely. All the type of chest pain we've talked about, they don't have ST elevation on ECG, and their enzymes are normal. We say they have what? Unstable angina. So somebody comes to you, severe chest pain, or they had a previous angina that is getting worse, or an angina that used to last 10 minutes before, and now it's 30 minutes and they're not getting relief. Or this is the worst pain they can describe, and they're just presenting for the first time. You think acute coronary syndrome, but the enzymes are what? Normal. We start calling that what? Unstable angina. Yes, the last box here is here. In that sometimes you will see someone with ST elevation on ECG, but the initial enzyme is what? Negative. We say from our initial presentation, you have to do a recheck in what? 3 to 6 hours. If you do repeated troponins and it's now high, that's likely ST elevation still. But sometimes there can be other differentials, other causes of what? ST elevation with what? A negative troponin. And some of them are like things like pericarditis, myocarditis, and the like, which we are going to talk about. Are you with me up to this point? Any question at this point? No, yes. Okay. So this is just reiterating what I've said earlier. So unstable angina, no ST elevation, Enzymes are fine. We say it's unstable angina. Non-ST elevation myocardial infarction. We don't have ST elevation, though we can have what? ST depression, T-wave inversion, or the ECG can look seemingly normal, but the troponins are high. We say is what? Non-ST elevation myocardial infarction. But if we have typical ST elevation, new left bundle branch block, we were trying to explain what left bundle branch block means earlier. We said bundle branch block is usually wide complex, wide QRS complex. We're going to show an example later, but wide QRS complex usually signify bundle branch block. So if you are seeing a left bundle branch block for the first time in a patient with typical chest pain, together with positive troponin, that is, the troponins are elevated, that's what? ST elevation myocardial infarction. So this is what I was saying earlier about partial occlusion versus total occlusion. Generally, complete occlusion of the short plaque will give you STEMI. And that's what gives ST elevation. But sometimes it's partial, so it can give either STEMI or unstable angina, depending on if the troponin is positive or not. So we are going to take a case. We are going to use this case throughout this lecture. I want us to pay close attention to it. It's just to highlight the salient points we've started with. Our patient is a 52-year-old male presenting with severe retrosternal chest discomfort. Now you can say, I say chest discomfort, not chest pain. Because for some people it's not pain, it's more of heaviness. Some will even say it's like an elephant sitting on their chest. Some will say it's just like something is squeezing their chest. That's why I use discomfort. Of 5 hours duration. He had an episode of vomiting. The relatives reported that he fainted once. The pain was radiating. He was recently diagnosed hypertensive, but not yet on medication. He's not a known diabetic. I've never checked his lipid profile before. Does not smoke or take alcohol. He was referred from another facility. There, they already taking acute coronary syndrome. So they gave him aspirin, 300 milligram start. Clopidogrel, 300 milligram start. When he was rushed to cardio care via ambulance, presenting pulse rate was 102 per minute, blood pressure 140/70. The jugular venous pressure was raised, heart sounds were 1 and 2. He was tachypnic, respiratory rate of 30. His oxygen saturation was low at 89% in room air, and he has fine crepitations in the lungs. However, the initial troponin at the referring hospital was 0.16 nanogram per mil, and the normal is 0 to 0.3, so it was normal. So back to the next, this is the question. What is the first step in the management of this patient? From what we've highlighted, we listed 5 steps earlier. So what's the first step? 1, if you choose any, just say yes or no. 1, take sample for a serum troponin level. Yes or no? If you say yes, anybody saying yes, can I see the hands? I should go back. The steps? No, we are coming to that, sir. So, yes or no? Take sample for a serum troponin level? No. Send for emergency echocardiogram? No. Do a 12-lead ECG? Do an urgent chest X-ray? So, the first step is what? You start with an ECG. So we go back to our steps. We said the person has presented. You've already defined the chest pain. You think you are thinking acute coronary syndrome. The next step is number 2. ECG. You are looking out for the positive findings. I hope that's clear. Thank you. So that's the answer, a 12-lead ECG. So there are some points. We will keep repeating them because we don't want people to miss them. If we say heart attacks are the most common cause of cardiovascular death worldwide, but we are not seeing much. That means people just die. You just hear somebody has finished his building, then collapsed and died. Somebody was praying and died. Somebody was in the prayer house and died. All sorts. That means we are missing them. So we don't want that. That's why we'll be specifically pointing out these things and repeating them. Everyone with ongoing acute chest pain or quote-unquote ulcer must have an ECG within 5 to 10 minutes. It's 5 to 10 minutes. So it's not that time you will now start clacking for 1 hour. Not every abdominal pain is ulcer. In Nigeria, there are certain diseases that are common. Malaria, typhoid, and ulcer. Some will tell you every 3 months, they treat them. So, and we don't want to forget that it's not all the time that patient will present with classical chest pain. So I said earlier, some people can present with just tiredness. Doctor, I used to take 5-kilometer walk every morning. Yesterday, just on 1 kilometer, I was already panting. And it came to you that same day. You should think, especially if the person is hypertensive, diabetic, elderly, or middle age, start thinking what? Acute coronary syndrome too. So we call those ones angina equivalent. Epigastric pain, difficulty breathing, exercise intolerance. So we don't want you to just think of ulcers alone. So this is how to know ST elevation or ST depression. You were taught this earlier. This is the P wave, the Q wave, the R wave. This is the normal. P, Q, R, S, T. Sorry, the R is not prominent there. But when we say ST elevation, we mean that this segment that is in line with this is what? Pushed up. So when ST goes up is what? ST elevation. And when it goes the other way is what? ST. Excellent. Thank you. Then sometimes the T wave itself, we said T waves are always positive, except in what? AVR. So once you see a downward T wave, is what? T wave inversion. Good. So ST elevation, ST depression, T wave inversions, they are the positive ECG changes we are talking about. Is that clear? And we said they are usually grouped. Once you see one in the lateral, any of the lateral lead, you must look for other lateral leads. Good. So we have 2, 3 AVF for the inferior lead. Lateral leads are as listed and all that. So we'll be fast. So this is just pointing to what we said. 2, 3 AVF inferior lead. Anteroseptal is V1 to V4. Lateral is what? 1 AVL, V5, V6. So this is the patient's ECG. Let's look at this quickly. The patient's ECG. Can we all see this? Good. This is the patient's ECG. So the question will now be, the next question is, what is the cause of this chest pain based on his ECG? Inferior non-ST elevation myocardial infarction. Number 2, anteroseptal non-ST elevation. 3, inferior STEMI. 4, acute pericarditis. So if you go for inferior end STEMI, anyone? Only one person. Anteroseptal end STEMI. So we should go back. I'm giving you answer. But it's fine, don't worry. So we can see the inferior leads. We can see the ST segment is going up here, right? Also here and here. We also have ST depression in other leads. But when you see ST elevation together with ST depression, the primary problem is the ST elevation. The ST depressions are reactive. They are just like a response to it. So this patient from this lead, 2, 3, and AVF has what? Inferior ST elevation myocardial infarction. So the first step is always an ECG. Is that clear? Thank you. So with inferior STEMI. So what's the most important blood test you want to send to the lab immediately? Troponin high. Yes. Thank you. So again, the steps: chest pain, positive ECG, positive enzyme, cardiovascular risk factor, then urgent medical treatment and reperfusion. So troponins are invaluable. You can't do without them in diagnosing this patient. And we said earlier, a negative troponin, especially patient presenting with suspicion of acute coronary syndrome, you should repeat again, Abby, in 3 to 6 hours. Thank you. Now, sometimes there are other causes of elevated troponin. So sometimes patients come with chest pain, troponin is elevated, we eventually diagnose other causes. But we won't focus on all these other causes. We would rather focus on what is most life-threatening and can kill the patient. It's better we are safe than what? Sorry. So it's just that generally sometimes for the experts or the specialists, the way they present, we can see which type of pain it is and all these other causes. So these are some of the other causes of elevated troponin. Remember, somebody was talking about elevated troponin in pulmonary embolism earlier, right? So pulmonary embolism is a cause. Stroke is a cause of elevated troponin. It's not too far-fetched. All of them are involved in certain form of thrombosis or the other. So now, I've defined all these earlier, so I'll skip them. These are some of the, I've shown you this, inferior STEMI. Now, look at this ECG. Where is the ST elevation? Anyone? Anyone? So we have ST elevation in V1, V2, V3, V4, and V5. Excellent. So this is what? Anteroseptal STEMI, Abby? STEMI or STEMI? STEMI. Thank you. So this is a bundle branch block. We're going to talk about maybe when we do our practical session. So I will not disturb you about that. We have also defined STEMI earlier. We said in this case, patient come with consistent symptoms with acute coronary syndrome. They have ST depression and or T-wave inversion, but no ST elevation. And their troponins are what? Elevated. Is that clear? So this is ST depression. Can anybody show me where the ST depressions are? Anyone? So we have ST depression here. Lead 2, lead 3, AVF, right? We also have some in V4 and V5. So this is what? N-STEMI. So this patient coming with typical chest pain, elevated troponin, and this ECG has what? N-STEMI. Good. An unstable angina can come in various forms. The most important thing is there's no ST elevation and the troponins are fine. But we said it can either come as somebody that is coming with a prolonged angina lasting more than 20 minutes, or they just come with a new angina that is very bad. They are sweaty, panting, they are in severe pain. Or they already had an old angina, but this time around, instead of having it maybe once a week, twice a week, you have increasing frequency, or it's becoming longer, or the amount of effort they must go through to develop angina is lower. Maybe before they used to have chest pain when they walk 5 kilometers, now it's every 1 kilometer. That's also worrisome. Then, of course, sometimes angina can occur after they've had a previous myocardial infarction. You start thinking of a stable angina. These are technical terms, but it's worthy of note. So back to our case. Our patient did, we said the initial troponin was 0.16, average of 0.2. So on presentation, we repeated it. It was 2.3 nanogram per ml. So it's now elevated. Is that clear? The cholesterol was high. LDL cholesterol was 160 milligram per DL. Normal should be less than 100. N-terminal pro-BNP was high. Creatinine was normal. So this is what we did for him. We nursed him in cardiac position. He was placed on oxygen. Because of his severe pain, he had morphine, 10 milligram start. We don't want him vomiting, so we gave an episode of a shot of metoclopramide. Then we continued the aspirin at 75 milligram, clopidogrel at 75 milligram. So this is going to be a bit hardness. So this is our diagnostic framework. So we've discussed all this. We've discussed the chest pain, ECG, enzyme. We said is a recently diagnosed hypertensive, Abi. So we have also picked another risk factor now, which is what? The lipid. He was not diagnosed with hyperlipidemia before, but on presentation it was high. So he's hypertensive and what? He has dyslipidemia. So we are back to number 5, which is urgent medical treatment. So the next question is, what other medication will you give these guests in the emergency room? Anyone? Okay. So what we try to do here is, we try to outline the medical treatment you give a patient presenting with acute coronary syndrome. So basically, I want you to think of this mnemonic, MONASH. Patient come with pain, they must be on analgesic, preferably opioid analgesic, so morphine or other opioid. They may need oxygen therapy, especially when their oxygen saturation is low. Nitrates are also important. However, we avoid nitrates, sublingual nitrate or IV in patients with inferior MI because it can tip their BP down and give them hypotension. But generally, it's part of the initial treatment. Antiplatelets are also important, aspirin or clopidogrel. Generally, we give the dual antiplatelet. We start by loading them, then continue with 75 milligrams. High dose statins, we talked about this earlier, the importance of statin when Dr. Fortune was presenting the case. It's not just for lowering the cholesterol, it's also to stabilize that plaque and prevent further rupture. So we give high dose statin. Then heparin. Heparin is important too to prevent thrombosis from other things, including pulmonary embolism and venous thrombosis, because the condition is actually prothrombotic. It can lead to formation of clot elsewhere. So we give heparin or either unfractionated or enoxaparin. That's MONASH. So for these guests, the guests also came with heart failure. So we gave IV furosemide, captopril, then heparin, then we gave high dose rosuvastatin. So as another point for you to remember, we want to avoid nitrates and beta blockers in patients with inferior myocardial infarction because they are prone to low BP and heart blocks. Because they are prone to what? Low BP and what? Heart blocks. So patients with inferior myocardial infarction, we don't want to give your sublingual nitroglycerin or beta blockers like bisoprolol and the likes. Also, patients with cocaine-induced myocardial infarction. For those that take substance, especially cocaine, they can have myocardial infarction, but we avoid beta blockers in them.
The inferior MI is which leads? ST elevation in which leads? 2, 3, and AVF, Abi. So even though we are saying MONASH, for those ones, that N will not be there. Please, let's remember that. And in Abuja or big places, ask about cocaine. If you give beta blocker there, you will never forget it.
So now the last part is still on the number 5. We talked about initial medical treatment and reperfusion when indicated. So you must remember that time is what? Muscle. If you don't reperfuse and open that occlusion, the muscle will die. A blocked artery every minute to second will lead to increased muscle death, heart failure, and possible what? Death. So it's not enough to say I gave morphine and I gave heparin. You must find a way to open the blocked artery. So these are the reperfusion strategies we have. First line is percutaneous coronary intervention. It's simple. Let me just use a layman language. It's not as simple as I said. Let me use a layman thing. It's to go in there, pass a wire through the blockage, then a balloon over it, open up the blockage, then we put a stent to keep it opened. The second line, in case you are somewhere where you don't have access to PCI and stent, or the patient comes early and they cannot get to where they can get PCI on time, you can give thrombolytic therapy. That's oteplase, tenecteplase. And in some instances, patient may also need what? Bypass surgery. There are certain instances like people that have all the blood vessels blocked, right coronary, left coronary blocked, people with certain types of lesions, people that have other indications for bypass beyond the blockage and the likes. So these are the three strategies we have. So for thrombolytics, the drugs are as listed, the strategies are as listed. So emergent reperfusion is the immediate priority. If you reperfuse the patient on time, you get favorable long-term outcome. So it's very important. It's not enough to just give aspirin and statin. So our aim is to reperfuse someone within 1 hour of arriving at the hospital. However, this is very important. If you are working in my village, and my village is 1 hour away, and the patient presented to you with STEMI, and you know you can do the initial management and get the patient to reach cardio care before 2 hours, transfer the patient. If you are also in my village, and my village is still 1 hour, but you know you will not have time, or it will be delayed, you can do initial thrombolytic therapy and transfer the patient afterwards. So when we do that, we call it what? A pharmaco-invasive approach. So you give initial thrombolytic therapy. If you are not going to get the patient to a PCI-enabled facility within 2 hours, then afterward you transfer the patient. Is that clear? Is that clear? So we are saying if you cannot get the patient to get the first line treatment, which is PCI, in 2 hours, give thrombolytics first, then transfer. But if you can get the patient to where they can get the first line treatment, transfer the patient. Is that clear? Is that clear? Thank you. So we've talked about the for patient with non-ST elevation acute coronary syndrome, either end-stage or unstable angina, the Monash, that's the initial medical treatment, is still there. We re-stratify them. We don't give thrombolytics in this patient at all. We don't give thrombolytics. We either do a PCI or we do bypass surgery. But we don't also do reperfusion for everybody. Only those that are high risk. So I will tell you some of the high risk pictures. So these are some of the high risk pictures you should note. Patient that come in shock or cardiac arrest, patient with ventricular arrhythmias, especially those that lead to cardiac arrest, patient coming with acute heart failure and they have non-ST elevation acute coronary syndrome, or the chest pain is persistent despite all the medical therapy. So an important point is that after all this, we've gone through the 5 steps. We said the first one is identifying the chest pain. Next is what? ECG. Third one is what? Troponin, the enzymes. Number 4, cardiovascular risk factor. Number 5, immediate treatment and what? Reperfusion. So after doing all this, we must prevent a repeat. Now, I started with atherosclerosis and I said we have a blockage that leads to what? Myocardial infarction. The same thing is going on elsewhere, in the brain, in the leg. So patients with myocardial infarction are prone to what? A repeat one, a repeat acute coronary syndrome. They are also prone to stroke. They are also prone to peripheral artery disease. Beyond the heart failure and cardiac arrest, they are prone to. So you don't want that. So secondary prevention is invaluable. So we start with lipid lowering. All patients must be on high dose statin. Our target is what? Less than 55. But if they have had repeated episodes, they become what? Very high risk. And we say the target for that will be what? Less than 40. So, but they are coming for the first time. Acute coronary syndrome, target is less than 55 milligram per DL. For the sugar, we said the target is less, hemoglobin A1C less than what? 7%. Now, they must be on antiplatelets. On it, compulsory. Our chief presented a case yesterday about somebody that went to a pharmacy with dual antiplatelet and he wants to renew his drug, and the pharmacy was like, aspirin and clopidogrel, they are doing the same thing. Remove this one. And the stent he had got blocked and he presented with what? Another episode and he died. So it's dual antiplatelet. The two must be on for at least 9 to 12 months. In our facility, we do 9 months. Others do 12 months. You can extend depending on the case. So other things we give are beta blockers, other heart failure medications, especially the EF is low, like ACI-ARB, mineralocorticoid antagonist. Now, there was a question about the role of all other health workers in managing this patient. The physiotherapy was asking the question yesterday, that what is their role? So we have a comprehensive program called cardiac rehabilitation for cardiovascular prevention, especially secondary prevention. And it involves exercise training, nutrition. So the physiotherapy is there, nutritionists are involved, weight management, endocrinologists may also be involved, blood pressure management, lipid management, diabetes management, smoking cessation is also part of it. Then we have psychosocial management. These illnesses are bad. People have PTSD from just suffering from stroke or acute coronary syndrome. People are trying to adjust. People will need some psychosocial assessment and management. So all these are components of cardiac rehabilitation. You can see it involves a lot of what? Subspecialty. And all this will help the patient and prevent a recurrence of what? Acute coronary syndrome. So don't forget, we talked about the diagnostic framework. We said 5 steps. Who can remember them? 5 steps. Anyone? We started with what? Chest pain, right? Next we said what? ECG. Next we said troponins. Next we said cardiovascular risk factor. And number 5 we said so immediate treatment and reperfusion when indicated. We also said the initial management is what? Monash. Abi? So for pain we said morphine. Abi? Oxygen when the oxygen is low. N is what? Nitrates.
Nitrates except in where?
Except in what?
Inferior stemi, right?
Except in inferior stemi. Then we said A is what? Antiplatelets. So we talk of aspirin and clopidogrel.
Together, 300, 300.
Together.
And
please.
all of this treatment should be done within 5 minutes of person getting into the facility. Everything, 10 minutes, it should be done. ECG, all of this should have been done.
S is what? High dose statins. H is what? Heparin. So this is initial management. And we said reperfusion is important because time is muscle. Time is muscle. So it's not enough. You must open the blocked artery. Otherwise the muscle will die. Patient goes into heart failure and possible cardiac arrest. And we say secondary prevention is as simple as A, B, C, D. I think I've removed that.
Thank you.
So this take-home message is the leading cause of death globally. Prompt recognition and initiation of guideline treatment is important and saves life. Thank you very much.
What's that? No. We'll answer the question later.
You're in a rush. I'll keep it.
All right. We'll answer your question. Don't worry. Please, Mohammed, please, let's go up. We have just 5 minutes interlude. Yes. 5 minutes. So to put together this conference costs a number of millions, and we have some companies that do support us, and all they ask is for your ears and that you give good due consideration to their products. Okay, so please let him just present for 5 minutes, and we'll go into ACLS. Get your pens ready, your books ready. There's still paper in your book, Abi. Still remain. Don't worry, we'll go fill them now. My job is to fill that book.
So Dr. Sego said I have 5 minutes. Okay. Good afternoon, everyone. My name is Mohammed from Medtronic. Okay. So a lot has been said in the last 24 hours on diagnosis, pharmaceutical, medical management, and now I'll be looking at the devices. I mean, I've had a couple of questions around surgical management, interventional management, and I'm glad that Adefila has actually done a bit of my job for me in terms of explaining atherosclerosis, the blocked vessels. I'll be talking about what devices do we now apply to these diseases beyond medical management. So I always say where medical therapy stop, we take over.
So, Medtronic is the largest medical device company in the world. And we've been in Nigeria for over 15 years trying to use medical technology to change the dynamics around the health sector. Now, we wrote this mission in 1960, and what we do with medical device is to see how we can alleviate pain, restore health, and extend patient life using medical technology. These 6 therapies are the therapies we focus on for cardiovascular in Nigeria, which include cardiac rhythm management, which has to do with the pacemakers. We actually started producing pacemakers in the world. Cardiac surgery, coronary vascular, which is your stents, and peripheral vascular. Now, endovenous and aortic, these are therapies that are still new in Nigeria. However, we still have these therapies being done in Nigeria. Beyond cardiovascular, for those who have practices, we have other divisions, which include general surgery, where we have the ligature, what we call the FT10, patient monitoring devices, surgical robotics. We have the surgical robotics known as Hugo, which is not yet in Nigeria. Now, if you look at this picture, the person on the left, that's who we call the father of cardiac surgery, Lily Hay. And if you look at the person on the right, that's the founder of Medtronic. If you look at what he is holding, you'll see that he's holding a battery. Now, the picture on the left was what the battery used to look like back in the days. Is the father of Medtronic, if you see the small device, that is the smallest pacemaker in the world we have today. That's how small a pacemaker is today. We have what is called the autotransfusion, which is for cardiac surgery. Now, if you have patients that require surgery and there will be excessive loss of blood, whereby you need a lot of blood banks, you need to request for like 20 pints, 30 pints of blood. We have some cases like that, like in aneurysm cases where we have that. Globally today, what people do is they salvage the blood. So what they do is they use the autotransfusion machine known as the autolog. So what happens is you suction the blood out of the field into this machine, it washes it and gives you packed cell. So you reinfuse the patient on packed cell. This is something for Jehovah's Witness patient actually, for some that accept it. It's more, very efficient because the packed cell you get is over 95%. So this is what the stent looks like, the making of the stent. The stent is coated with zotolomos anti-proliferative agent, which extrude into the vessel. Once you want to introduce the stent, the drug, anti-proliferative drug, extrude into the vessel to prevent restenosis. These are some of the pictures of some of the therapies I was talking about, like you have the surgical innovation, the staplers and co. One particular item here I want to focus on is the gastrointestinal section, which we also cover, which is the endoscopy, which is the pill count. So a lot of times people go for endoscopy and they run because you have to put something into their mouth. Now we have what is called the pill count, which is the capsule endoscopy. Is it been done in Nigeria? Yes. Interestingly, somebody asked a question earlier when they were talking about stroke, and they've talked a lot. Like I said, they've made my job easy. I'm just telling you what we have to do, or what is obtainable in Nigeria today. Now, if you look at the hemorrhagic stroke, ischemic, and the AVMs, today with the latest technology, you don't actually have to crack the skull to intervene anymore. You can actually do this in the cath lab today. For patients with the aortic, with hemorrhagic stroke, we actually have what is called the pipeline. Same thing for the aneurysms. You put a pipeline stent. Back in the days, they go in, the surgeons open the skull, they clip it. But you don't have to open the skull anymore. You go percutaneously like you're doing a coronary intervention and do the same. Same thing happens for ischemic stroke, where you have things like a mechanical thrombectomy. You just put in a device and pull the clot away from the brain. We had one done last week, and so far in the last 2 years, we've done over 40 of these cases. That's to tell you that a lot of patients have these issues. But however, most of them stay on medical therapy. But again, if it's not effective, you have the option of having the device done. So this is just a slide showing everything we have all together. And one particular area we are very strong at is training. You cannot have advanced technology without training people. And at this point, I would like to thank Cardiovascular. We've been in partnership in doing things like this, trying to see how we can expand this therapy across Nigeria. not just Nigeria, but in West Africa, where we have center of excellences for these particular therapies happening here today. Nigeria has been at the forefront in West Africa, whereby we have most of these therapies. Unfortunately, most people are not aware. That's why every year I try to present the same thing, try to modify it for us to understand that these therapies are available and you can refer your patient to get these therapies within Nigeria. I was discussing Dr. Iseko now. Sometime next year, we should be looking at how we can get some of these trainings done locally. We've invested millions of dollars in trying to set up facilities in Turkey. Also in ICAD in Rwanda, we have a facility which we partner with called IRCAD, which is IRCAD. There's the center in France, where we started a partnership with IRCAD Rwanda just 2 years ago, where we send surgeons, we send HCPs to that center for minimally invasive surgery training, colorectal surgery, hernia surgery, likewise robotic surgery. So I think this should be my conclusion. What I have to say is successfully introducing new therapies in Nigeria requires adoption of a localized, multifaceted strategy that addresses both systemic and market-specific barriers. Like we have seen the challenges we have with stroke therapies, and we are specific to certain therapies to address certain barriers we have, which includes training as well. Our key approach includes partnering with government and private health institutions to enhance this infrastructure, invest in physician training. I keep emphasizing on physician training is really key to us, and we are open to partnership. And also by aligning innovation with accessibility and local health priorities, we can play a major transformative role in expanding this life-saving therapy across Nigeria. I think I've done justice to my time.
All right. Can we give a round of applause? That one is for me. So, before we go into icebreaker, before we go into ACLS, one more icebreaker to wrap it up. Can we be on our feet? Can we be on our? I know the rice has gauge. So let's do a bit of stretching. All right, can we raise our hands up like this? And do helicopter. No space. Okay, lift it up. Stretch to the left. Stretch to the right. Stretch backwards. Stretch forwards. Don't slap somebody. All right, let's have our seats. Thank you. All right, for the ACLS session, Dr. Iseko will take us away. Thank you, sir.
All right. Good afternoon, everyone. Are we ready? Or you're tired? We've not overloaded your brain yet. This is the capstone lecture. Final major lecture of the day. ACLS, Advanced Cardiac Life Support. ACLS, what happens next? Can I have that clicker? By the way, if you want this t-shirt, they have outside. I didn't say anything now. All right. If you answer enough questions, I'll give you. All right. Yes, please, my slides. All right, I need you sharp. So you have finished eating now. So pens, paper, biro, you need to be sharp. What you will learn now will determine somebody's life. So you're not doing it for yourself. You are learning for somebody else. Very important. That person could be very dear to you. So please, 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 I need your full attention. If somebody is disturbing you, not slap them. Move to another chair. Please, focus, focus, focus. Okay. When you need it, some of you will not need this thing. Maybe in 2 years' time, that is when you will just remember that they taught me something like this. All right. What a guan. All right, so let's start. This is somebody's phone. I don't know whose phone this is. What is advanced cardiac life support? What is advanced cardiac life support? Thank you very much. So, to do advanced cardiac life support, not every facility can do advanced cardiac life support. But our hope is that once you learn, you will begin the push and the advocacy to get it in your facility. What do we need for advanced cardiac life support? We need a number of things. Number one, you need to have a defibrillator. You cannot deliver advanced cardiac life support without a defibrillator. Number two, you need to have a crash cart. And you can see examples of crash carts. Sorry, we brought one of our older defibrillators. The ones we are using now, some people, they had to shock this morning and it's on standby there. So, life more important. So, but we can explain with this one still. All right, you need a crash cart. Number three, you need a trained team. You need a trained team. A group of people that know what they are doing about ACLS. And that's why we are here. Number four, you need algorithms that have already been preset, that this is what you do when this happens, when this happens. And number five, you need checklists, because you need to check and make sure that you are always ACLS ready per shift. It's not when somebody collapses, they rush the person to your facility, that is when you start trying to buy adrenaline or buy amiodarone. It's too late. So you need to have that checklist. If you don't have that, how many of us have all those things in our facilities? Wow. Okay. That's why you are here. Checklist, crash carts, trained people, defibrillators, and then everything we need for BLS. Okay. Again, my name is Iseko. I'm an interventional cardiologist with Cardio Care. I will show you some interventions that we do sometimes here, also as part of ACLS, because you cannot do ACLS without knowing all those things. Remember that treating MI, which Dr. Adefila has done a good job on, treating stroke, treating PE, sometimes is all part of ACLS. All right, so let's go on straight. What is ACLS? It is a standardized, algorithmic set of treatments for life-threatening conditions. Algorithm is just a big word for step by step. If this happens, do this. If this happens, do this. Now, why do you need to learn ACLS over and over again? Every stuff has half-life, meaning that you will be forgetting. So you need to do it and remind yourself and remind yourself and remind yourself. Some of the things I will teach you today, you may not see it again for the next 5 years. But the day you see it, you should know exactly what to do to save that person's life. And when it is done well, people actually are alive. We've done countless. They are fine. They are doing very fine. So it's a set of treatments to deliver life-threatening. So, number one, a set of clinical guidelines for both urgent and emergent treatment of life-threatening conditions that have caused a cardiac arrest or that will cause a cardiac arrest. So ACLS is not only instituted when the person has had a cardiac arrest. What do we say cardiac arrest is yesterday? 3 things: unresponsive, no pulse, correct. Then we gave you a modified early warning score that can be used by nurses, doctors, everybody, to be able to identify those that are at the risk of a cardiac arrest. We've also taught you some conditions that are very prone to have cardiac arrest, like MIs, PE. And we've now said that the things that will cause or have already caused a cardiac arrest, ACLS needs to be started. And is using medical procedures, medications, and techniques. This, I believe, should be mandatory in nursing school, in physiotherapy school, in medical school. You should not graduate without it. Okay? And outside the country, every 2 years, you must get an official certificate. Otherwise, you can't practice in the hospital completely. Good. Do we understand that so far? Hello? Do we understand that so far? Very simple, Abi. Sorry, I know that when anybody tells something simple, you know it's hard. But just follow me. If you follow me step by step, we will understand everything. And once ACLS happens, the person that has been trained becomes the team leader. So you will be able to guide. So those people that are here, you are going to be the hope of the people. Remember, you need to write. Don't just say you will get the slide or snap it. Write. You can snap, but write. So, there are 8 steps generally, but as concerns ACLS, it's actually 5. But generally, we will say 8 based on the algorithm that we teach in ACS for Nigeria. First step, like we said yesterday, was preparation, Abi. Checklist, Abi. Then the baseline report we did, and then assessment. So let's go over it again. Are we prepared for ACLS? Trained personnel. Please, do we have the laryngeal airway masks now? Emmanuel, can you ask Mr. Victor, where are the laryngeal airway masks? Laryngeal airway masks. All right. So trained personnel, you need monitors. No monitor, you are in a primary healthcare center. Hello? How many of you are in primary healthcare centers? You are in a primary healthcare center. 2 types of monitors, basic or advanced. But you must have a monitor that can read an ECG at the very least. You may have an advanced one, great, good for you, but at least you have a basic monitor. Otherwise, you cannot do a CLS. Number 3, you need protocols, drills, checklists. So we typically started doing it quarterly, just drill. So when it happens, you are not thinking. It comes, it's at spinal level. It should not come from your brain. What should I do? You should do it before you remember what to do. So now everybody in the team, it's not that the person that knows it is off duty. Then we'll start calling from the house. No. Everybody needs to know it. If your mother cannot be admitted in your hospital, you need to go and fix something, Abi. Good. Number 4, crash carts. Crash cart. And I said if you cannot have a fancy one like this, get a cupboard and put wheels on it. Have all the drugs inside it. Number 5, you will need some point of care testing. You will need some ability to check blood glucose, sometimes troponin, sometimes D-dimer, even while the patient is in front of you. Number 6, you need a defibrillator. A basic one, yes, but when you are doing ACLS, you need an advanced defibrillator. So this is one. Suleiman, help me turn this thing so that the camera can catch it. Come now, come. Need a defibrillator. In ACLS, you are not waiting for the computer to be telling you do. Other people can do that BLS. But for this one, you need to read the ECG, interpret the rhythm, and deliver what you need to deliver. Okay? So just remove that part from it so that when they zoom their camera, they can see the front. Good. So one camera should just show that a bit. So so you need a defibrillator. If you like, buy second hand, but get a defibrillator. And then others. Cath lab will be great. ICU, excellent. Temporary pacemaker. Please go back to the slides. Temporary pacemaker, ECMO, and the like. So Cardiocare has a cath lab, one of the main cath labs in northern Nigeria. Okay, so everybody that needs, people come from the east, from the south, everywhere. So that if you need that, that can be done. And all those advanced things. Some of you have never heard of those things in Nigeria, Abi. So Nigeria is trying, you just don't know. Okay, so. All right, so trained personnel around the clock, trained and retrained. That's why you are here. You will need people that are trained in airway management. That is, they should be able to intubate. Okay, I know I intubated a patient 3 weeks ago. Yes. You should be able to intubate. You should be able to intubate, and it's not hard. Okay? Maybe one of the days we'll do an intubation sub-workshop. But for now, this is what we are talking about. Then, post-arrest care. This is what your crash cart should contain. So this one you can snap. This is what your crash cart should contain. So you can make a list, laminate it, and then attach it to your crash cart so that every day you people can check it. If you look here, you can see this is our you can see the road confidential because it's trademark. See it hanging there, Abi? can see it hanging there. It should be there on your own. So that you can cross-check and check. When somebody is dying, it's not the time to start. A running nurse is a bad nurse. A running doctor is a bad doctor. Okwinanu? Aha. Chotigbo? Aha. A running doctor is a bad doctor. You should not be running. As you are resuming, you check all of these things. Ambu bag, amiodarone. You see those ones in red? We are going to talk about them. Then the other ones that are for other things. Great. So far, so good. Easy, right? Not so? Hello? Talk to me, talk to me, talk to me. Even me, my glucose is down. I need ginger. Is it easy so far? We are learning things that we are going to go and use to change Nigerian healthcare. So these things, I know you will not have them, but now you are going to go and change it. Some people should not die. I'm sure yesterday some of you knew that people have died that should not have died. And so now today we are going to the next level. All right. So we've talked about preparation. Remember, BLS is still the basis. BLS is still the basis. Yesterday we talked about BLS. 5 C's, Abi. 6 C's. First C, checklist of where hospitals of which one of these things are there, and patients. And we say what we use for the patients. Modified early warning signs. Number 2, check for safety and responsiveness. Area should be safe. Blood, tap the person. Safety and responsiveness. Environment, check people. People carrying knife. Number 3, I showed it. What help is AED. In this case now, we are going more than AED. So they can bring AED, but your advanced team should be on the way. In most hospitals, you should have a code blue team. So when you start that CPR, the people that can do the advanced airway should be on their way. Consultants should be called in. Normally, it takes me about 7 to 10 minutes to get to the hospital. So they can start a code and maybe there in time. All right. People, crash carts. That's why the crash cart needs to have wheels. You can see the IV line is already hanging. You should be able to just move it straight to the patient bed and you are ready to go. Number 4, confirm arrest. And we said that should take how long? How long should you take to confirm your arrest? 5 to 10 seconds. 5 to 10 seconds. Great. And then we say cardiac arrest or respiratory arrest. Number 5, CPR. Number 6, ACLS. So we must remember this. We must remember this. This is still the basis. If you don't get this, you will still kill the patient. Defibrillator is coming in at that CPR. Compressions have started. Airway breathing while you are trying to connect your monitors, while people are coming, while you are doing. In this day of WhatsApp, you can almost run a full code with a WhatsApp. That is, somebody can be telling you, okay, do this, do this. If you are able to do that, just don't let people see you so that it's not like you don't know what you are doing. Great. Are we together? Fantastic. So, check safety, check pulse, extra hands, compressions, firm surface, 100 to 120 per minute, minimize lock elbows, straight, 32, amble back. We talked about that all yesterday. Now, let's go to primary and secondary survey. Airway, breathing, circulation, you need to check all of this while you are doing. And then 5H and 5Ts. Once you are doing that CPR, as someone that has done ACLS, you need to be thinking, what caused it? And start correcting it. Sometimes you are doing CPR, and what caused that arrest is hypoglycemia. And as soon as you give 50% glucose, the patient comes back to life. So 50% glucose should be your crash cart as well. Hello? So you see that most crash carts have a place for connection. Hypovolemia. Hypovolemia. Patient has lost a lot of blood. You need, as you are doing that CPR, you need to be rushing fluids. You should have pressure bags. Okay, and if you don't have pressure bags, you have human beings, Abi. They press the fluid like this. You press it. Press them, you know? The fluid is connected. You have a large bag can press. If you have a pressure bag, it's like a fig. You pump it, and it will put pressure on the bag while it's going in. So that is what. Then hypoxia, oxygen too low. Connect oxygen. Acidosis. You may need to give bicarbonate. Hypo or hyperkalemia. If the person has had renal failure, for example, and the person is crashing at this time, you should be taking hyperkalemia. And how will you correct hyperkalemia? Who knows? Who knows? Insulin and glucose. Insulin and glucose together. And slowly give calcium gluconate over 10 minutes. Calcium what? How did I say slowly? If you give it fast, now you kill them. Slowly over 10 minutes. Very slow. So it comes as 10 meals. That should be one of the things in your crash cart. You will sit down there. You have to get a chair so that you'll be giving it slowly. Slowly over 10 minutes. That will help to protect all the receptors around the heart and stop the extra contraction. If you don't correct that hyperkalemia, you will shock. You will shock, tire. Your machine will spoil. Shock, come back, shock again, shock. You need to correct the underlying things. Now, the other T is tension pneumothorax. You need to release the air, tamponade, toxins, and thrombosis. Coronary thrombosis is otherwise called myocardial infarction. Thrombosis in the pulmonary system is otherwise called pulmonary embolism. If that is the case, you will continue doing CPR. So as you are doing it, somebody should start thinking, what happened here? This is why ACLS comes in. And that's why we have to teach you. All of that is part of ACLS. So as you are doing it, you can quickly take blood and start D-dimer. D-dimer is elevated. This man was fine. Maybe his leg is swollen. At that point in time, you may need to give thrombolysis to get out of there. Awesome. So now let's enter ACLS proper. ACLS proper. Crisis Resource Management. Say it together. Good. Crisis Resource Management. So there are 4 principles of crisis resource management. Leadership, communication, preparation, and team dynamics. We've already done preparation. So in this case, we're talking about leadership, communication, and team dynamics. If you miss this, you will not be successful. Everybody cannot be Oga. Anything that has 2 heads is a monster. Hello? This is not the time to drag. Who is dragging? The most senior person becomes the leader. The most senior person or the person that has got the latest training becomes the leader. And I will explain why. This is critical in ACLS. It's not just about stuff. Everybody doing everything, you will kill the patient. So if I get to an ACLS code, I go to the head of the bed. I don't go and start doing CPR. I stand here. And then all information, communication passes through me. Sir, the ECG is looking like VFib. Really? Okay, you do this. I want to give this. I say, okay, give that. So you are the head as the leader of the team, giving the instructions. So leadership and team, that is very important. Please don't forget this. So one person must assume the role of a leader. He ensures that all tasks are carried out competently. So sometimes I am here. They now call one guy, doctor, so the person now comes. Doctor has come. And then he starts doing CPR like this. Will you get out of there now? Before I slap you. Do you understand? So you, the team leader, must know. Of course, you have to say it nicely too. But depending on my mood. All right. So you are the team leader. Maybe you'll be nicer and say, you know what, why don't you go to the airway and be pressing the bag? Abi? Because that person is going to kill that patient. Anytime the person comes, they're not giving. So you must make sure everything is done properly. You must coordinate communication. You must implement the strategy of doing and assess performance. then you must collect the experience and wisdom of everybody. I am not the best person. So when I'm doing the cath lab, it does not matter. Everybody, the nurse, the assistant, the cath lab tech, what do you think? What do you think? What do you think? And that is why we are very successful in our cath lab. What do you think? What do you think? Guys, is this okay? No, sir. You'll be surprised who will say, sir, that artery, we left it. You'll be surprised. And so when you get to the cath lab, you should be able to learn from anybody. Okay, fantastic. So you as the leader must be able to collect the experience and wisdom of everybody. Even someone that just came from here today, go in and say, sir, I think we should give you castle today. That person should be able to pick it up and say, you said what? Okay, why don't we give that? Just to collect it. So that's the leadership. Communication. Communication. This is ACLS. We are talking about how to execute ACLS. Communication. All pertinent information must go through the leader. All the tasks are assigned by the leader. So typically when you get to the head of the bed and the leader is there, the leader will find out who is tired. Or yeah, switch. It's 2 minutes. Switch. It's time to switch. It's time to check. It's time to shock. You shock. So all pertinent information must go to the team leader. Every communication must be repeated back. Give atropine. The person that wants to give will say, atropine, 1 milligram to be given. Everything must be repeated back. Otherwise, you will give the wrong drug. Give adrenaline 1 ampoule. Adrenaline 1 ampoule. The person will repeat back. And when they want to give, adrenaline 1 ampoule about to be given, given. Do we understand that? Good. There is no mago in this one. All right, I need 10 mils of 50% of glucose given. 10 mils of 50% glucose being given. That's how you do it. So you will coordinate all of that. All right. Please, you need to remove everybody else that is not. Some people are just there. They are hospital staff who are just watching and say, "Kai, oh, wow." Then the worst people bring out their phone. Thunder, fire them. I will seize that phone for 1 month, I swear. It's not me and police. All right, so at the end, you debrief the team and learn anything. So, preparation, we talked about preparation. So, clear roles, team dynamics. One thing I should talk about team dynamics, you need to have these roles in your team. There must be a leader. There must be at least 2 to 3 people that are performing compressions. So all our housekeepers, our hospital assistants, our security men, they are like this. Those guys can compress. My God. My God. Some people are alive because of them. I'm telling you, they can compress. And they don't get tired like us. And they have been trained. So you're tired. Move next, move next, move next. Okay? So you have people. You should have somebody on the airway. So remember how we showed somebody should just hold the airway and that person should be bagging. And if you have someone that can intubate, the person should be trying to intubate then. While other people are doing that one. You should have somebody taking IV access and giving the drug so that nobody gives 2 drugs twice. Whether to give 1 drug, you not give the wrong drug. Somebody should be in charge. Then you should have somebody on the monitor. And very important, somebody to document. Please don't forget, there's an app that was launched in Kenya for recording CPR, for guiding CPR and ACLS and recording it. If I remember the name before, I will share it with you. That person should record. That person will tell you how long you have been doing CPR. How long have we been doing? 35 minutes, sir. How many adrenaline have we given? We are giving 6. How many atropine? They are recording. They are recording for medical legal reasons. They are recording so that you know when to stop. They are recording so that you can write down all of this and also so that you can replace it. Yes. If you use everything for somebody and say you saved the world and you not put another on, the next patient will die. So you need to know what you have used and replace it. So very important in all of that. Is that clear so far? Very simple, Abi. Basic stuff. So let's start going in. Now let's enter the cocoa. Are we ready? Some people are tired. Don't be tired. Don't be tired. After today, tomorrow is weekend. You sleep small. Then you find somebody to teach ECG, Abi. Sunday again, you find another person to teach ECG. You reach church, you gather your church people, say, come together. I want to teach you something. All right. So, reading identification and treatment. ACLS treatment starts and hinges on the correct diagnosis of the ECG reading. If you miss the diagnosis of the ECG reading before or during the ACLS, you will not be successful. You will need a miracle. In that case, you may as well just be praying. Why are you here? You should be somewhere else learning how to pray. All right? Otherwise, you should learn. And that is why I took a lot of time teaching the ECG. You cannot successfully do ACLS without learning ECG. So the whole of today has been ACLS, really. It's just that the way we broke it up in a way that it can be assimilated and used here in Nigeria. Good. Sorry. So what are the ACLS rhythms? There are two types of ACLS rhythms. Two major types of ACLS rhythms, according to Cardiovascular, according to me. Number one, the cardiac arrest rhythms. And number two, the non-cardiac arrest rhythms. Hello? Talk with me. Stay alive, stay alive, stay alive. Right. This is the cocoa. If you get this one, just wake up, just stay alive. Chew chewing gum. Stand up if you must. Stand at the back. Two types. Cardiac arrest, meaning there is no pulse. Non-cardiac arrest, meaning there is a pulse. Right? Once there is no pulse, it's an arrest. Once there is no pulse, once there is a pulse, it's not arrest. So there are two types of ACLS rhythms: cardiac arrest and non-arrest rhythms. Is that clear? What is the difference between the cardiac arrest rhythm and the non-cardiac arrest rhythm? Pulse. If the pulse is there, no problem. If the pulse is not there, we are having a cardiac arrest. Perfect. So let's go deeper. For the cardiac arrest rhythms, there are two groups. The first group is called the VFib or the pulseless VT. Ventricular fibrillation, which we said on ECG is like what? Ventricular fibrillation, what do we say it's like? Jaga jaga. And the ventricular tachycardia, what do we say it's like on ECG? You remember? What do we say ventricular tachycardia? VT. Wide QRS, bizarre, multiple, occurring next to each other, not one occurring next to each other. So wide QRS, multiple, very fast. Abi? So if you have these ones and no pulse, these are shockable rhythms. This first group, anytime you see them and there's no pulse, you must shock. Sometimes even the notes you wrote after the person died, if they took you to court, you will not survive. You will not survive. You did not check the ECG. You did not write what you saw. You did not shock. You did not keep any record. Okay? So, by the time you are doing CPR or the person has no pulse, CPR has started, Abi, then you are putting your pads. Don't mind how old this thing is. It has given its life. It's still working. Take the pad. One under where? Right shoulder and another one under the left breast. Good. So we stick it there. I don't want to waste this one. It's not 300K or something. All right. So you put it like that and you stick it there. Then this will start reading the ECG. You can see the ECG. Once it is ventricular fibrillation, which is like jaga jaga, or there is a VT, wide QRS, very rapid, very wide, and there is no pulse, you must shock 200 joules. If you are using this type, you turn it to 200 joules. You press charge, this number 2, charge. After it's charging, then you will now shock. Everybody, what do we say you must say before you shock? You will say clear, everybody will now shout all clear. So clear, then we will now deliver. Bing, boom. All right? Very simple, but it works. It works like magic. Oh my God. It's extremely rewarding. Extremely rewarding. You know, when the patient is back and they are not arguing over whether they should pay or not, you are looking at them. All right. Poverty is a bastard as well. This is supposed to be covered by insurance. You're supposed to just be doing it and nobody should be thinking about everything. All right. So Now, the second group of arrest rhythms, pulseless electrical activity or asystole. Asystole is the one you see in movie. That is like flatline. It doesn't mean the patient has died though. Continue your CPR. That now for Nollywood. It's not for real life. It is an actual rhythm. And sometimes you'll be doing CPR, it will go to asystole and come back to VFib, and you will shock, and the patient will come back to life. So don't follow that thing. Number two, I see some people, they want to do CPR, they now do take torchlight and put in the eye, and say, people is fixed and dilated. They don't cool. Then they just walk away. No, there's nothing like that. You continue. Assume it's your relative. Give your best. When you give up, after you have done your best. Cancer patients, you don't give up. You do go ahead. Except they have an advanced directive. Some people in cardiac care have written, do not resuscitate. The person has tried. They sign that, look, I've tried. You have resuscitated and they've come back. 2 days later, 5 days, they came back again. They say, oh boy, the next time, please, allow me. Allow me. Because truly, if you do some of these things very well, sometimes you can continue like that. Then, you know what will happen? Like I will show you some cases today, if we have enough time. Like those devices that those people are selling. We put a device inside called an ICD, and it interprets the ECG and delivers the shock. So it can continue keeping the person. For somebody has come from Katsina like that, boa, 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 almost 20 before he reached Abuja. Yeah, but he's alive. Got to Abuja, we found what the problem is, tried to fix. The device had run down his battery. We changed the device, put another one, and he has gone back. The device is there still. Okay? So, do you understand? So, those devices too are life-saving. Anybody that survives a cardiac arrest successfully, you need to put on all the devices to make sure that if they have it again, something can save them. Don't let poverty kill anybody. And if a person is too poor, we have some donated devices in cardio care. But don't bring someone that will come and be asking us for private room and asking for donated device. That's a lie. We have some donated devices from donors and from cardio care for patients that cannot afford it. I think you should give a round of applause now. This is about to go off. All right. So, non-arrest rhythms. So, we have talked about these arrest rhythms, Abi. The first set you shock. The second set you don't shock. This pulseless electrical activity. In pulseless electrical activity, what will you see? You will see normal ECG. But when you check, you will not pulse. The ECG is looking fine. Don't say, the man is fine. No. Check. If you cannot feel a pulse, you don't have. Now, when you are checking for a pulse, please stand up, sir. Let me use a man. If you are checking for a pulse, don't start checking pulse here. You may not be able to feel, and with all the adrenaline, everything shouting, you want to check a central pulse, carotid or femoral. Then sometimes you can come over here, but this is the main pulses you are checking. If you cannot feel a pulse and you are seeing this is still PEA, you need to continue CPR. You need to continue CPR. There's electrical activity, but there's no mechanical activity. The electricity is transmitting, but the heart is not picking it up. Thank you. All right, so what are the non-arrest rhythms? The first set of non-arrest rhythms are those that are fast. Narrow complex and wide complex. Remember, they have a pulse. Who knows the difference between narrow complex and wide complex? Hello, sister. You look like you know. Who knows the difference? Guess.
The QRS come.
Awesome. Let's clap for her. Exactly. This life is not that hard. We have already read ECG, so we know it. You are just afraid. Don't be afraid. We will give you a certificate today so that you can carry your shoulder. Yes. Don't be afraid. The heart rate is fast. The heart rate is 150, 160. Now, what you need to look at on that ECG is it narrow or is it wide? That will differentiate what you will do. Is it narrow or is it... What is a wide QRS? Who remembers? More than half of a big box. Awesome. Awesome. And then we now have bradycardia. Bradycardia is just too slow. Like the case I was telling you, the man just developed bradycardia. Immediately I put in a temporary pacemaker. Took it over. No wahala. After a while, everything stabilized. I fixed the heart problem. I removed the temporary pacemaker. Okay? Now, in bradycardia, if you cannot put in a temporary pacemaker, temporary venous pacemaker, and you have this same kind of defibrillator or any of these defibrillators, some of you have it in your hospitals, maybe it's locked up in an office somewhere. Look at it again. On the defibrillator, there is a pacer written here. I need one camera that will come and show. There's a pacer. There are newer ones, final ones. Our newer ones are in use now. There are newer ones, final ones, that have pacers on it. As you put these pads here, although for pacing, it is better to put at the front and at the back. But still, from here to here will work. Once you put it there, you turn your machine to pacing. And then you change the heart rate. So you will control the heart rate from here. It will now be delivering an electrical shock in between the two of them, and causing the heart to beat. That is for bradycardia. Hello? Any of you ever seen this before? Okay. So now you know, Sha. So you put it on, you will turn it, you will now start seeing the QRS beating. You need to check whether there's a pulse. Sometimes you can have electrical capture, but no heartbeat. You may need to increase the amount of current passing through. That is for a slow heart rate. Okay, so we've gone through two sets of rhythms. What are they? Arrest and non-arrest rhythms. And they are differentiated by whether they have a pulse or not. For the arrest rhythms, we have a shockable set and a non-shockable set. The shockable set are those, which ones? VFib and VTAC. The non-shockable are what? PEA and asystole. While for the ones that are non-arrest, the pulse is present, but it's too fast or too slow. We have tachycardia, which is narrow or wide. And we have bradycardia. Is that not all? It's not simple. Thank you. Somebody finally believes in me. All right. So now let's go a little bit deeper. So you know what? If I get tired, I'll give you. All right. Cardiac arrest, no pulse. What pattern is this in this cardiac arrest? Possible? Yes, ma'am. You are the one running the code. You just brought certificates. So everybody came to you, ACS certified. Yes?
I'm going to guess.
C. That's not a guess. That's a good guess. You have a no pulse, but you have an electrical activity. That is what? Pulseless electrical. Can we clap for her? You see? You know it. You just need to practice a little bit and have some confidence. So that is, you have no pulse, no breathing, unresponsive, and you have this ECG on your reading. You cannot do ACLS without a monitor again. You cannot do ACLS without a monitor. That is witchcraft. Abi? It's witchcraft. How can you know? VFib. Na lie. Okay? That is witchcraft. All right. What about this one? What about this one? Choose quickly. Talk now. We don't have time. But the patient has died though. The patient is still waiting like this. She's losing though. Hey. Do what? Talk now. Talk. Choose one. Just choose one. B. No. Choose one. Choose. Go ahead. Choose. Anyone. Choose now.
B.
B. She said B. What's B? Pulseless ventricular tachycardia. Ventricular tachycardia. What do you say about what is VT? What do you say VT is? Wide. Multiple together. Is there anything wide and multiple together there? What can we see there? Asystole, Abi, almost flat, Abi, and there's no pulse. So D, Abi, should you shock this one? No. What should you do? Continue CPR and give adrenaline. Hello? Perfect. So, for the non-shockable rhythms, most times non-shockable rhythms are the ones that are caused by hypoglycemia, hypovolemia. They've lost a lot of blood in labor room. Okay? They are in theater. Something is happening. somebody has intubated the stomach instead of intubating the intubating the trachea. Abi, has it happened before? For those of you that have been around, you must have seen one in your life. As soon as you notice it, you start your CPR and you should know what to do. Start checking the 5H and 5Ts immediately. Adrenaline, 1 milligram, and repeat every 3 to 5 minutes while you continue CPR. Okay? Great. Isn't that simple? So, any of those non-shockable rhythms, we've showed 2 of them. We showed a PEA, no pulse. This one. Okay, now, what about this one? What do we think this one is? Are you sure? Dr. Iseko, come and help me. Cardio care, come and establish a branch in Aba. Please. Yes, ma.
Ventricular fibrillation.
Awesome, awesome. Let's clap for her. Let's clap for her. Everything jaga jaga. But very important, check that the ECG cable is fixed well. Sometimes ECG just came off. I'm telling you, we're doing a case. We just look VFib. Somebody's grabbing. I say, Oga. The man say yes. I say, ah. They would have find wire back. Before we would have shocked a hopeless person. All right. So very important. What about this? So same thing, Abi. If you are doing ECG for the person, you are the nurse, and you just notice this one, you have to start doing something. Or you are the physiologist, Sharon. What will you do first? Notice this one. Call for help. Thank you so much. I am telling you, help, help. And then you start your CPR, and you are calling for that AED or defibrillator immediately. Now, another thing that has been shown to help. Hello, watch this, please. Watch this. Especially for those of you that have nothing. In a witness CPR, it is believed that a precordial thump can give a small amount of electrical activity and can revert it back to a spontaneous rhythm. That is, here in the sternum, if you saw the person giving, it's believed that it can give up to 10 to 50 joules of energy, especially if you did it within 10 seconds of the event happening. That's why critical patients are in ICU, so that the nurse can be looking at the monitor like this. It's not so that they can be chewing gum and be moving around. No. So that they can be looking at. So when they see that thing, if you don't have this, or before they bring it, it is believed that this may be able to give some. It's not fully certified because it's not a study you can do, So different evidences have shown to some extent that can help. For those of you that don't have CPR, don't start blowing people's chest too. But you understand what I mean? Of course, you are already knowing that please, be an advocate. If your hospital does not have a defibrillator, we are in trouble. We are in serious trouble. Please. And if your hospital is very big and you have only one, that before they find it, they need to go 130 minutes, find somewhere. It's the same thing. You don't have a defibrillator. Both of the people that don't have and you, they are the same. The people that cannot read and the people that don't read, both of them are the same. I'm sure you know, ba? Slide, please. Slide, though. All right. No pulse. What do we think this is? What do we think this is? I have some interesting live cases that I will show you. What do you think this is? Now, as you are seeing this, you will recognize that you have probably been seeing these things. You probably have been seeing it, you just did not recognize it. Sir, what do you think it is?
To me, it's almost like the jaga jaga.
Okay, but does it seem a little bit organized? Up, down,
it's
up,
organized.
down,
yes,
up,
it's
down.
organized.
It's organized,
Yes,
up, down.
yes,
Is it a little bit wide?
Yes, it's wider. It's wider than.
So that organization, what do you think it is now? Wide, QRS, just beating very fast.
Positive ventricular tachycardia.
Correct. Pulseless ventricular tachycardia. Can we clap for him, please? It is very important to qualify that it is pulseless. Very, very important. If there is a pulse, do not shock. If you shock somebody with a pulse, you can tick them the other direction. If there is a pulse, what did I say? Do not defibrillate. Not do not shock, not defibrillate. You can cardiovert. I'll talk about that one later. Do not defibrillate. Do not defibrillate. Hello? You feel a pulse. And you saw this one. I said, ACS, they said we should shock. Boam, 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 boam. You're on your own. Do not defibrillate. All right. Continue to exclude. Now, very important for this shockable reading, that after that 1 milligram of adrenaline and you continue, you shock adrenaline every 5 minutes, you keep on checking. By the second or third shock, you need to reach for your crash cart and bring out IV amiodarone. I prefer by the second shock. I don't have to wait for third shock. By the time you have shocked once, you gave adrenaline, you still saw it continue. Shocked again, you still saw it continue. Reach for IV amiodarone immediately. You need to give IV amiodarone to stabilize that heart. Okay, so we have a series that I think we have published or we are publishing on what we call ventricular storm. Someone that is having repeated VT for almost 24 hours. Shock, 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 shock. There's a way to manage that one differently. I'll keep that one for myself. I can't give you all my secrets, Sabi. Let's learn this one first. So, have you ever given IV amiodarone? IV amiodarone. Who's raising hand there? Are you in cardio care? IV amiodarone. So now you need to go and make sure it's in your crash cart. If you don't have IV amiodarone, what can you use in its place? Lidocaine. That same lidocaine used for local anesthesia, you can use it. That same one. So go and look for it in your crash cart and put it there if you don't have amiodarone. You need to check the dose and check that what you have will match the dose. So if you are deep in the village somewhere, if you have IV lidocaine, you can use that in its place. All right. So cardiac arrest, first thing, check the rhythm. Abi? For cardiac arrest rhythms, we have two sets. What is the first set? Pulseless electrical activity and asystole, or read your book. What's the second set? Pulseless VTAC or VFib. So for the one that is asystole, adrenaline, CPR, continue CPR, adrenaline, CPR, continue. For those that are pulseless VT or VTAC, what do? Shock. You shock, continue your CPR plus adrenaline. After adrenaline every 3 to 5 minutes, check and treat your 5H and your 5T. Abi, remember that while you are doing that, you are shocking. This is why you cannot do ACLS, one person, 2 people, 3. You need at least 5 people. So if you are already 2 people on your duty in your hospital at night, already know that, people can die. Abi? Now, after the second shock, you've given the shock, continue CPR. After 2 minutes, you checked again, it's still doing. You give CPR, you need to now give IV amiodarone, and then continue what you are doing. By this time, you should be calling for specialist help. What should I do? What should I do next if you don't know what to do? Hello? Is this simple? Is this basic? Should I go over it again? Cardiac arrest, no pulse. You started CPR. They've now called you. You came from ACS. First thing you did was connect the monitor while they were doing CPR. You saw it was asystole. You said they should continue. You should give adrenaline. And then you start checking the blood sugar, checking the oxygen. What was the last A and U? Should we correct hypokalemia? Should we give bicarbonate while they are doing that? Or you checked and you saw VTAC, or jaga. What do? You deliver a shock. Continue CPR every 2 to 3 minutes. You check the rhythm again. CPR, adrenaline. By the second shock, third shock, you should add IV amiodarone. I would say if you don't have IV amiodarone, what should you use? Lidocaine. Please pay attention. Please pay attention. You may be tired. This is not the time to get tired. This is the reason why you are here. This thing I'm telling you, you may not remember it. You may not see it again for the next 2 years. What I'm telling you will be the patient's only saving grace. You must be committed enough to know it. For those of you that will jackpot, they will send you back if you don't know this thing. I'm telling you. Now here will they play. All right, we remember our 5H and 5Ts, right? Sometimes it's hypothermia. Somebody has drowned. You see they have, especially children. you're starting this in children, you need to make sure they are properly wrapped, head particularly first and foremost covered. Even post-delivery, cover that head first, and then you continue what you are doing. All right. So, TRB example, stroke. So we talk about these three ones. If it is a thrombus, before arrest, the things that can help you differentiate, they could have been neurologic deficit, loss of consciousness, and a possible CT scan. That will tell you are dealing with a stroke. If it is a STEMI, before the arrest, the person may have held their chest pains, angina, troponin may be elevated, and ECG may be suggestive. Sometimes while you are doing it, sometimes some people got ECG. They did ECG in the ECG room. If you're in government facility, maybe you have an ECG room. Those people should have been here. They got MI, and then they sent inside the patient's file, and nobody opened the file. It has happened though. Now you are doing CP, called you. You want to check those things quickly. This is MI, and you are doing it, that you can thrombolize there. While you are doing CPR, we've done it severally. Okay? So, suggestive, and if it's PE, you already have all of these things happening, elevated D dimers, and you can check. That's something to remember. That's why we have to do it. Again, we've talked about all of this, right? So no need to waste time here again. All right, this is a real life case. I saw the man on Saturday during heart failure support group. What can we see? Anybody? Can anybody explain? This is the timeline of what was happening. This is 1:50 a.m. at night. This timeline, something happened, shock came, and it came back to here. What rhythm is this? What rhythm is this? Some people are not sure. Those that say PEA, say I. Those that say asystole, say I. Those that say ventricular fibrillation, say I. Those that say ventricular tachycardia, say I. Which ones have it now? So, we can see that it is regular, it is wide, and if you look carefully, can you see a P wave before the QRS? P wave before the QRS. So, it's not really jag-jaga, it's regular, it's regular. At this point, it starts becoming almost VF, baby, and then the shock, POAM! I gave this guy the shock myself, and then fiam, he came back. Okay? This is about 3 years plus now that the man is doing very well. And you know what the man said when he came back? Why are people making so much noise? I'm telling you, some people are very rude. Because he lost pulse, because we said, he started having a seizure, you know, their eyes start going up. I said, why are you making so much noise? At 1:50 a.m., you can imagine. Anyway, let me not say anything. All right. All right. So I need to go to the next level. How do we do that? All right. So we've talked about the first set, Abi. Shock, shockable, adrenaline, atropine, Abi. We've talked about that. Now we are talking about the second level. And for the second level of non-arrest rhythms, we have to ask ourselves one question. When you see that non-arrest rhythm, is this person stable or unstable? Hello? Stable or what? How do we define that somebody is unstable? If they have hypotension, low blood pressure, if they are in shock, if they are having chest pain, if they are having heart failure, altered sensorium, they are unstable. So those ones, you need to act differently. So for wide complex tachycardias, the ones that are stable, you use drugs. The ones that are unstable, you need to cardiovet. Cardioversion is another type of shock. There are two types of shock. Everybody say two types of shock. First type is called defibrillation. We raise it to the maximum, typically 200 joules, and we just POAM! Emergency. The second type is called cardioversion. Say cardioversion. In cardioversion, the energy we use is much lower. 50 joules, 100 joules. And then we don't give the shock at any way. We synchronize the shock to the QRS. That is, we want to deliver the shock exactly at the same time of the QRS. How do we do that? It's not by looking at it with our eye and pressing it. No. We will press the button on that machine. This machine, I don't know, it costs about 10 million naira now, or thereabouts. Of, I don't know, maybe 12 million. But the day you use it, you thank God. you will press something that says sync on it, and it will identify the QRS, ping, 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 so that whenever you press the shock, it will not deliver the shock then. It will wait for the next QRS point, and it will deliver the shock at the same time. Because if the shock goes at the wrong time, it can stop the heart. Okay, so that's the difference between cardioversion and defibrillation. In cardioversion, you're using a lower energy. In defibrillation, you're using what? A higher energy. In cardioversion, you are giving that any time of the cardiac cycle. In defibrillation, you are giving it where? QRS, at the peak of the QRS, synced to the QRS. So, in the non-arrest rhythms, we don't defibrillate, we only cardiovert. And we cardiovert only those that are unstable. Somebody during the break came and showed me an ECG of somebody that they were managing and got very bad. They moved to ICU, and she showed me the ECG. And I said, read it for me. And she read it very well, thankfully. And she said, this is an atrial fibrillation. I said, atrial fibrillation, fast, somebody is unstable, what do you do next? You need to, what will you do next? Hello, what will you do next? Cardiovert. Okay? That is ACLSO. Fine. So we'll go through them now. Why did I get all these ones? All right. So let's go to the tachycardias. We are going gently. We'll soon finish. Don't worry. I know you are tired. But please just hold on. Just hold on. This is too critical to miss. If you are feeling sleepy, just stand up. Just stand up at the side. Catch this thing. Swallow it. Pulse or heart rate greater than 130. What is our first question? Is the person stable or what? What defines as somebody that's unstable? What? Hypotension, shock, what again? Chest pain, what again? Heart failure, you did not write, that's why you're looking at me. Heart failure, what again? Altered sensorium. Hypotension, shock, chest pain, altered sensorium, heart failure. All that tells you they are unstable. So whenever you have this pulse greater than 130, you're already almost thinking of ACLS. Now I know sometimes high fever can cause that, but you need to think about these other ones first. I use 130 just to increase it. Normally it's about 150. But for just to make sure that your index of suspicion goes high. Okay, so that if the nurse picks 130 on the ward, they should call you immediately. At least you that came for ACS, you should come as team leader, you know. I went for ACS. Bring the ECG. Abi? Yes, no. I want here. All right. If it's unstable, what do we do next? What do we do next? How do you cardiovert? You synchronize, reduce the joules, 50 joules, 50 to 100. What's the dose of the shock you are delivering? 50 to 100, and you synchronize it before you shock. You cannot do that if you don't have this kind of device. You cannot do that with an AED. You need a proper device. That means you must have that device. After now, you are going to go and make a case for it. So if you cardiovert, you continue with medications. If the person is stable, what do? Decide, is it wide or narrow? If it is narrow, vagal maneuvers. Unstable. Well, until whether it is wide or narrow, you cardiovert, have you? Let's leave it. Vagal maneuvers or medications. I'm trying to teach you something that should take a full day to teach in 20 minutes, in 60 minutes. Any questions before I move further? Any questions before I move further? Is Dr. Adedoku around? I saw her before. She has gone. Any questions? Yeah? Yes, go ahead.
No, my question was just whether you could expand more on the vagal maneuvers.
Okay, vagal maneuvers. Thank you very much. Vagal maneuvers are typically very simple. Number one is to bear down. That is as if they want to pass a very hard stool. It's expiring against a closed glottis. Close if you want to expire, but you close your... So you are pushing out. The other way to do vagal maneuver is to take a syringe. Can I have a syringe there? There's a syringe there. Take a syringe. Okay, that's good. There's one syringe here. Take a syringe, remove the plunger. Right? Now tell the person to try and blow out from this open place through here. So they'll put on their mouth and try and blow out. That will, if you, while you are doing that, you'll be checking your ECG. It can also revert. Another way is to do what we call a carotid sinus massage. Please, sir, sorry. Carotid sinus massage, you're tired. A carotid sinus massage. Before you do that, make sure you listen that there's no sound in the this. Otherwise, when you touch that place, you will just cause a stroke. Don't do both at the same time. You will just find the carotid. Remember we felt the pulse yesterday, Abi? Then you just massage while you are watching the ECG. And sometimes you do that, you see the thing just reduce. From 150, you just come down to 80. Okay? That's what vagal maneuvers are. Thank you so much for asking. Everybody understand that? I should go over it again. No, good. So, while you are doing all that, make sure you have IV access, oxygen, ECG. Remember, the person has not had a cardiac arrest. So you may have some time to be on the call, to be on a WhatsApp call, and to start this one while you are trying to transfer. Check and treat and reevaluate. We are about to go to mega code. Never defibrillate when there is a pulse. After I explained all of this, Abi, remember, these are just the doses. If it is narrow and irregular, 50 to 100. Now, can the camera just show here? On all your major defibrillators, you will see a dosing here. We will see a dosing. If you can look on the screen, you can see the dosing here. On all your defibrillators, you will have that. And you can easily turn and choose the level. In some of the newer ones, it will be touch screen. In fact, I don't think you can find this one again. This is a very, very old one. But it has done work. You turn it. So you want to be between 50, there's 70, there's 100. You want to be between 50 and 100 for the narrow regular. For the narrow and irregular, you want to do something wider. Or for the wide regular. That wide regular is which one? Which one is often which one? Wide, QRS complex, regular. Which one is it normally? VTAC, Abi. So you want to use more of 100. Okay? And in cardiac arrest, you defibrillate. 200. No need to synchronize. Press, deliver the shock. Okay? Cardiac arrest, what do? Defibrillate. But check if there is a pulse. Do not defibrillate. Do not defibrillate. All right. What drugs can we give? If there is a pulse in VTAC, pulsed VTAC, that is there's pulse, there's VTAC. These are the drugs we can give. We can give that amiodarone as infusion, and we can give adenosine. That's normally for this one, but put it there. In narrow complex, vagal, remember the vagal, what do you say the vagal maneuvers are? Sinus massage, bear down. What's the Hausa for it? Nishi or something. Yeah. Bear down, push over a syringe, and then carotid massage. All of that are all important. Some people have even tried putting ice block on the person's face. Wow. Okay. Now, IV adenosine, but IV adenosine is very difficult to find. And if you give IV adenosine, you must give it fast. It only lasts in the body for 3 to 6 seconds. So if you give it too slowly, you give it and flush it immediately. Give it a 2-way. So you can flush it immediately. Because in 3 to 6 seconds, it will disappear from the body. So if you give it too slowly, it might not even reach the heart before it disappears. So you need to give it fast enough to get to the heart and it will just calm it down. Very, very effective. Extremely effective. I love the drug. Okay? Beta blockers and calcium channel blockers. So we are going for bradycardia. This is the final of the rhythms. This is the final of the rhythms. Just bear with me. For bradycardia, if they are stable, observe. Treat for any reversible causes, sometimes hypothyroidism, and prepare for permanent pacing. You can send to cardio care, and we can have. Medtronic and people that have the pacemaker, can you please just pass around your pacemakers? Genos and Medtronic, are they still around? If you have your pacemaker, just pass them around so that people can see and hold what a pacemaker looks like. Don't put it in your pocket, so it will not help your ministry. Just pass around so that you can see and feel what we put under the body. Very small, under the skin. Please, can we do that, please? Genos guys, Medtronic guys, please, can you bring your pacemakers and then just pass it around. Let people just feel and see what it looks like. Now, if they are unstable, you have no pacemaker facility. You are from Gombe, Kebbi, I don't know where again, that does not have a pacemaker facility. You have no temporary venous pacemaker. You have several options. First option, which is in your crash cart, atropine. Atropine. It will work in some cases. You have to give immediately. Hello? Please, I need you to focus. The person is in front of you, they are crashing. Their pulse is weak, they are unstable. They are not seeing very well. And then you check, their pulse is 20. Really, 20. I've ever seen somebody with 20 before. Have you ever seen somebody with 20 before? One, no, yeah, I can't do it now. Have you ever seen somebody with 20 before? 20. Sometimes people have even said they were dead. There's one person that they said he was dead. Then the man moved again. Everybody started shouting. I'm telling you, 20. Some people 15. So what you do first, you start the atropine. Then you do transcutaneous pacing. How do we say we do transcutaneous pacing? Hello, who remembers? We take this thing, a pad of our defibrillator again. You can see no monitor, no defibrillator, no ACLS. Take it, put it either the normal way you put it, or one in the front and one in the back, and then you turn it up. It's painful, sha, but you have enough time to now move the person to a center that can put a pacemaker, like cardio care. You can put it front and back, enter the ambulance. It's a little bit painful, so you need to give some sedative because you'll be delivering shock. Cham, 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 cham. But the moment you stop, you know, say, so now sorry. So now, if you don't have all of that available, what do you do next? Adrenaline infusion or dopamine infusion. That also can help to push the heart rate enough for you to move to get what you need to do. Is that clear? We're about to enter what we call mega code so that we can now test ourselves. So remember all of these things. So airway, I will not talk about airway too much. I'll jump all of this. Example of a case, 56-year-old woman. This is a real life case. Came in, known hypertensive diabetic for over 10 years. Exforge, bisoprolol, galvosmet, Amaryl, atorvastatin. This was our ECG from the referring hospital. What can we see? What can we see? Read the ECG now. Quick. Where are my ACS graduates for 2025? Those are going to make me proud. Woo! Yeah! Who is not looking away from me? Yes, ma. Can you try? She says ventricular tachycardia. Do we agree? Very likely ventricular tachycardia. So they sent to our hospital. When the person came, this was the ECG we saw. Miracle. No, they tell it's gone, Abi. We didn't find anything. So if it lasts more than 30 seconds, we call it what? Hello? More than 30 seconds, we say is what? Less than 30 seconds, we say is what? Non-sustained. Have you started passing it around? Be passing it around so that they can just hold it, feel it. There are different types there. One is ICD, the one that can deliver shock, is the bigger ones, and the pacemaker is the smaller one. So can you just pass it? Let them just hold it. Don't worry, they will not steal it. You can be using your eye and following it. That is from Abbott. Abbott. So Abbott also supplies devices. Great. Fantastic. I mean, you need those devices are life-saving. All right. However, in the middle of the night, again, what can we see? Normally, our defibrillator, when you deliver a shock, it prints this one out. This one is meant for medical legal reasons. Maybe you defibrillate, if you have the paper inside, it will print for the last 2 seconds till the shock and a few seconds after. Can we see that here? What can we see here? VTAC, wide complex moving, shock. and then it comes back to normal. Can you see? Who can read what is here? Shock number what? Number 6. Can you read what is here? Shock number 8. Woo! Telling you. It's not funny. But she's alive today and doing fine. That's a good thing. 2 years or so after. Now, in this time, one of those devices is in her body. An implantable defibrillator. So that if you look, you will see when the monitor changes. Can you see this monitor? What is this? VTAC. And then the device delivered a shock and it changed to normal. So she would just say, something. And then it came to normal. As you are seeing this, some of you have seen this on your monitors. But you continue watching. And you kill them all. Now you go back, now you can see your monitor better. Abby, thank you so much. So you can now, if you don't even have all of these things, at least you can start some amiodarone, you can start something. This was our ECG afterwards. This is another man. This is one that we showed before. What can we see in this ECG? What can we see? Anybody? Want to try? Don't want to try. Lie. Yes, what can you see? Ventricular tachycardia. Ventricular tachycardia, Abi? What did we say? When it is 3 or more. 3 or more. See the normal beat. 1, 2, 3, 4, 5. Another one came in. Then it became normal again. So once it's 3 or more, we say it's ventricular what? Tachycardia. However, it's not up to 30 seconds. So when you are reporting this one, you will say a non-sustained ventricular tachycardia. This is a red flag. If you pick this up, don't joke with it. You may lose that patient within 1 week, 7 or 3 days. Okay? So took the patient to the lab. This was the same person that we had to shock. And then we put a device for him. Now you see what the device looks like. We just put under the left clavicle, insert some anesthetic, local anesthetic, take our leads, our wires down. Some of you are passing the device around. Please feel it before you go. You may never see it again in your life. There are people that are qualified and never seen it before. So just see it before you go. Then we'll take our lead into the heart and connect it to the device. This device now will constantly, it's like an AED inside the heart. Constantly be reading the ECG forever, just there till it dies, which can last up to 8 years, 10 years sometimes. And whenever it feels a shock, boom! There's a man we put on Friday. By Sunday, he had 3 shocks. You know that should have been by and by, Abi, if he did not put it. And then there's somebody that we put, he never had anything. Until the 3rd year, they started having shock. So you can see that it is extremely important. Is it cheap? No. Is it important? Yes. No. When the time comes. All right, so ICD in and the man does well. So let's do the ACS miracle. This is our final testing. This is interactive. Interactive. Every question, we have 5 seconds. Wake her up, wake her up, wake her up. Well done, ma. Well done, ma. She's responsive, so no need to call for help. If you tap somebody and they're not responsive, please shout for help. Help! Somebody here. Okay. Fine. So, I'm going to give you 5 to 10 seconds for anything that you see on the screen to give an answer, because that is about the time you will have. You need to try. Don't sit down and be detached and not try. Say something out. If like say the wrong thing, it's better than not saying anything out. That is the way I know that you've learned it. Okay? Are we all together? Can we start? You are ready? You're ready? All right. So, case 1. 52-year-old collapsed at rally. Bystander performed CPR at the scene. He arrives at your hospital. Okay? Umaru and Sons Hospital International, Kebbi State, Zuru, Kebbi. BP 60/30. Blood pressure, pulse steady. BP 60/30. SpO2 95%. What are you doing? Call Dr. Eseko. Zuru is too far. You know already. There's nothing. So you're on your own. Doctor has gone on leave. His phone is off. Now you there. what will be your initial steps? Cardiovet, adenosine, ABCs, consult cardiology. Some people want to cardiovet. Quickly. Oh yeah, give me an answer now. ABC is not cardiovet. You cannot cardiovet if you are not seeing ECG. Are you a witch? I know you are a prophet, but not be like this. All right. So, ABC is right. ECG for the patient shows. What do you do, Joanne?
So you shock. No, the patient has a pulse. You can't shock. Because
See, what rhythm is this?
this is ventricular tachycardia.
So what will be your initial management? Yes, ma. Aha, today is your day. So what will you do? Huh? Speak up now. She said, I'm your Daron. Do we agree? What do we think? Huh? Some people are just saying, cardioversion, Abi. Why are we cardioverting and we are not giving drug? Number one, there is pulse, so we cannot defibrillate. Number two, the person is unstable. We said stable, you can give drugs. Unstable, cardiovert. Perfect. Some people are with me. What dose of cardioversion? Are you sure? Oh, great. Now you have killed the patient finally. So, you are starting cardioversion. Unfortunately, patient now doesn't have a pulse. Sir, what will you do next? Defibrillation, he said. Are you sure? Call a friend. Final answer. Final answer, defibrillation. So he has moved from a pulse ventricular tachycardia to a pulseless ventricular tachycardia. In this case, defibrillation. And you start CPR. You don't just defibrillate and also they are bringing defibrillator. What are you doing? He said, they are bringing defibrillator. I'm waiting. Thunder fire you there. Start. All right. Initiate CPR. Now the time to defibrillation is very important. This is why you need a manual one in this case. It's not that one you put and you start analyzing and you waiting. No. You put it straight, bam. You shock and the person now goes. Okay, fine. No pulse. Blood pressure is 40/20. SpO2 query. Which of the following medications should be used for pulseless VT? Try. Make sure you are talking. Make sure you are talking. Better to fail than not to try. Sure. 1, 2, 3, or 4. This one is like APC and PDP. Some people are just saying anything that other people are saying.
4.
She said what? 4. She said 4. Atropine. Which one do we use atropine for? What do we use atropine for? Bradycardia. Not in this case, okay? The person is having pulseless ventricular. That means the heart is already very fast. So we want to give anything that speeds up the heart. That's not our plan. So what do you want to give? 1, 2, 3, 4, 5, 3. Is it those that differs? Yes, you are correct. Those that differs. Those that differs. We typically give for VCF, we typically will give a higher dose. You have given free, you typically give 300 milligrams of amiodarone. You need to be writing this because there's some teaching inside here. Okay, you need to be writing in this. If the stable VT, that is, remember the first one when I asked her, and we're asking whether it was drug, assuming the person was stable, and it was that VT, and you're not cardioverting, and you are giving the drug, you will have given 150. Once the person is In cardiac arrest, you are giving 300. But if they're not in cardiac arrest, you can give 150. Okay? Very important. I hope you are writing. Hope you are right, because you need to read it again this evening so that it can enter your spirit. This thing needs to be on spinal level. Even me, sometimes it goes down. You need to refresh. Case 2, mega code. Mowing the lawn, and then he collapsed. What's the rhythm? Yes, who can I meet? Yes, sir.
Ventricular fibrillation.
Great. VF, rapid irregular, jaga abi. So CPR, what do you do? Start CPR immediately, abi. And then what do you do next? Defibrillate. We've already called it ventricular fibrillation. So defibrillation, you can see how it just follows. Defibrillation, which is a shock. All right. So CPR, defibrillate. After the second shock, you should, or second or third shock, you should give what drug? Albuterol. And if you don't remember that, you can try what? Lidocaine. Oh, you guys are fantastic. Case 3, NSTEMI. What's the rhythm? What? Ma?
Tachycardia.
Awesome. Let's clap for her. So what will you do? Yes, what will you do, physiotherapist? We have included you now.
Is there pulse? Is it pulse?
See, there's pulse.
Cardiovascular.
If there is pulse, NSTEMI, what will the person have? Will they have chest pain or not? We have chest pain. If there's chest pain, is that stable or unstable? Unstable. So you want to cardiovascular? Great. So rapid regular, and then different types of it. Okay, now case 4. Who wants to try? Remember, 10 seconds. 72-year-old, alter sensorium, blood pressure 84/58, heart rate 44, respiratory rate 18, SpO2 90. Sir, you want to try? 10, 9, 8, 7, 6, 5, 4, 3, 2. Am I increasing your attention? 1. That's the whole idea. Obituary has come out. Want to try?
So there's prolongation of the PR interval and then a drop bit. Is a second degree Mobitz type 2 hard lock.
Awesome. We did not teach this one. I know. We did not teach this one. But that person, try. Let's clap for her. It's in the slides, you read it, and it's on your ECG sheet. You have that ECG sheet in your book. Inside the book and on your sheet is there. So look at it and read that. So second degree Mobitz type 1 actually. All right. So what's the next step in management? His sensorium is altered. If you have altered sensorium, is that stable or unstable? Unstable. Great. So what do? BiPAP, intubate, CPAP, oxygen via nasal cannula. Abraham. Oh yeah, now. You want to intubate straight away, Omo. This guy don't suffer. Oh. Yes?
I think number 1, we should put oxygen first.
I'll put oxygen, Abi. See, it just, the guy is not yet gone, Abi. I mean, oxygen. So, now, the wife confirms it's not any drug that is causing the slow heart rate. You put IV access. What drug can be given as initial therapy? What drug can be given as initial therapy? Fine guy. See, fine guy, fine glasses. You must try now. Come on. Anyone, choose at random. 1, 2, 3, or 4. Close your eyes and pick one. What can we do? 5 minutes of bolus of adrenaline, of atropine, no adrenaline, 0.5 of adrenaline, 0.5 of no adrenaline. 2, you want to give no adrenaline. When we say it was slow, what did we say we would like to give first? Atropine. So automatically, you have already removed 2 and 4. So it's either 5 milligrams or 0.5 milligrams. So how does the tropine normally come? 0.5, 0.6, Abi? So that will be the correct answer. Abi? Great. Can we clap for ourselves? You see, you just have to try. The day it will happen, I will not be there. It will be you and the patient. So try now. If you fail now, you will never fail it at that time. Okay? Great. You gave. The heart rate did not change. So, oh boy, it did not work. Oh. So what can you do? What can you do?
You said why others intervention? What does frequency can atrophy be? 0.5 mg IV every 3 to 5 minutes.
1 milligram IV every 3 to 5 minutes. Total dose of 3 milligrams. But of course, 0.5 milligrams can also work every 3 to 5 minutes. But total dose of 3 milligrams. All right. Second dose of atropine was given. Heart rate goes to 58, but comes back to 41. So boy, you tried, but it's back to square one. Doctor, your medicine know they work. All right, who wants to try here? Anybody? Fine lady.
I think synchronized cardioversion.
Cardioversion. Why do you want to give a shock? It's not jaga jaga. It's not fast. Remember that it's only when it's very fast we want to give a shock to bring it back down. Right? Very slow. It's very slow. We've given atropine. It did not work. We start atropine and atropine does not work. What can we do? What do we say we should do next? What do we say? Pacing. We need to put the pads there, turn our device, and start transcutaneous pacing. And we say if you don't have transcutaneous pacing, you can do what? What do we say? If you don't have transcutaneous pacing, you can do what? Who remembers? What do we say? What drug can we give? No transcutaneous pacing. If I were you, that's the one I would have listened to well, because if you don't have transcutaneous pacing in your place, you should know what to do now. So, if you transcutaneous pacing is not available, what will you do? What? Speak up now. He said epinephrine infusion. Are you sure? Final answer, correct. So adrenaline, 2 to 10 micrograms per minute. So if you don't have that, you can put this one up, and then you can start transferring. You can start calling for help. Patient must not die. Now, what if it's a minister or a governor? Is this the time you will start asking this kind of question? Fail now, oh. Before they demolish your clinic. All right. Adrenaline started. Mild improvement in vital signs. He remains symptomatic. He's still drowsy. What is the next best step? You have called cardio care now. 10, 9, 8, 7. That's not at all. Guess now. Cardiac catheterization. What would that do? That would just measure the pressures in the heart. You are continuing transcutaneous pacing, and then, no, you've not even started, you only gave infusion now. Remember there was no pacing now. So we gave you infusion now. So we need to plan for this full pacemaker. That one they are passing around. Did you see it? We will start preparing and prepping the pacemaker. Has it gotten to you? See it there. It's coming, it's coming, it's coming. That's an Abbott device. You are getting free publicity. So that when you send your patients, we will try and put Abbott for them. So he will bring it to you. All right, case 5. Diaphoresis, mid-sternal chest pain, arm and jaw. What is the best diagnostic or therapeutic first steps? Yes, anybody? Dr. Guma. Yes, which one? Before they cannot call for code for this one, no PA code. Oh. And you cannot deny their PA code. What do we think is likely wrong here? MIRB, but we don't yet have an ECG. So, 12-lead ECG immediately, IV, oxygen. Well, test will you do next that Dr. Abdel taught us? Troponin immediately. Don't for the HMO. Do the troponin immediately. Is there troponin on NHIS list? I don't think so. It's not covered. God help us. All right. And then once you have confirmed it, screen. This is the ECG. What is here? Are you running away? Speak up, speak up. Try. Try. Only those that, the children that refuse to try and walk will never walk. Oh, it's the ones that try and fall down that walk fast. Abi mummies. All right, try. What can you see? Hello, ma. Fine lady. Yeah, I told you don't look away. Just keep on looking towards me. The more you're looking away, the more I'm coming to you. Yeah. Try that. What can you see? What's the reading? Is it regular or not? Is it regular? The RR interval, are they regular?
Yes.
Huh? Speak up now. I know you're not quiet. Is there any ST depression or elevation here? Is there any ST elevation or depression here?
Depression.
Eh?
Depression.
Depression, where? Yes, where did you see depression?
I'm not sure.
Where did you see depression?
I wasn't following it, but I'm not following it.
Can we see that? Can you see that? What leads? Lead 3, where else are you looking for? If you see in lead 3, where else are you looking for? Lead 2 and AVF. That's depression. Is there elevation here? Remember what he said, that the depression is a reflection. The main place, can we see the elevation there? In V1, V2, V3 at least, almost V3. Okay, so what do we think is happening? 1, 2, 3, or 4? Okay, so 4. Acute MI, give aspirin, give clopidogrel, contact for your PCI center, emergency angio and intervention. Must be ready immediately. And then, if you have thrombolysis you want to give, how long did he say if you cannot get to a center within 2 hours, what must you do? What must you do? He even used the example of his village. If you cannot get there, what's the time frame? 2 hours. If you cannot get there in 2 hours, give lytic agent. You can do it. Okay? Give it. Now we talk. Okay? And if you don't know what to do, put it on the phone and then you can exchange. Send the ECG via WhatsApp. This is what you got. This is what you think. Somebody will help you. Please join our intervention group. That way we'll be able to tell you what to do. Now, if they can get to where they are going within 2 hours, get there as fast as possible. But very importantly, thrombolysis is preferably done in less than 24 hours from the start of the chest pain. If it's more than 24 hours, don't give. If you're not sure of the diagnosis, don't give. Hello? The chest pain started this morning. The person comes to your clinic now, and you know you cannot get from Niger State or from Kaduna to Abuja in that time. You need to give the lytic therapy. But the chest pain started 2 weeks ago. You still saw this one. Don't give any lytic therapy, please. It's too late. 24 hours max. All right? All right? Mr. Emmanuel, let's start. What should be done urgently? We've done this one, Abby. Inferior MI. Abby got the diagnosis. Okay, sorry. On the next check, after that patient, we now came palpable pulse, hypotensive, unresponsive, and hypoxic. Please just sit down at your table. The team is coming according to the way you wrote with your certificate. Don't worry, you don't have to pass today's test. We will give you. Some people are afraid. All right. What are the next steps? Yes, what do we think is happening here? There is pulse. Is the person stable or unstable? Unstable. So, what is the next step? What is the next appropriate step? Huh? Correct. Because there's a pulse. Defibrillating anybody with a pulse is life-threatening. Always check. Cardioversion, 50 to what? 100 joules, Abi? What must you do before you cardiovert? Synchronize. Look for that button. It's there. Some of you are working in very fancy hospitals. I know he has a very fantastic hospital. Abi, you guys have one beautiful hospital. It's there. They're not using it. Now you're going to use it. Look for that button. It's there. Press it. Synchronize. You will see the thing just go boom like magic. And if you're not sure, put me on video call if you have my number. Okay? And if I'm awake. Then you defibrillate, you cardiovert. Okay? Please, very, very important. After cardiovecting and intubating, this is what you saw next. What will you do? What will you do? Yes, fine lady. What is the reading first? VFib, Abi, correct. So what do you do with VFib? Yeah, fibrillation, so defibrillation. Abi, defibrillate. Very fantastic. And then you continue CPR. Don't forget. Don't forget to continue CPR. Okay, what can we see here? This is a real life ECG. Somebody say, ah. The more you know, the more you will see. So I assure you, within the next 6 months, you will start seeing things you did not notice before. Are you like, hi, what was I doing before? Before I came for ACS. Thank you, Cardiocare. You know, you guys are too much. If you want the t-shirts, I think they have some at the back for sale or whatever. And if they are not available, they can make one for you. What can we see? So they are coming with your certificates now to your table so that we don't have a rush. Somebody said what? I'll ask you so many questions. VTAC, Abi? Great. Great. So, summary. Preparation, BLS and CPR. What are we assessing? A, B, C, D and what? 5 H's and what? 5 T's. Crisis resource management. Crisis resource management entails 4 T's. What are the 4 things? Leadership, communication, preparation, and team dynamics. Team dynamics. Number 5, reading identification, which we did. Airway management, we did not go too much into it. Post-cardiac arrest care. We're supposed to do it, but we don't have enough time, so we have to cancel it. And then specialized interventions like pacemaker and the like. All right. Any questions? Any questions? So they are giving out your certificates now. I want to thank all of you for coming, for your different establishments. Thank you so much. It's been a fantastic 2 days. It has been a fantastic 2 days. I'm sure you enjoyed yourself. We are better for it. They are still passing around the pacemaker by Abbott. They are also sponsors of the event. So even if the patient what happened to the lights? Are they trying to drive us out? Even if the patient has a pacemaker from somewhere, if you send them to the facility, we can interrogate it and find out the state and reprogram it. Okay? So your certificates are coming to you. Please check that everything is correct. If there's any problem with your certificate, please don't shout at anybody, please. This work is hard enough, all right? And I'm sure you know you did not pay quite enough to cover this thing. The payment was just to make sure that you're paying attention. It's not that it's going to cover what we are doing. Even the food alone, I'm sure, Abi. So that's the reason for the payment. So please, if there's a problem, no problem. We'll just take it down, and then before Monday, we'll get back to you if we cannot rectify it immediately. So while we are doing all of that, I'll just show you some cases, devices in heart failure. I think I've showed you some of them. I've showed you this case now. Okay, so I will show you some cases. This is a special type of pacemaker. Hello? So while they are giving you a certificate, I want to just show you a few things. This is called a left bundle branch area kind of pacing. It's a special type of pacemaker. It helps the pacemaker to be inserted and behave as if it is normal. It deceives the body as if it's a normal thing, not like the abnormal one. And by God's grace, Cardiocare has been the first to do this kind of pacemaker in West Africa. Thanks be to God. We presented the papers in different places. Okay, so Nigeria is the first country to do that, and that was in Cardiocare in March 2024. All right, so the difference between this pacemaker and other pacemakers is that it mimics the normal conduction system. Unlike the other ones that you're just connecting, imagine you're connecting an electrical wire to this building and you just put it inside the floor. You will have electricity, but it will not be very nice. In this one, we connect it to the wire coming to the building. So it now gives you in an organized fashion. So that's the difference between that. So let me show you some cases. Doctor, I have ulcer. All of us must know that anybody that has ulcer must have what? Must have an ECG. Please and please, you came for ACS. You will not make that mistake. 58-year-old male, I have ulcer, phenomenon. And we can see the 100% blockage. This is the right coronary artery. It should have formed like a C. Okay, that's the right coronary artery. It should have formed like a C. Can we see that wire there? Can we see that wire? That's the wire going through across the blockage like Dr. Adefila was explaining. Then we can put our blom. This one, we did it through the wrist. Without, while we were gisting with the man. Then we open the vessel. Can we see the blood flow now? And then we put a stent in. Okay? In this case, I had to put 2 stents in to open it up. And then you will see the before and after. Very, very beautiful case. And beautiful things that can be done here in Nigeria without traveling abroad. So you can see that. Can we see that? Isn't that beautiful? Just the way God prepared it. This is a patient from you guys. This is a patient from you guys. Professor, recurrent chest pain, not evaluated, severe chest pain, developed. Travel, can we see how long it took from Sokoto to Abuja? Hello? So if it's going to take more than 2 hours, what must you do? What must you do? Thrombolize. Thrombolize, right? Okay, so ongoing chest pain. So we came in and there is 100% occlusion here. This artery should have continued like this, but it's blocked. This is called the left circumflex artery. It's 100% blocked. It blocked here, 100%. So that's what we had to do. The right is like this. So we passed our wire through, very difficult. Defibrillator abuse, somebody is holding. Okay, now then we pass our wire and then pass our stents. And then these are some special maneuvers. And eventually, the thing was blocked 100% here, and now we have good blood flow. This is a very tricky case because the man also had a stroke. You can give that aspirin to open that one and you can burst and the heparin you give here can cause hemorrhagic stroke. So very, very tricky case. It was extremely difficult. What can we see in this ECG? What can we see in this ECG? This is just Jara. What can we see in this ECG? Anybody? Anybody? What can you see? Yes, talk. You can see it, eh? ST what? Elevation where? Is this elevated? V2, V3, V4, V5, V6. And some depression there, Abi. So, MI. Okay, this Cardiocare, in case you have not been there before, and sometimes we use the femoral, sometimes I use the wrist. Okay, now I like to use the wrist a little bit more. Okay, can we see the 100% occlusion? Can we see before? And can we see after? So blood supply. That whole heart, part of the heart was not getting any blood supply before. And that will be worsening the patient's condition. And sometimes vessels outside the heart. Can we see this blockage here? This is the anterior tibial artery. That is a stent being opened up there. This is the leg before and after. So we can now see this coming up. I know you are getting your certificates. Everybody's happy. Everybody's happy. And we are doing fantastic work. All right. Who talked about PE? We should have used this slide though. Should have explained. I forgot to show you this slide. Can we see the clots there in PE? Where is that dialysis nurse? This is what we do for PE. We take our catheter into the pulmonary artery. we can see the clot, and this is after the procedure. There is now blood flow in that place. The person will stop using oxygen. The person's blood pressure will come back up after this procedure. Very fantastic for the people that deserve it. All right. Thank you very much. We are very grateful again. Please take pictures, tag us, and invite your friends for next year. First week or second week of December, the 10th anniversary of Abuja Cardiovascular Symposium is going to be large. It's going to be big. The people that are clapping are people that will not have jackpot. The people that will have jackpot are not bothered. The WhatsApp is full. Mr. Ima, please open the second WhatsApp group. Give them links to the second WhatsApp group so that they can ask their questions, they can have follow-up. For the nurses, your CME points, I think there's a different way they are arranging it. Nurses, your CME points, the one that your director promised, is at the back. Nurses at the back, when you are going, your CME points are at the back. Can we have a closing prayer while we close? Hello, sir. Can you pray for us? Can you pray for us? Don't worry. Do that one.
Now, can we close?
He reminded me about the society. We will send to your mails the way to join the society. The Primary Cardiovascular Care Society of Nigeria, where we will certify you as a cardiovascular care at primary care, so that every one of us can be part of a society that we can belong. So when we come for 10th one, you will bring some of your cases and present. It will not be only cardio care presenting. All right? So that will be fantastic. So let's have our closing prayer.
Shall we rise and pray? In the mighty name of Jesus, our God and our Father, we thank you, especially for the blessings of today, for the knowledge we have gained for these past 2 days. May you help us to transform it into the society, to continue to save lives in Jesus' name. Give us special knowledge and wisdom and understanding that whatever we have studied in this special conference shall remain with us to be applied for the benefit of mankind in Jesus' name. As we depart, go with us. Guide us safely to our homes. And by the time the next Abuja Cardiovascular Symposium is announced, let us be alive and well to participate in Jesus' mighty name. Amen.
Thank you all. God bless you. Have a lovely weekend and Happy New Year.
Okay, quick announcement. If for any reason it been given to you, feel free to reach out and gain more information at the front desk outside. Also, please don't forget to take pictures and put hashtag ACS 2025. And finally, we'd like to give a big shout out to all our sponsors. Those at the back with their booths, feel free to check them out before you leave and check out. It was nice meeting and having every one of you guys. Shout out to Medtronics, Edge Plus, Genos, Dorleys, Novartis, JNCI, Wema Bank, Getz Pharmaceutical, Basic Pharma, New
Emmanuel,
Heights.
please, the second WhatsApp group so that people can join. Emmanuel, please, can we have the second WhatsApp group? Mr. Enokela, please put the QR code for the second WhatsApp group so they can join, please, right now. Quickly. Mr. Enokela, Mr. Emmanuel, I need you here in the front right away. Well done.
And remember, nurses, for your CME points, promise, please see them at the back in the front desk.